Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hello everyone, and welcome to the 2024 Moyad Scholz Mid-Year Update. We have an action-packed event lined up for you, and we're going to have some incredible speakers. But before we get to that, here is a short invocation.
Thank you, Lord, that one day does not go by without your oversight or understanding. Thank you that you are faithful to your own word. Thank you, God, that same word declares you as the healer and the great physician. We come to you thanking you for the other physicians you've raised up for men and women. And we ask you that your wisdom and your insight and your plans for our health and healing would be revealed in this critical conference this very weekend. Bless this time, dear God. Amen.
Just a few things before we start. If you aren't already subscribed to our YouTube channel yet, please click that subscribe button. When you do this, it tells YouTube that these videos are helpful for you, and they'll push our videos out to other people who are looking for answers when it comes to prostate cancer. Now, I wanted to let you know that this video and broadcast will stay on our YouTube channel for you to go ahead and reference in the future. So if you can't stay for the whole broadcast or you want to remember something a speaker said, you can go ahead and come back to our YouTube channel and see it for free. Now, I'd also like to take a moment to thank our sponsors. Because of them, we were able to make this free. So I would like to thank Bayer, Janssen, Pfizer, and Dendreon. Because of their generosity, we are able to present this to you. Now, if you would like to support our cause and support what PCRI does here with all of our videos, you can go ahead and do that at pcri.org/donate. Now, another important thing I want you guys to check out is our conference page. We have an exhibit hall, we have information about our speakers and how to get in touch with them, their biographies, and so much information. Everything from information about prostate cancer to even financial plans and different things that can help cover those drugs that you may be taking. And so it's a really great opportunity to learn more about the resources we have available. And you can go ahead and do that at pcri.org/2024-mid-year-update. And I'll go ahead and link that in the description below. Next, we have Dr. Mark Moyad, who will give us an intro to our conference. He is the Jenkins Poe Kempner Director of Complementary and Alternative Medicine Education at the University of Michigan Medical Center Department of Urology. Now, Dr. Moyad has moderated over 25 of these PCRI conferences, and he's been a longtime friend to Dr. Scholz, myself, and the PCRI. But more than that, he has helped thousands of patients learn about their disease by breaking down complex concepts and putting everything in context for us. From helping find world-class experts to advising PCRI on our education and helping us stay up to date. We would not be the same without him. So without further ado, here is Dr. Mark Moyad.
Hey everyone, it is Dr. Mark Moyad. Here I am. I'm excited. We got this spring Moyad Scholz conference. Remember, it's Moyad Scholz, not Scholz Moyad. My name comes first, and that makes me happy. But in all seriousness, maybe my favorite spring conference we've ever done. It's just loaded. It's just so much information, whether it's talking with Dr. Raman about imaging, Dr. Helfand about a certain type of genetics called Germline genetics, Dr. Kwon getting some Q&A, because people don't get to see the Kwon that I get to see, which is a lot of just back and forth Q&A. Just take some of his slides away. Just let him talk off the cuff. Man, oh man, Alex and the team and Peter and just the entire PCRI team. Hi, Ethan. Anyway, it's just done a magnificent job. I am truly excited about this. And what makes me maybe the happiest is not only getting out this good information, but I'm get to wear my Michigan National Championship hat as well as my Michigan National Championship shirt. And I get to wear it for an entire year because we are the football national champions. Look, it doesn't matter that much who is the national champions until Michigan wins it. And now I can wear this at every conference event, including the men's health event and also the event where I'll see you at in the fall. So I hope you love the spring conference. The team put together an amazing group of people, an amazing group of questions, an amazing amount of educational information. See you soon. Enjoy.
Thank you, Dr. Moyad. Before we get to Dr. Raman, I just wanted to remind everybody to visit our exhibit hall. Those conference pages are built to help you. There's lots of helpful resources. There's our exhibit hall. There's information on our speakers and so much more. So go ahead and check it out. Now, our first speaker is Dr. Stephen Raman, and he is the Director of Prostate MR Imaging and Interventions and the UCLA Prostate MR Imaging Research Group. And today he will be presenting the latest updates in prostate imaging. Right after his talk, we have the Q&A session with Dr. Mark Moyad, where they're going to go in depth with your questions. So without further ado, here's Dr. Raman.
Okay, thank you, Alex. I'm Steve Raman from UCLA. I'm a professor of radiology and also in the departments of urology and surgery. I'm director of prostate MR imaging and integrated diagnostics program here. And I'd like to talk to you about how MRI and PET scans have revolutionized diagnosis of prostate cancer in 2024. No relevant disclosures. So we're going to talk about prostate cancer, limitations of current techniques, including the PSA, DRE, and in the transrectal ultrasound or TRUS biopsy. We're talking about sharks and minnows because that's a theme that's going to recur throughout the talk. And then we're going to talk about MR imaging techniques for diagnosing and staging and really talking about prostate cancer in its entirety and understanding how MRI has become critical for prostate cancer biopsies and other sampling of prostate cancer, and how MRI improves all aspects of prostate cancer treatment, how other things like artificial intelligence improve prostate cancer diagnosis, and how MRI and PET scans predict worse prostate cancer biology, all the bad genes and bad proteins and everything else that is tied up with prostate cancer. As you know, prostate cancer in 2024 has around 300,000 new cases with 35,000 deaths. That's in the United States per the American Cancer Society. 15% of men will be diagnosed with prostate cancer in their lifetime. Now, prostate cancer is a matter of minnows and sharks. So 14% of all men diagnosed with prostate cancer will progress to metastases. And this is what we want to diagnose. Who are these people who are going to go on and have bad prostate cancer? Half of men will have low-risk prostate cancer without progression. Who are those people? Those are the minnows. Well, how are we going to diagnose those and not do anything to impact their quality of life? The problem is that most men to date were overtreated with lots of side effects, which are really terrible. So we don't really want to do that. Prostate cancer in reality is a range of diseases. We need to pick out the minnows and sharks. We have lots of existing ways to do that, and they're all pretty good, but they're not necessarily good enough to do this as they were. They include prostate-specific antigen, digital rectal exam, systematic transrectal biopsy. They were significant advances for their time, but I think in 2024, we can do better than this. The prostate-specific antigen was introduced in 1987, and these are some of the old papers from that time, the original paper, and you know, it has really pretty much revolutionized how prostate cancer is thought of. The test picks out about 80% of prostate cancer, but when it's elevated, only 36% of men will have prostate cancer. So just because you have an elevated PSA doesn't mean a lot. Most of these men will not have prostate cancer, but it creates lots of anxiety. There's a number, PSA greater than 4. You'll hear that number. 15% of men with prostate cancer have a PSA less than 4, and 70% of men with a PSA greater than 4 will never develop prostate cancer. So that's with PSA. It's a good test, but it creates a lot of anxiety and it creates lots of false alarms. There's other ways to look at the PSA, and we won't talk about that here, but the density and the velocity and the free PSA. The density is important for MRI because the more dense the number is, and if the number is 0.015, if the density is higher than that, there's a higher chance that something will be seen on an MRI, and it may be more relevant. The good thing is, with those existing techniques, the rates of prostate cancer deaths were decreased quite a bit between 1992 and around 2010. So that was a dramatic decrease in prostate cancer deaths. So that's good. But more than 1 or 2 to 2 million men have undergone surgery, radiation, or both, somewhere in the neighborhood of 1 to 2 million men who probably didn't need it. And this is the sharks and minnows. How can we not treat every cancer like a shark? We want to pick out the sharks and and from the minnows. So we just really want to minimize that problem. This came to attention even 20 years ago in this trial from Scandinavia, where they showed that whether you observed prostate cancer or you did radical prostatectomy, the probability of any problem was very, very much similar. The difference was that men who underwent radical prostatectomy had a lot of side effects. So it showed that, for the most part, prostate cancer is a diagnosis that can be watched, but we got to pick out the sharks. This was also seen in the PIVOT trial 10 years later, where death was similar between radical prostatectomy and observation. So men who underwent active surveillance and men who underwent radical prostatectomy, the risk was slightly reduced with radical prostatectomy, but those patients had a lot more side effects. Again, picking up the sharks from the minnows. The minnows can be watched. The sharks probably need some treatment, and that's who we want to pick out and go for. Again, the most recent version of this is the PROTECT trial, and that also showed pretty equivalent survival over 15 years and also metastasis-free survival. In other words, the people who underwent prostatectomy or radiotherapy had slightly better metastasis-free survival over 15 years, but not by much. So the majority of them were minnows, but the sharks, if they were treated, did better. So we got to pick out the sharks. And these three major trials have shown us that. So a diagnosis of prostate cancer doesn't automatically mean a terrible outcome. In fact, for the most part, it's a pretty good outcome. We just got to pick out the bad actors and find ways to do that. So that's our minnows and sharks. We want to pick out the sharks from all the minnows around it. Shark from minnow. The digital rectal exam, that's a tried and true method. It picks out about half of prostate cancer. When you find a nodule, about 6 in 10 times, that's a real finding, and that may be prostate cancer. But the other 4 times, it's not. So just because you have a finding, only about 1 in 5 times will it be actual prostate cancer. And if it's negative, doesn't mean you don't have prostate cancer. So it's an okay test, not a great test. And the biggest problem with it is, you have maybe Dr. Moyad or someone else doing it, and you could get every single prostate cancer, and someone else like me doing it, and you may not get any prostate cancer. So that brings us to the other thing that was actually quite revolutionary for its day, which is a transrectal ultrasound-guided biopsy. That's another mainstay of prostate cancer diagnosis. This is the gold standard for many, many years, since 1986 or the mid-'80s. And its rate of diagnosis for a first biopsy, depending on who did it, was anywhere from 40 to 70%. But it's a little strange because it's one of the only cancers that doesn't have an imaging diagnosis. You take these samples from the prostate, from both sides of the prostate, 6 to 12 samples, maybe more. And, you hit the cancer, you may not hit the cancer. But the bottom line is about half of men will have a true risk assessment of the cancer risk. So it's not great. It's better than what there was, but it's not great. It has a lot of room for improvement. The other thing is, first time, it was about 40% for diagnosis of prostate cancer, 40 to 70%. If that came back negative and the PSA kept going up, they did another biopsy, and that was only 20% successful. And then it went up again, and it had a third biopsy, and that was only 8% successful for finding prostate cancer. So it was really finding, where is the cancer? That's the other problem. It's sharks and minnows, but where are the sharks and where are the minnows? And also, it's a problem of who does it, how good they are at doing it, and where they do it. So in the prostate, you have different areas, the apex, the mid-gland, and the base. And the localization matters because the biopsies are better at the base and not as good at the apex, and that's a recognized problem. So there's all these issues with it that need to be better. So this is what a transrectal ultrasound biopsy looks like. This is the probe in the rectum, and this is when this white line is when you shoot the biopsy into the prostate, which is this kind of gray blob. You don't really see a tumor most of the time. You're just kind of shooting, and you're shooting into the different areas. You can get 6, 12, or more biopsies. Sometimes you can see the tumor. If you're good at it, you'll see the tumors. Sometimes they're bright, sometimes they're dark, but most of the time you don't see anything. So really, it's the idea of sharks and minnows, finding the shark from all these minnows, and the question is, do you even need all these biopsies? You want to find the shark and really avoid all these minnows, because that's what we want to do. The one shark or three sharks in this case from all this kind of background that we don't really need to know. And one way we do this is take lots of biopsy samples. But what if we could just go to the cancer? That's what we really want to do. And that's what we want to do, because that's what gives us the true answer about what your individual risk of a prostate cancer is. Some people have done this. This is a saturation biopsy, and this looks kind of horrible. 128 biopsies with these grids to get every little part of the prostate. Well, that's one way to do it, but that seems like it's kind of a brute force method. So the reason biopsies are not liked is because they can cause pain in a lot of cases. They can have bleeding into the urinary tract, in the stool, and in the sperm. They can have infection in the blood and infection in the urine. So there's lots of things that are not desirable about prostate biopsies, biopsies in general, and prostate biopsies. Nobody likes them. Prostate cancer is the only major solid organ malignancy that's not routinely imaged. So these are, from all the old guidelines, did not routinely image prostate cancer. It's kind of strange. It's so common, but it's not routinely imaged. Dr. Walsh, who pioneered radical prostatectomy, said the discovery that would have the greatest impact in our field would be the development of accurate imaging of the tumor within the prostate. So this was in 2008. And since then, I think we found that tool, and that's MRI. We've said, and many organizations have said, prostate cancer care is blind. And this was, from in the last 10 years. This has been a recurrent theme, that we do this because we didn't have a good way to figure out where the cancers were. What we want to find is the sharks, and that's called clinically significant prostate cancer. And there's many definitions. Some of them are a tumor, but they go by tumor volume, or they go by the Gleason grade on the slide. So Gleason grade is 7 or higher, or a tumor volume of 0.5 centimeters or more, a cubic centimeters. But there's other definitions of this. Now, magnetic resonance imaging is a technique that uses strong magnets that affect the hydrogen molecules in your body, both in the water and fat molecules. And these strong magnets help us see the cancers and other things better, because the cancer molecules are affected by the magnets in a different way than are the normal tissues. So we can see normal tissues that get affected one way, and the hydrogen ions in the magnetic field that get affected in a different way. The exam can be as little as 10 minutes or as much as 30 minutes or even longer. So depending on what kind of exam you do, what they're doing, we can do it in a closed bore magnet, which most of the magnets are, or sometimes in an open bore magnet. These aren't quite as good, but for claustrophobic patients, they can, they do better with this. It's better than nothing for sure. So with MRI, you have different sequences. One is a T2, it's very important. One is a diffusion sequence, very important. These are different ways to perturb the hydrogen ions in your body. There's perfusion, where we inject dye into the body, and the cancers generally take up the dye, so we can see it. So on the T2, the cancers are dark. On diffusion, and this is the ADC map of the diffusion, they're dark. On perfusion, they're bright. Then we can also do with this, we can combine this with PET scans, have MRI PET scans, and the cancers are bright on the PET scan. We can use it for a variety of techniques to biopsy the actual cancer, biopsy the shark. And then we can also treat the shark with MR therapy. So MRI, magnetic resonance imaging, has evolved over the past 15 years and is currently considered the best imaging modality to grade, stage, and detect prostate cancer. It helps target biopsy of the most aggressive target or the sharks and helps separate the minnows from the sharks. Prostate MRI looks like this. Most of the prostate gland is bright on this T2 weighted image. There are different zones of the prostate. This is the peripheral zone here. This is the transition zone here, the central zone here, and so on. So we look at the prostate and we look at all its different components on the MRI. We know where the urethra is, where the urine comes out. It's right there. And this was done with an endorectal coil, which we don't use anymore. But this is a beautiful image of the prostate and all of its different zones. When we do all these things together, we call it multi-parametric MR of the prostate. We use a T2 weighted sequence to show us the cancer here. It's dark. Then we use a diffusion sequence where it's bright here. And then the ADC map of the diffusion sequence where it's dark. So dark, bright, dark. And then we give dye, and that's bright. And we can see how the dye in the cancer shoots up and then comes back down. And this is what we want to see, these four things, to call it confidently a prostate cancer. And we also have a way to now categorize these with a PIRAD score. I'll come to that in a second. The same thing can be done now with PSMA scans. This is an agent that binds to a protein on the prostate cancer membrane. It also does other things, but primarily for prostate cancer, it lights up as bright on most prostate cancers. So dark on T2, bright on PSMA. Dark on T2, bright on PSMA. Dark on T2 and bright on diffusion. So all these three things together help us better diagnose the sharks and the sharks here from everything else. So on the MRI, we have different looks to prostate cancers. The cancers generally are oval or lobulated. Prostatitis and other things tend to be wedge-shaped. So we can kind of tell just from the look of it, this is not probably going to be a cancer, and this is going to be the cancer. So we can tell the sharks from the minnows again there. There are other shapes we can find. The oval is bad. The teardrop shapes are generally bad. The irregular spiculateds are bad. This what we call lenticular is bad. So we can tell just from the shapes things that are bad and things that are good in the different zones. We can know from the diffusion weighted imaging that the worse the diffusion is, that is, the brighter it is and the darker it is, the worse the Gleason score is going to be on the biopsy. So this is a non-invasive way to tell where the cancer is, where the sharks are, what kind of a cancer it's probably going to be, and how dangerous a cancer it's probably going to be. So the darker it is, and the darker it is on ADC and the brighter it is on diffusion, the worse the cancer is. So it correlates directly with the Gleason score. So the lower the ADC, the worse the cancer is by Gleason score. So this is a powerful tool without a biopsy that tells us, do the biopsy here, and this is probably going to be where the sharks are. So based on this, we, more than 15 years ago, printed this paper, and this paper showed us a way to understand the prostate MRI, and we came up with a score. This was the UCLA score. And this was showing us where the cancers were in the prostate gland, and we wanted to target the most aggressive cancers or the sharks and see how that compares to all these other biopsies that didn't target anything or potentially target the minnows. So we wanted to target the sharks. And based on that, we came up with this 5-point score that then was adopted by our section at UCLA in 2010. And then in 2012, the ESUR published MRI guidelines called the PIRAD score. And that is now a standard way of communicating across the world what an MRI looks like. So we not only have a way to detect the sharks, we also have a way to communicate with other doctors about what we're finding so that we're all on the same page as much as possible. So we helped develop this scoring system that's now adopted, and now it's just a standard overall. So MRI is a great advance, and PET is even a better advance to add on to MRI. So basically, we say that we have a PIRAD score lesion of 3 to 5. It's a 5-point scale. 1 and 2, we don't consider cancers, or the chances of a cancer are very low. 3, 4, and 5 are much higher chances of cancer. So we find that, we can biopsy it, we can target it with treatment, or go to active surveillance, and then we do follow-up. So we do all these things together, and this is a much better way of understanding prostate cancer. We understand from the MRI and the PET scan the biology of the prostate cancer and find the sharks. So MR-guided biopsy. So there's many ways, many different tools under MRI guidance or fusion guidance. There are lots of different tools to basically find the shark. So here's the tumor. This person had 2 different biopsies. When they came from the rectum, they biopsied this area here and this area here. The cancer was up here. They found no cancer. The PSA kept going up. They found no cancer in the biopsy. 2 different biopsies. That's 24 different samples. Patient bled every time, had pain every time, and hated that biopsy. And we convinced him to do this biopsy 10 years ago. Found the cancer. This is a PIRADS 5, UCLA score 5. It's dark on the T2, bright on the diffusion, dark on the ADC, and enhances very avidly after we give dye. So there we go. We just target the tumor, find the sharks. And we can do that by different methods. We can do that here in this situation, in this circumstance, where we find this tumor by ultrasound guidance or ultrasound fusion guidance. Or in that same case, we came in with MRI guidance. And to me, if this is me or my brother or my dad, I would want this. This is like you put the probe right where it is, where the tumor is, find where the shark is, look at it in different projections, and put a needle right through it. Needle right through it. 1 or 2 or 3 needles, and this came back. All 5 of the samples we took were Gleason 3+4. So again, we went right to where the action was, and the patient can then make a decision about what to do. So, there are other things we can do looking at this, but we can now very confidently understand where the sharks are. So again, this is what we want to do. Find the sharks. This is a couple of other things that I did recently. I've since used MRI. This was a patient had 2 different biopsies. A former colleague of mine, 2 different biopsies, didn't really find a cancer here, even though we had this dark area here, slightly bright here. We ended up doing a PSMA scan, made it bright there too. And so because he had a problem with his rectum, he had another problem that we couldn't use transrectal guidance. We just put a probe right in his perineum, where we just below his scrotum, between the scrotum and the anus. We just put a probe in the perineum, and then used fusion to find where this thing is, where the PET scan is positive, and put a needle right through it. Boom. And this was a Gleason 3+4 as well. So you can do a lot of innovative things with new innovations. You can combine them to find the actual shark. So then we said, well, why are we doing all these other biopsies? So myself and some of my students and my lab partners looked at where are all the cancers that are positive outside of what we see that are targeted. So how many biopsies do we actually need to do? And so on the cover of this major journal, European Urology, this was last year, last year, we had this paper which showed that all of the clinically significant cancer that is on any biopsy sample, in other words, these are the biopsy samples from the sharks, but what about the other biopsies? So when we looked at this, we found that almost all of the clinically significant cancers that we could find on a biopsy were within 1 centimeter to 1.5 centimeters of the original shark target. So to me, I'm not sure why we're doing these other biopsies on the other side when almost 97 to 98% of the time there are no significant sharks on the other side. It's all where the PET and the MRI show the tumor to be. So 90% of significant core biopsies were within 2 centimeters of this target. So we've gone back and said, how do we do biopsy better? Find the shark, but do less biopsies, because if we do less biopsies, it's better for patients, less pain, less bleeding, less other problems. And so we put this together in a biopsy report that has the pathology, the MRI, the PET scan, and everything else together. This is our integrated biopsy report, and we've had this out for about 10 years. Shows all of the biology of the tumor. So MRI predicts aggressive prostate cancer. And all these papers that we wrote show that issue. So when we do these biopsies, we find the sharks, and we find that based on our UCLA score or the PIRAD score, the higher the score is, a score of 4 and 5, we're finding cancer in the majority of them, but also they're red cancers, the more aggressive shark-like cancers. They're not in the 1s and 2s. They're in the 3s, a little bit, 4s and 5s for the most part. So this is what we're going after, finding those sharks. So we've shown, carefully looking at sections after radical prostatectomy in multiple papers, that we can find the most aggressive cancers, dark here, bright here, dark here, on the T2 diffusion and ADC map. And we can find all of these different cancers, but the sharks are here, and we can find those shark-like cancers or the clinically significant cancers up to 90% of the time. So that's what all these papers are showing. We can find the sharks up to 90% of the time. Now, this is also now, these original studies that we did with the biopsy have been shown in 2 different randomized clinical trials, randomized controlled clinical trials, that this does better. In this, the PROMISE trial with 740 men, they showed that the MRI positive cancers, in the MRI positive cancers, 91% had clinically significant cancer. So that's the ones that you want to possibly act on. Whereas if you just did the old way, half of them had clinically significant cancer. And I bet if you go back and look at this data on both these 2 trials, it's the PRECISION and the PROMISE trial. If you go back and looked at where the clinically significant cancers were, they were going to be within 1 to 2 centimeters of the target, meaning you probably don't need to take all those other biopsies. But this has been a now validated concept that the MRI targets make a big difference. With PSMA scans, you do slightly better. We said before, we can find these bright areas that correspond to the MR. Sometimes we find other areas too. So what we do is we can say that with MRI alone, we detect somewhere between 80 to 90% of cancers. With PSMA alone, we detect somewhere between 80 to 90% of cancers. But with both together, we detect even more together. So they're better together with MRI and PSMA in terms of finding those sharks or the clinically significant cancers. So with this, doctors have recognized that there are lots of ways to use all these tools. Detection of the cancer, that's the most important thing. Where is the cancer when the PSA is high? Surgical planning, active surveillance, radiotherapy planning, and so many others that I haven't even listed on here. So these are all different ways to deploy these new techniques to make the diagnosis better in every single way. So we want to use potentially active surveillance for the minnows for patients in low volume, low grade disease. MRI, doesn't show those cancers all that well. So you're okay. You're saying that, well, if you don't see something on an MR, it's really unlikely you're going to have a clinically significant cancer. If you don't see something on MRI and a PSMA scan, very low likelihood, less than 10% chance, you're missing something big. So we've shown that MRI improves active surveillance. Just even if you're looking at the minnows, you're following those up, MRI improves active surveillance. And we have shown that, and other people have shown that, for example, in this situation, this was when we first started using it. This is an MRI with somebody with high PSA. There was really nothing we saw, but then the PSA kept going up. Biopsies were negative. A year later, another MRI showed some darkness here, and then some other areas, and then the same area had some abnormalities on the diffusion and perfusion, and the tumor declared itself, and the parameters are abnormal, and the targeted biopsy here showed Gleason 3+4 cancer. So MRI improves active surveillance, and this has been shown in multiple papers, but in this paper, for example, you looked at just the MRI alone compared to some criteria that are used commonly, Epstein, D'Amico, and Capra, and it shows that the MRI alone cohort was closest to what they found on pathology. All these other ones had more errors in what they showed, but the MRI alone still had some problems, but not as many problems as some of these other ones. We've shown that, again, it's good for active surveillance. It's good for surgery. If you're planning to have surgery, you should have an MRI, because MRI, even 10 years ago, changed the surgical plan in 27% of patients and made it better. So basically, if the cancer was on one side, you could resect, you could do a prostatectomy and go deeper on this side, maybe even spare the nerves on this side. It's possible. But on the other side, you've left it alone and improved the function in terms of sexual function and urinary function. Take the nerves maybe on the areas that need to be treated more aggressively, but leave the other side alone. So these are different ways to do surgery, and it improves the actual surgical resection or prostatectomy. So we can also see the nerves with MRIs, and these aren't used commonly clinically, but we published a long time ago that using these MRI techniques, we can see the nerves really nicely when we need to. But we're still trying to find a way to put this into clinical practice. So MRI has improved the outcomes after prostatectomy. So in this paper, for example, if you saw a tumor beforehand, before radical prostatectomy, there's a higher chance that afterwards, if you don't do a proper radical prostatectomy, that you have a higher risk of biochemical recurrence. So the PSA starts rising after radical prostatectomy. So when you have a big tumor on MRI prior to radical prostatectomy, you have a higher chance that it might come back. So that's important to know and counsel patients. When we do a radical prostatectomy, we slice up every single one of those in this whole mount section. This is 3D printed from the patient's MRI, and they're sliced. And so we examine every single one of these slices. We have over 1,000 of these that we explore because we want to be that good at MRI. And we can say that when we see something dark and bright, so dark on T2, bright on diffusion-weighted imaging, bright on diffusion-weighted imaging, dark on the ADC, and bright on the dynamic contrast imaging after dye, that we can see a big tumor here. And we want to correlate the size of this tumor, the shape of this tumor, and other metrics with the T2-weighted MRI. We want to be very careful about how we're doing this because it affects everybody's life. It affects their sexual function, their relationships, and their urinary function. So it's very important that we get this right. MRI improves radiation planning in PET scans. PET scans as well improve radiation planning. So MRI can detect the cancers. PET scans can detect the cancers. MRI can show us the extent of cancers, and the PET scans can show us not just the cancers, but where the lymph nodes are. So that's very important before understanding what to do with prostate cancer. So again, this is high-risk disease. These are the sharks. This is a big tumor that's invaded outside of the prostate gland into the seminal vesicle and into the pelvic sidewall. So this is very important to understand how this cancer looks, where it is, and how to treat it. So this is where to sample it, where to treat it, where to know where it is. So MRI and PET scans help us really understand this. So we've shown that MRI improves radiation therapy because when you see a cancer, we can boost the areas of MRI visible cancer with radiation. So we can show that it does a better job when we call different kinds of cancers. All right. We can use all this data for artificial intelligence. And, that's a concept, artificial intelligence, that's in vogue. Everybody's talking about it, and we've been doing it. There's different ways to do it. There's deep learning, machine learning, and other ways of doing artificial intelligence. But the bottom line is, with all this data that we have, we've shown that it helps doctors improve. So basically, when we use artificial intelligence techniques, it helps us detect the tumors better. And this is the actual machine doing it. And it's as good as somebody who's an expert, and in some cases. So that's good. So that means that it'll help the community get better at interpreting MRIs. One of the problems with all this advanced imaging, MRIs and PET scans and everything, is that not everybody's as good. Some people are good at certain centers, but we want to diffuse that into the community. And one way to do that is artificial intelligence, to help everybody get better and have everybody treated better. So you don't have to go, to the UCLAs or the Michigans or anywhere else. You can do it even in your local hospital. And that's the idea, if we can do that. So MRI has improved the diagnosis of prostate cancer, helps us target the prostate cancer, helps us do a better job in understanding how to do surgery, how to do radiation, helps us predict who's going to recur after surgery and radiation. But we use artificial intelligence to make us better diagnosticians. But MRI also helps us see the underlying biology. So both on the genomic side and the protein side. So not only does it correlate with the Gleason score, but it correlates with the underlying biology that the genes and the proteins tell us about. So here we looked at some commercially available genomic tests. This is Oncotype DX, and MRI helps us improve the performance of Oncotype DX beyond what it's capable of. So the higher the PIRAD score, the higher the Oncotype DX score. This is also for the Decipher test. You may have heard of the Decipher test, another set of genes that's looked at for prostate cancer. And in this paper, the mean Decipher score of MRI positive cancers was significantly higher than MRI negative cancers. So here is an MRI negative cancer. These two little MRI negative cancers, these are the minnows. The Decipher score is 0.67. And MRI improves the performance of the Decipher test. The Decipher test is a very commonly used FDA-approved test. And in this paper, the mean Decipher score of MRI positive lesions or visible lesions was significantly higher than MRI negative lesions. So here's a minnow, PIRADS 2, Gleason group 1, and a lower Decipher score. Here's a shark, PIRADS 5, Gleason group 3, and Decipher score of 0.79. So Oncotype, Decipher, when they're done on MRI visible lesions, the genomics are worse. This is also true for the 4K test. The MRI and the 4K, the MRI visible lesions are always worse on the 4K test as well. It's also true for the PCA3 test. Here, the cancers, the higher MRI lesions or MRI visible lesions show us the sharks, and the MRI visible lesions had greater Gleason 7 or greater cancers, and less no cancers, and less Gleason 6 cancers. So they show us that the sharks are visualized and that the underlying biology is worse. This is a paper from the Cedars-Sinai group that showed that the subset of genes, when they actually analyzed the genes that were associated with MRI visibility, had a poor prognosis. They were cell division genes, DNA damage, repair genes, and other genes. And those genes were worse in the MRI visible lesions. And we showed in a paper here in European Urology that a number of different genomic markers of poor biology, worse cancers, shark-like biology, were worse in the MRI visible lesions, hypoxia genes, and other genes. So one of my colleagues has called this nimbosis. That is a gathering of storm clouds. The ones that are, the minnows are monoclonal, have less hypoxia, are stable, are MRI invisible, have no bad histology on their biopsies. That's the minnows. The sharks are MRI visible, have unstable genes, are hypoxic, polyclonal, and so on. And these are bad. The minnows don't relapse, have very little metastasis risk. The sharks have much higher rates of relapse and much higher rates of metastasis. And this is what we want to see. This is what we want to see with MRI and PET scans or whatever else comes to pick out the sharks from the minnows, right? 50% of the time, we're misdiagnosing men the old way. Hopefully, this will make it much better in the future. This paper basically showed that there's so many different things that MRI helps predict. It makes commercial assays better, like we talked about. The DNA-related features are worse with MRI visible lesions. Other biological hallmarks of cancer, biological pathways, and cellular structures are all worse with MRI visibility. In those tumors that are MRI visible, the whole biology is worse. And we also showed for the first time, this is true for protein expression. In this paper, we showed it's not just the genes, but that the proteins that come from those genes are worse. And when we see that, when you have the worst proteins, you have worse outcome. Those patients do worse than the patients with the better protein profile. And again, MRI visible cancers are better. MRI visible cancers are worse. They have worse biochemical recurrence. They have more metastatic disease. They have more patients that are MRI visible have progressed to death and other things. So MRI visible lesions tell us that the biology is worse, and it helps us really understand where that is. So when you see this, when you understand this, when you're talking about prostate cancer, you really want to understand the whole gland, and you want to understand where the sharks are, because when you find the sharks, they are probably going to be worse. Not always, but probably going to be worse. This has been shown for radiation therapy. So this has been shown for radiation therapy where a high PIRAD score also means that they can recur after radiation too. It's not just surgery, it's after radiation too, that MRI visible lesions, the patients do worse than lower PIRAD scores or MRI invisible lesions. So this is the gathering of storm clouds. That's nimbosis. It means that things that are MRI visible have worse outcomes. They have worse genetic markers, worse outcomes. So this helps us really understand for any individual person how to put together your personal risk profile. You have a number of features, all the MRI features, the PET scan features, your pathology features on biopsy, all the genomic data, putting all this together, and other tests that may come, putting all this together, possibly with the use of artificial intelligence to really plan a therapeutic pathway for you that's unique to you and your situation. So this is kind of being done, but it needs to be done in a much bigger and better fashion. So in summary, I would say that MRI and PSMA PET-CT and PET-MR have dramatically improved the diagnosis of prostate cancer. Dr. Walsh told us was you need to find something that's going to make a difference in terms of imaging the prostate cancer, imaging the prostate, and that's there now. We localized the sharks, so the most aggressive disease. We help biopsy those areas. We may reduce the overall number of biopsies, and that helps men suffer less. It may improve the genomic performance of tests that are already available. We may incorporate artificial intelligence in a good way, not a bad way, to help diagnose different things, to help bring good sets of diagnostic criteria all across the world, not just at specialized centers, not just at the Michigans or the UCLAs of the world. And help patients choose more wisely what they want to do. The majority of men could probably have active surveillance, but if you're going to do treatment, you understand upfront what you're getting and what the chances of coming back are. So this is really what we want to do. And this is how we're trying to work to make this a reality. So thank you for your attention. And this is our information at UCLA if you'd want to get in touch with us, either in radiology, urology, or radiation oncology. And I'll be happy to take any questions. Thank you. And this is our group of many, many people who make this possible in the IDX program under our chair, Dr. Ensman, in radiology with my colleagues, urology, and then pathology.
Dr. Raymond, that is excellent, honestly. And you know why it's excellent? It's excellent for a couple reasons. First of all, because I think it's excellent. And second of all, I've watched a lot of videos online in preparing for this juggernaut of an interview. And I've noticed that your slides and all your other talks are not as high quality as the ones you use for PCRI. Am I right or wrong, sir?
Oh, you're absolutely right. I redid most of them.
I mean, you got a beautiful shade. You got a beautiful color there. The images look amazing. I would love to see this talk myself a second time, which I'm going to do. You kind of took your game to another level.
You know, I wanted that shade to be somewhere between a Michigan blue and the UC blue.
Oh, that's a beautiful answer. And you know what I appreciate? Because we were talking off camera. At least Michigan, Michigan won the national title and we have the greatest football team in the history of college football, right? At least you know that.
At least we know that, yes.
Yeah. Do you know what I got from PCRI right after we won the national title after 15 years of service?
What did they give you?
I got nothing. You know why? For two reasons. One is because they probably didn't know about it. And two is because I can guarantee you, Mark Scholz, who has no football knowledge, had any idea that we won the championship. So
we were out here surfing, Mark.
Thank you. I don't know. After all this talk of sharks and minnows, I'd be scared to surf out there. All right. You ready? I got a couple questions before we dive into MRI and PET CT. I want to talk about both. We got about 30 minutes. So I want to just take our time here. Now, I saw the funniest thing online after one of your talks, and usually I don't look at some of those funny comments, but it's a really good question because when I go to your bio, it says Professor of Radiology, Urology, and Surgery, and someone goes, how can he be a professor at 3 different professors at once? And I'm thinking, well, because the guy's a stud. The guy is world famous. That's why. But then I'm thinking, maybe I'll let him explain it. How were you able to get professorships in 3 departments?
I actually don't know myself, but somebody asked me if you want to be a professor, and I said, sure.
Really?
That was as simple as that. Because, I work with these people so closely, so sometimes they consider you family because, it's just you bail them out as a radiologist, you kind of bail them out as right?
There you go. See, that's impressive. But also what was impressive is I looked at what you do in your free time. And when I see that on a bio, sometimes it's BS and sometimes it's real. So one of the things you said is you like, because I'm a huge runner. I ran this morning before we decided to talk, so I'd be in my game. So it said you like to go running. Is that true?
It's true. It's true. Running, since the beginning, it's we run together as a family because I got 3 boys into running, so we all kind of run. But again, no marathons. But I have attention deficit disorder of some kind, so I can only run about 10K.
That's great. How long have you been doing that?
Since high school.
That's excellent. And then it says you like to travel, but it didn't say where.
Anywhere.
You could
anywhere.
PCRI would send you on an all-inclusive trip. One spot. Where do you pick?
Iceland.
Wow.
It's amazing.
Really?
Really amazing.
One place I have not been. I missed.
One place you should go. Iceland is just blows your mind in terms of how anybody actually settled this place. And as you know, Greenland is not green and Iceland doesn't have ice. So but it's just the landscape there. It feels like you're on Mars or somewhere else.
That's incredible. I have to give a shout out to the active surveillance and other prostate cancer patients in Iceland. They've actually become a fairly tight group. They've worked with PCRI. So Iceland. Okay. One more thing the audience does not know about Dr. Raman. And that is, again, tell me if this is true or not. It says you speak Spanish.
I grew up in California. So, again, I learned that in grade school and I've spoken Spanish to, most of 30-40% of my patients speak Spanish. I have to, necesito hablar español.
That's awesome. You share that with Dr. Scholz. He speaks Spanish. What helps me when I'm in LA is I grew up with Farsi. That was my father's side. So that helps in Los Angeles. And then my mom's from Vienna. So I don't know many people that speak German in Los Angeles, but whatever. That's great.
On the way home, there's a German American club that we always drive by.
Really?
Yeah, there's a big German connection here, sure.
Well, so I think so what it tells me, because you know about football, you go running, you like Iceland, it tells me you're not all geek, you're not all nerd, you have a life outside of your job, and that makes me happy.
Thank you. Mostly, though, I'm the former.
That's great. I want to talk about something else before we talk about MRI and prostate cancer, because I went back through all of your publications. Yes, I have no life.
How did you do that? I'm sorry you had to do that.
No, it's impressive. I almost should apologize that we haven't had you on earlier. But we got you now at the height of our audience. So you've worked in a lot of different cancers and situations. I saw some things on kidney cancer and liver cancer. Do you want to comment before we get started on prostate? Are we outside of prostate in terms of imaging, whether it's kidney, whether it's liver, whether some of the other stuff that you've been doing or have done, is there an exciting world out there? Because we only know prostate. Is there things happening imaging wise that's just as dramatic as prostate?
Yeah, you know what? One of the good things about doing something outside of an area is kind of bringing the cross-pollination.
Yeah.
If you're just in an area, you just don't really know it. I have that same problem. Like, what are they doing in brain cancer? But they're doing a lot of exciting things there that we bring into prostate. So my biggest problem is, what's the best tool out there that we can adopt into prostate? And some of this work that I've done in liver and kidney cancer has been adopted to prostate. Why aren't we thinking about prostate cancer more like a liver cancer or a kidney cancer from the imaging point of view? Because all those cancers are based on imaging. Liver cancer is entirely based on imaging. There is no biopsy. It's been eliminated.
Completely eliminated, really?
Completely eliminated. They said no biopsy, only based on what's called the LIRAD score, which is the PIRAD score is modeled after the LIRAD score.
Wow. Because you remember the day, not that long ago, the idea of getting a liver biopsy was you'd be horrified.
Right. And hopefully there'll be a day when the prostate biopsy will be that too. Maybe not.
Wow. I really didn't think about that in terms of liver biopsy and how it's really not necessary anymore.
Not necessary. It's been not necessary for 10 years because of MRI. Again, MRI has revolutionized liver cancer care for the people, who can get MRIs. That's the problem with MRIs, access.
Yeah. Yeah. And in kidney cancer, are you excited what's happening there?
Kidney cancer, again, it's another disease where we didn't have biopsy. Everything went to surgery. Now we've developed what's known as we developed a UCLA score for the liver. We developed a UCLA score for the kidney and for the prostate. And the UCLA score tells us what something is a cancer or not a cancer, and then also tells us what else it could be if it's not a cancer, or what kind of cancer it could be. So every time we see something in the kidney, we give it a score. We're not always right. Nothing's 100%, but 80 to 90% of the time we're right. And we learn from our mistakes. We try.
That's just really interesting. Do you actually think that we will get to the day in my lifetime where you're diagnosing prostate cancer without a biopsy?
I hope so. I sure hope so. What I've shown is we can predict so many things that, maybe you can eliminate biopsy. I can't make a prediction like that. I mean, that's been such an ingrained part of prostate cancer care, but we can get close because, at least we will hopefully eliminate the systematic biopsy and all the problems with that. We can at least target it to the region and do it properly. And maybe that'll be less problems overall in prostate biopsy. I mean, when you think about biopsies, doing a liver biopsy or a kidney biopsy is relatively simple. Most of the problems I hear are from prostate biopsies. People hate it. Like, just as a man, getting a prostate biopsy pretty much is like, there are probably few things you want to do less than that.
It's like a shark bite.
It's like a shark bite. Right.
By the way,
it's down there with a shark bite.
There was so much talk about sharks, and you are in the Hollywood area. I want to test your movie knowledge before we keep moving on. One of the most famous quotes of all time was, "You're going to need a bigger boat." Do you know what movie that's from? You're much younger. This is really frustrating. This is like it's like
You're gonna need
Alex
a
and
bigger
Peter. They're
boat.
just too
I
young.
can't. My memory's going, Mark. So you have to tell me. I kind of
Gonna
vaguely
need a
know that.
bigger boat was in the movie Jaws.
I should
And
have said that.
yeah,
What other shark movies? I should have said that.
it was Jaws. It was Roy Scheider.
There was Roy Schneider saying that. Yes. Okay.
Right. And
yes.
he was playing Chief Brody, and he was throwing out the chum, and out came the big shark, and he gets back and goes, "You're going to need a bigger boat."
Right.
Most famous lines. Anyway,
Of course.
I mean,
Very
we cover a
famous.
lot more than just prostate cancer here. Before we go in just to MRI, and before we spend the rest of our time on just imaging, which can spin my head, there's so much talk of imaging, it's incredible. People don't now maybe people do realize you're also a big fan of MRI guided treatments, I believe, and where we're going in terms of interventional radiology. And the reason I think it's a really cool field is it was either in one of your talks or one of your papers. I never really thought about it in terms of fibroids, for example, being treated today by interventional radiology. It's pretty dramatic, right? And then here's one that people don't realize: essential tremor is now being looked at, right? When someone has an essential, so these very diverse areas are now getting all this play in interventional radiology. And it's really messing with my head, because in a good way, someone the other day, a friend of mine said, "Well, I'm going to go get a steroid injection for carpal tunnel." And I said, "Have you ever considered an interventional radiologist delivering it in the carpal tunnel? Because landmark wise, it's difficult to deliver that compound." And he said, this person said, "I never even knew that was an option. My doctor didn't bring it up." Fast forward a couple of weeks later, an interventional radiologist does the steroid injection, and the person is extremely happy. My world is being surrounded by interventional radiology. Do you have any comments on that? Because you are immersed in that right now.
I think interventional radiology doesn't have to be done by just interventional radiologists. There aren't enough of them around. Every field can have interventional radiology. Urologists do it all the time. The key skill set is understanding the imaging well, and what I call tip management. Can you get that tip exactly where you need to be? If you can't get that tip, you don't have no business doing it. But if you can get the tip to where you want to be, your target, that's good interventional radiology, and you can do a lot of things well.
Are you excited about a certain type of MRI interventional treatment in prostate cancer?
There are many techniques that I think supplement what we can do. So, I like, for example, right now, I like the Tulsa treatment. I like the Inside Tech treatment. I like those treatments because their safety margin is high, because you are not only imaging with MRI, but then you're using the imaging during the treatment, and you're also checking the heating precisely, not only where it's heating, but also the temperatures. You can measure that all non-invasively with MRI. So I like that as a safety mechanism. So, but again, it's who you choose, and all those things don't matter. They're the same issue.
Yeah.
Does anybody need this? That's the biggest problem.
Here's a couple of thoughts. People are always asking, you just showed a picture of an open MRI versus a closed. And people ask all the time, and I'm sure they ask you, why can't they do an open MRI in prostate cancer? Why are these closed? Why? Open MRI machines advertise all over the United States. And I think if people were given the choice, I'd want to be in an open MRI versus a closed one, because claustrophobia is not a small thing here. So can you do an MRI of the prostate, or can you do any of the things you talk about with an open MRI, or is that just not happening?
A closed MRI system is like the Cadillac of MRIs. In a physics world, the way MRIs work is the power of the magnet. So the power of the magnet in a closed MRI is well above that of anything that's open. And the reason that's important is because the power of the magnet determines how much the hydrogen ion will resonate with the magnet. And the resonance power determines a lot of downstream features of can you detect normal tissues? Can you get good T2 weighted imaging, diffusion weighted imaging, perfusion weighted imaging, and all that stuff, and how fast you can get it? So you can't argue with the physics, but the open MRIs are much lower power, generally much lower power. So they perturb the hydrogen ion much less. So all of those things that the hydrogen ion does when it's perturbed less are just less apparent at lower strength. But it's way better than getting nothing. Yeah. So you're not going to be like at the top of your game, but you might be in a 2 leagues below. In a sports analogy, you're not going to be playing for the Yankees. You're going to be playing for maybe Youngstown.
I see. I thought you were going to say you're playing for the Wolverines,
I didn't want to go there quite yet.
Okay, you don't want to go there.
That's next year. That's next year.
Next year when we lose a lot of games, I got to enjoy this for a year. Okay, so I walk into an MRI center. I don't care if it's for screening, what other reason. People always talk about this 3T stuff. Does this help patient advocacy? Do you got to make sure that when you go into a center of excellence and you're talking prostate imaging, that is this something you make sure that the person has as a 3T MRI? Is there a 4T? Is there a 2T? Like what?
Yeah, there is a 7T, but we're not using it for prostate clinically.
There's a 7T?
There's a 7T, there's a 12T, but right now those magnets that are super powerful are being used for the brain and to do very, kind of functional imaging and other things in the brain. So they exist. But I think if you can get it, a 1.5 or a 3T system is what you'd want to get. If you're super claustrophobic and you can't use an anxiolytic or a medication like that, Valium or something like that, Ativan, and you can't get through it, then get an open, make a 0.5T open system. If you can get through that, it's better than getting nothing.
Wow. 7T and 12T, are those gonna, do you see that higher T?
Right now, not really for the prostate.
No.
Not really for the prostate. But I will say MRI PET scans are a thing. They've been a thing. And those will combine the advantages of MRI with the advantages of PET. And for prostate cancer, they're going to be very powerful.
And I can't wait to talk about that. I still want to hang out with MRI for a little bit because I like learning about all this MRI stuff. If you go on some sites, I'm not asking you to be specific here. There's always this talk of metal. I got metal. I got a pacemaker. I got clips in my brain for a surgical procedure. I've got an implant in my ear. How are you dealing with, when I think of the world today, so many people, I don't care if it's tattoos, and believe it or not, this came up recently, yoga pants. I didn't realize that some yoga pants have some metal strips in there. How are you dealing with the whole world basically walking around with metal? I heard that you can't get an MRI if you have metal. So what's your general thought on wearing metal or having metal in the body and getting an MRI? Can I still get one?
Well, if you have metal, then you should, if it's implanted by a doctor, they should have a card about what that metal was. So if it's a cochlear implant or some other implant in your heart, an implant somewhere else in your spine, you always need to have either a picture on the phone somewhere what that was, because you can look up any implantable device under MRIsafety.com. So if you know you have metal, you can go on MRI Safety, and if you put the serial number in there, it'll tell you if it's MRI compatible.
Okay.
So if you don't have that information, then we have to kind of figure out what you have. So that's implanted devices by doctors. Now there are other things that people could have, shrapnel from war injuries or accidents or whatever.
Yeah.
And that just needs to be known where that is. If it's in the extremities, it's probably not a problem. If it's in your eye or your orbit, that could be a problem sometimes, and it could heat up or move. And so we don't want that. So then what we do is we urge you to get the MRI in a lower field strength magnet.
I see.
So the whole metal thing is mostly overrated, but there can be some certain situations where it can be problematic. 90% of the time, it's not a problem. 90+% of the time, it's not a problem. You just have to know what it is and where it is. With the very specific exceptions of it, something in the eye or some other very sensitive area. So the real problem is, will it heat up and cause a problem, or will it move and cause a problem? And that almost never happens.
So I'm glad you gave us that website also, because as I touch on 60, I'm just about to cross over there. I know Dr. Scholz is touching on 70. I always like to remind people that he's 10 years older than me. It makes me happy. And I'm starting to.
He looks good though. He looks good.
He looks good. There's no question. But me, I could be a male model.
I mean, you also look good.
Thank you. But
Yeah.
I have male model potential. And
Yeah.
so I can tell you, in my mind, I'm good looking. Outside of my mind, I'm not so sure. Okay, so I have friends now that have metal hips, metal knees. We're still okay there?
Yes, and the biggest problem there is not so much the metal, but the artifact from the metal, especially in the hips, that can cause problems imaging the prostate. We want to do it at a lower field strength, and use sequences don't cause so much artifact.
I wish that came out on the websites more. To me, on the websites, a lot of them that I looked at before we did this interview, is a lot of them sort of all or nothing. I didn't feel like there was a gray. I don't know. Maybe that's just me.
Yeah, and I think this is a bit confusing area, but I think if you go on MRIsafety.com,
yeah,
gives you what you need to know. But generally, if you have implants, we can do almost anything. If you have a defibrillator, if you have heart AICD and defibrillators,
yeah,
we can, and pacemakers, we can turn those off and scan you. But we have to know what they were. You have to carry a card or know what type it was.
Yeah.
Once we have that information, we can deal with all that.
That is awesome.
Yeah.
That is awesome. The other thing that confuses me about MRI is they used, I'm sorry, but you guys and gals throw around these words like fusion biopsy or in-bore biopsy. And a lot of people go, what? Does that mean that they're getting the biopsy inside the MRI? Does that mean that you're taking the pictures from the MRI and then just utilizing those with ultrasound to then do the biopsy with ultrasound? Does in-bore mean, so can you walk me through the in-bore fusion basics, and what does that mean if a doctor says to a patient, I want to do a biopsy for you in-bore at UCLA, or I want to do a fusion? Can you walk me through those basics?
Basically, there's many ways to get to the target.
Yeah.
The idea is, based on the MRI and or PET scan, you have a target. That's the shark, that you're thinking that's the shark.
Yeah.
To get to that target, you got to get a needle into the target. And a lot of that comes down to the skill of the person doing it. That's the whole thing about interventional radiology. It's not just done by interventional radiologists. It can be done by anybody. The skill set is getting that needle into there every time reliably and safely. Safely and reliably, maybe the opposite.
Okay.
So you can use the MRI to do that. And the beauty of the MRI is it's WYSIWYG. What you see is what you get. You can't argue with the needle like I showed you, that tumor. It's in the tumor. You know exactly where it is.
Yeah.
Every other technology is an approximation of that. So what we then do is, not everybody can get an MRI biopsy. It's just not possible. So then the next step is fuse the MRI with the ultrasound. You fuse two things together. But there you have the error there is about 4 to 5 millimeters. It could be worse with people who are inexperienced. It could be better with people who are experienced. So then you have a tolerance of error about anywhere from 2 to 5 millimeters. Could be more.
Okay.
So if you know what you're doing, that works great. And that can be done in the doctor's office. Okay, so both the MRI and the in-bore MRI in the magnet and the fusion techniques can be done through the rectum, which is our most traditional way. It can be done through the perineum, like I showed, just right through the area between your scrotum and your anus, that area. After we do some numbing, we can do that there. So both of them are good, but I think that the gold standard for me is the in-bore MRI, because that one is the needle is imaged where it is. There's no, it is what you see.
I always give this preamble before. I never see the speaker's slides before. The speaker has no idea what I'm going to ask before, during, or after. They have no idea what's coming. But I want to give a quick ad for UCLA. I have found that when people call the PCRI, we've had a number of people where biopsy after biopsy, they know there's something there. They can't find the target. And eventually they moved to an in-bore biopsy at UCLA. I know this can be done other places, and they found this significant tumor, right? So then that makes me think, man, it's too bad everyone can't get an in-bore biopsy. I mean,
well, and I don't think everybody should. I think it depends on your doctor and the comfort of your doctor. I don't want to say that everybody needs one of these.
right.
But the problem is some people don't realize. I mean, I always want to realize my limitations and I want to be better, but not everybody thinks like that. So if there's a mismatch, there's got to be a reason for the mismatch. PSA is going up, but the biopsies are negative, right? If you just did the old fashioned way, the first time you get nothing, the second time it's even less. They're going to get something. So why is that? Why can't we make that better? So with MRIs, it is better. But if you go out there and you have a PIRADS 5 lesion, it's very high likelihood. It should be in the 90% range that you find something. And the biopsy comes back negative. Why is that? It's not because, it could be because the MRI is wrong or something else is wrong, but more than likely, almost every case I've done, it's because the targeting was wrong. Something with operator, it's operator, the person who does it, that variable is a big variable. It's in all fields, not just biopsies.
Yeah.
Operator error is a big problem for anything. And to me, most of the time, that's operator error.
So in your experience, because this is not a small minority of individuals, they just can't find it. They know there's a PIRADS 5, like you said, and then they go to the in-bore. Do you find when most of these patients go to in-bore, you go, they find it? I mean,
every time that's happened, I've found it.
Every time?
Every time. And I've made my own mistakes on in-bore, and I've gone back and found my own mistakes.
Really?
Yes, because I can make mistakes there because maybe sometimes I'm overconfident. Maybe sometimes I was rushed. Maybe my pager was going off. I don't know what the problem was, but it's embarrassing, but I did it. But I did it to myself.
So what's the limitation on in-bore? Is it also cost, insurance? I mean, what's going on? Because I believe you. It makes sense.
Well, the problem is not a lot of radiologists want to do it. It is a little bit, it feels like a little, it depends on who is where doing it. And I mean, the whole point of prostate cancer care is it needs to be done in a team setting with all these people who are invested in it. So we have that at UCLA. You probably have that at Michigan. A lot of places don't have that. It's just individual people doing things.
Yeah.
And if you don't have a team who can bail each other out and help each other and help the patient ultimately, it's really hard to do.
I'm still kind of wrapping my hands around every time it went in-bore, you found it. I'm just
every time. It's
now my first thought is, does every time mean twice, or does every time mean lots and lots of times?
No, I'm talking about dozens of times over the last 10 years.
I love that story because when people come to advocacy group, it's not always the straight cases, meaning, straightforward, like, oh, here's a biopsy, here's a PIRADS, we got it. There's a lot of gray area. There's a lot of confusing cases, and people don't know what to do, and they don't know what to ask for. So I really appreciate the discussion of in-bore versus fusion guidance. That helps.
And Mark, I'll tell you that not everybody can get a transrectal biopsy. So we've tried to do other ways. We could go transgluteal. We can go transperineal. We can go anterior if we need to. So we'll find a way to get to that target.
You've gone transgluteal, the butt
all
cheek?
The time.
That does not sound comfortable. That sounds like something you would do to someone you don't like. It does
sound like that, but we give the patients plenty of conscious sedation. They don't really even feel it most of the time.
So sometimes when you can't get there perineal wise, you can't get there rectally, you go transgluteal.
There are lots of situations where patients don't have a rectum, or their rectum is damaged or diseased from like ulcerative colitis.
Yeah,
we go transgluteal. Yeah.
So a lot of these IBD type patients, like Crohn's,
anybody who has an
inflammatory bowel disease,
fistula, so many reasons.
Yes,
they could not. Yeah.
Wow. Okay. I thought when I was watching one of your videos, you said transgluteal, and I thought, is that right? So I'm glad you brought that up. Man, this is a learning session beyond a learning session. Okay, now let's talk about something else with MRI that comes up. Someone's been biopsied, and then they want to do an MRI. So there's always this discussion of inflammation or bleeding, and how long do you wait when there's been trauma to the prostate to get an MRI if you need one? Or I don't know. There's always, when you listen to certain speakers, some people will say 4 to 6 weeks, 6 to 8 weeks, that when you image the prostate with an MRI, if there's a bunch of blood there and it's temporary, that's not a good time to image the prostate. Do you have any kind of general comments on that? Because
to me, I used to think the 4 to 6 week thing, the 4 to 6 weeks, I think those data are from the time when we routinely did a biopsy first and then MRI, which was done in the early days, like 15 years ago.
Yeah.
You can see blood there for much longer time than that. So I don't really see a need to wait I don't see really see a need to wait. I would say if you can at all do the MRI before the biopsy, that's ideal, because we can see blood there for months on MRI.
That is interesting. So
I wouldn't really wait. I just do it. Maybe do the PET scan if the MRI is negative. Whatever you can do to get a diagnosis.
Okay, the old saying, well, if you want to go to a surgeon, you better find someone who's done a lot of surgery. You want to get radiation, go find someone that's done a lot of radiation. But I don't think that's often a pathologist. You want to go to a good pathologist, someone that's done a lot of pathology. I don't feel like that is often applied to radiology. In other words, you've got to convince me in the audience that the experience of the person reading the image makes a massive difference. There's a learning curve with MRI. We're going to talk about PET later, but there's a learning curve there that's pretty steep, isn't there? Don't you want to go to a center that does a ton of these things?
In every field that that does anything, the more you do and the smarter you are, the better you are. You want to go to the master machinist, you want to go to that person.
Right.
It's true in surgery. High volume centers do better than low volume centers for anything.
Right.
It's true in radiology. At our center, we have super specialized groups, meaning we have people who just do abdomen and pelvis reads. Only a fraction of those do prostate reads. So we have 40 people looking at general abdomen pelvis scans. Only 6 or 7 only read the prostate.
Huh.
Nobody else reads them, because we want all the QC metrics to be sure that we are interpreting everything at a high standard, that our inter-reader variability, meaning radiologist A, B, and C are close to each other. And so as a result, only a few people read it, and we try to make sure that when they get something wrong, they know they get something wrong. We get the feedback. When the biopsy comes back negative for whatever they've called, they understand that. And that's what that report does. So it is critical in every step of the game, no matter what field you are, to go to somebody who's done a lot of it, and somebody who's smart about it, and somebody who recognizes they make errors. To me, all the stuff that I've done is because I feel like I'm not good enough.
Well, the reason this drives me a little bit wacky is because you look in the newspaper. Are there newspapers anymore? You look on the internet and it says, hey, imaging center here, imaging center there. They pop up all over the place. And I'm going, well, wait a second. I'm pretty comfortable getting an image there. I'm not so sure. Like, who's reading this thing?
That's very important. And that's also important for pathology. You got to know who interprets the stuff, how good they are. Because again, when you look at just general inter-reader agreement, that's the measure of quality. Radiologist, pathologist, urologist, A, B, and C.
Yeah.
How good are they with each other? And you want a group that works well with each other and does it at a high level, and most importantly, measures themselves, measures their own successes and failures. And we do that.
Okay. Then I think we agree with each other. You should be just as critical of the person reading your scan and make sure they're experienced as you are of the radiation oncologist treating you or the surgeon, right? But then if that's the case, then why do we never see these signs on websites? Hey, you want a second opinion on your MRI, or let's just say even PET CT? Call blank, blank, blank. call Dr. So-and-so at UCLA or USC or wherever. In other words, two-part question. Do you do second reads on MRIs? I mean, does your group do a second read if someone wants to get another opinion, if they're a little bit nervous about, or there's something ambiguous? Or do you only do that when people push it really hard? I mean, is this advertised?
It should be.
It
It
should be.
because
Exactly.
it's necessary. And believe me, half our business. So today, when I go back, I'll have 25 scans to read. 12 or maybe 25 or 30 scans. 12 or 20 or 12 of those 25 are done somewhere else, waiting for my second opinion. And almost always will disagree. 80% of the time will disagree with that opinion because it's being done by somebody who's just not, who's just not as good and or not as experienced. And for a PIRADS 1 or a PIRADS 5, they may be good, but it's always in the middle. All that stuff in the middle.
Yeah. Like the threes.
Like the threes. And that's in life, you're sitting at where the threes are. The ones and the fives, you can figure out who had a home run. That's fine.
Right.
That goes you can figure that out. You can figure out who struck out. But what about the grounders?
That goes back to the discussion of in-bore. It's like everybody knows the basics, but what do you do when the basics aren't applied? So thank you for agreeing with me, because I'm so stressed out about this question and this sign that I need to take a sip of my Michigan Wolverines cup, my green tea.
There's the big M. I'm going to look away.
Yeah, you should look away. But I'll tell you, it really gnaws at me that, I don't know, maybe PCRI should be doing it. I brought this up last year at the conference. Somebody needs to advertise. Look, there are plenty of pathologists right now advertising second opinions. It's right on the website for prostate second opinions. If I would have told you that we're going to have advertising like that 10 years ago, you would have thought I was drunk. Now it's standard of care. You say, hey, we do second readings. Now there's second opinions everywhere in oncology. We don't see second opinions on MRI and PET CT. I'm throwing this sign away for now. I'm just happy that you validated it. Thank you.
I think, Mark, that's very important. But again, it's the group that does it that should be invested in prostate imaging,
right?
Invested in everything prostate. They should be doing, just like the good pathologists are prostate pathology people. And even in urology, the good practitioners practice mostly prostate. I mean, they live prostate world, like you said. Our world is prostate cancer. They live that world, but it's also true for radiology and for pathology. But the only thing I would say is there are probably not enough radiologists, and that's where artificial intelligence comes in to help us reread and give them. It's not perfect, but it's getting better, and it helps average people get better. Yeah. Better people make less mistakes.
I just see a lot of pop-ups wherever I travel, and I'm just thinking, hey, it's not that I'm saying a pop-up's bad. I'm just wondering, hey, where would you go if something's ambiguous? Well, so basically you do these things. That makes me happy that you do them. All right. Nobody argues anymore about how important an MRI is in telling you your PIRAD score, your chances of having a significant tumor. But when I watch people get up nationally all the time, they'll say, well, it's still, the MRI still misses about 10%. Some people say 20% of significant tumors. And I'm thinking, and you touched on this, I'm thinking, well, that's not exact. I mean, it's a great score overall. It's a great batting average. But why is it missing those 20%? Did you answer that? I mean, I think you did, but can you re-explain? How are we going to get to those 20%? And the second part of the question is, I think you said it. You said even the ones that we miss that are invisible, they have sort of a different feel to them anyway. Can you talk about that again? Why are we missing, and why should I feel good about you missing 10 to 20%?
That metric has advanced so much more than what we used to have, right?
Right.
Before it was like half or whatever. Now it's up to 80 to 90%. We do miss 10%. Some of them are because the tumors are just not in clumps. When we look at this on pathology, and we do every case that comes out, the ones that we miss tend to be the ones that aren't in a nice clump. They're kind of diffuse. So those are problems. They're not like these nice round balls. They're kind of like this. They're kind of like a little spider. They're just kind of like little spider legs, and we don't see those as well on MRI. I think we do a little bit better when we combine MRI and PET scans. We find more of those things. There's certain types of tumors, like mucinous tumors, that just they look like a background on MRI. So we do miss those. So I think, you know, I mean, if all else fails and the PSA is rising and you can't find anything on anything, you probably should get a biopsy. Probably should get a carefully done systematic biopsy. It's just, so it's not totally dead to me, but I wouldn't want one if the MRI shows something, because when the MRI shows something, then you could target around it. But when it doesn't show anything and you have this high risk, maybe high family risk and all these things, then you have to do it, because it will miss a few 10 to maybe 15%.
So there you go. PSA is rising. People not sure what's going on. It's been missed. I know we're not there yet, and I'm sorry I'm jumping the gun a little bit, but why not then just ask for a PSMA PET?
Oh, no, yeah, I think that's reasonable. Yes. I think, like I said, the PSMA PET and the MRI together.
Yeah. Yes.
Okay. It's not a night and day difference, but it's better. So PSMA PET will pick up 80. That was one of my slides. In our hands, PSMA PET will pick up around 80%, 83% of the cancers, 85% of the cancers. MRI will pick up anywhere from 80 to 90% of the clinically significant cancers.
Yes.
The two together will pick up close to 90%, because some will be missed on PSMA, some will be missed on MRI. We put them together, they're better, but they're still not 100%. The ones they miss, like I said, though, are the lower grade, smaller ones. Very occasionally, you'll find a high grade big tumor that's missed on both. And those are the mucinous ones, for example.
Yeah. Boy, that's interesting. That's really, really interesting. Okay.
So we're getting to 90%. I think we're close to 90. I'm not sure how much better we can get with this, what we have now.
It's so funny because you know this, 3-5 years ago, the idea of combining an MRI with a PET, is that where we're going now?
I think so. I think so.
You're feeling that good about the data?
I think so. I think, you know, PSMA is too good not to just ignore or use as a secondary test.
Yeah.
I don't think you need it all the time, but I think if you're going to make critical decisions like the ones we talked about, it's necessary. MRI is negative, PSA is rising, PSMA for sure.
Yeah.
MRI is discordant, then I would do a PSMA. You want to go to surgery or radiation, I would do a PSMA. Right? You want to do active surveillance only, maybe MRI is okay.
Maybe MRI is okay.
Yeah, maybe MRI alone is okay for that.
What if you're one of those that you are in active surveillance and you're teetering, you got a little bit of pattern 4 going on? You're one of those, you're not a minnow, possibly you're not the shark, maybe you're cod. Maybe you're salmon.
I don't know the answer to that. Maybe I don't know the answer to that yet. But
yeah,
you know, this is what this is where we're getting. But I think right now, the data I'm feeling confident about is if you're able to do it, and you're able to do it in a good place, I would get the combination, especially for critical decision making.
I'm sorry to ask you this next question, but I ask it of everybody who does MRI because it's never going to go away. I looked online, it's everywhere. It's the MRI 2024 controversy. And then we're going to talk about a little bit about limitations. And then we will go to PET-CT. Here's what Shakespeare said in my mind, or Hamlet, actually. To use contrast or not to use contrast. That is the question. I'm sorry to do this to you.
I'm going to go like Hamlet. I'm going to go a little sad.
All right.
I'm going to go a little sad.
I'll take
I need to go back.
Steve or no, Steve?
Yeah. I will say that
I am just on pins and needles, just waiting to hear your answer. This is actually important stuff. I can't wait to hear it.
I think you don't need to use it. I don't think you need to use it. I think if for most situations, there's no good reason to potentially use it. 90% of the information, 90 to 92% of the information is on the T2 and the diffusion weighted imaging. However, about 7 to 8% of the time, you may only find the cancer when you give the dye and it shows up in that early phase. We image a whole bunch of times after we give the dye. It's like taking a multi-shutter image of the same area after you give the dye. The tumors light up. Tumors light up generally. So about 6 to 8% of the time, that's true. And you may find a tumor only in that situation. There are other reasons to use the dye. If you've had radiation or surgery, sometimes the tumors only show up with the dye.
Ah,
So it does help. It doesn't help most of the time, but it does help on occasion. So,
okay.
so the answer is, I agree with the fact that you don't need to use contrast most of the time. Most of the images, most of the time, the information's all there.
Well, what I put in here was metal. I found that the first paper I saw was from Cleveland Clinic in the Journal of Urology, and now other people are accepting a certain position on it. You know, with some of these BPH procedures, like when they put metal clips in there, UroLift, there's a question of where do you stand with these procedures that place metal in and around the prostate? You have to use dye there, or can you?
Yes, I think so, because they create a lot. They can create a lot of artifact.
Oh,
They can't.
well,
Terrific. So
yeah,
I would say
great.
if you're going to do that, at least get a baseline MRI to see what was there.
Yeah. No, but this is important because people are running around, and then, you know, UroLift's a good procedure, but if one of the catches is, you know, you
It
have to
makes all
go
these imaging things hard,
because it makes the image harder to read,
harder
right?
to interpret, because you have a lot of artifact, and there's no way to get around that now. What are you going to do? You know, it's already in there.
Oh, there are so many ditties in this talk. Alex, Peter, I know you're watching. I am foaming. I'm so not foaming in a bad way, foaming in a good way. I want to talk a few more catches. So one of the catches of having some metal there, and you might have to get the dye, but gadolinium in and of itself, when I talk to most people, I understand the worries with certain individuals, but they also remind me of the millions and millions of scans that if it was truly, really problematic for most people, that you would have seen a signal already. Is that fair to say?
Very fair. So I think the problem is there's been scares that are outsized of what's actually happened.
Okay.
So gadolinium has been around since, and FDA approved since 1989. So in around 2006 or 7, they found in a certain subset of patients were having these skin reactions, and that was called nephrogenic systemic fibrosis. It was about 200 plus patients.
NSF, yeah.
Yeah, NSF. And that problem occurred in people who had multiple medical problems. And in our situation, it occurred in patients who were post-transplant, multi-organ failure, really sick, and they were given the dye. And those patients were more at higher rates of getting the NSF. So, but that problem has been virtually eliminated by not giving those kinds of patients dye.
Okay.
It's not in an outpatient population like a prostate cancer population. It's not in that population. And plus, the dyes that were most associated with that particular entity, which is also small, are no longer being used. So both of those things has eliminated that problem. Then the next problem came that they've noticed that in the brain of patients who had multiple gadolinium-based exams, so if you're getting a cancer scan, that some parts of the brain, the center of the brain, had gadolinium deposition, meaning they found that on successive scans, you could still see some gadolinium there. And that's been true for other parts, other organs. But what's not been shown is that that's actually caused a problem in any given patient. Any kind of memory problem, cognition problem, you know, your intelligence problem, thinking problems, or any other kind of problem. They've noticed that the fact that there's some deposition, but not a problem from the deposition. So to me, okay, it's there. Yeah. So if you need the scan, there's no reason not to do it. If you don't need the gadolinium scan, don't do it. But it doesn't tell me not to do it, because it's fundamentally a very safe drug. A few problems I've ever seen with it include allergic reactions. That can happen.
Yeah.
And so that can be serious, but it's really pretty rare. So if you don't have that problem and you need to use the dye for some reason, there's really no reason to not to use it.
Okay. But in the end, if someone just says, your choice, doc, you would like to use it, if you could, to
I would like to use it,
6%.
but I don't insist on it. You know, if you have some phobia or anxiety about it, don't use it.
Okay.
Until you absolutely need it in the situations what I outlined, after surgery or radiation.
Okay.
That's an absolute, you know, it's really helps in those situations.
Really? So as you move along there, okay, the stage part. Okay. All right. That's really good to know after surgery and radiation. All right. Tell me about.
Maybe also focal therapy, Mark. Maybe also focal therapy.
You took the words right out of my mouth. Focal
Yeah.
therapy. Okay, great.
Yeah.
So post radiation, post surgery, and after focal therapy, that's a lot of people that you're excited about getting the contrast.
Well, I'm not
Okay.
excited about it. It's just, it helps a lot. Like,
I know. I mean, yeah, it helps you.
yeah, it helps a lot to see where the tumors are. And maybe with using PSMA more, maybe those will also, it may be less important. But right now, we don't know. So right now in 2020, March 2024, I can say that I would use gadolinium absolutely in those situations, not worrying about your ability to think or any other problems with you.
No, people don't talk much about diet restrictions with some of these images. Are you, because I know you don't want the prostate moving. I remember doing an interview one time for someone in New York, and they said, well, they want their patients on a low residue diet before an MRI scan. They don't want much rectal gas. They don't want a lot of gas in there. Is that still the case? Where are we with all this?
I think whatever you can do to minimize motion is very important. So MRI is very sensitive to motion.
Okay.
And so are these techniques, the T2, the diffusion, the perfusion, they're all sensitive to motion. And motion comes from breathing. Motion comes from your just moving around. Motion comes from the bowel, your intestines moving and the rectum moving. So if you can minimize all that, it's better. And gas is very important because gas distorts a lot of things. So we want them to empty their bowel, especially their rectum, beforehand, because gas really gets in the way. So we try to do all those things to minimize any problems.
So they change their diet. You want them to.
We do a Fleet's enema. We give them.
Too.
Yeah, we do all those things to just help them get rid of all that stuff in the rectum as much as we can. We don't always succeed, but we try.
Okay. I hope you're not in a hurry because I'm having too much fun with this and we're answering too many questions. So can you hang in there just a little bit longer?
Absolutely.
By the way, you want to hear something? You can show you how much, again, this is proof positive I have no life. I read a headline before this interview. It said, oh my gosh, this was a major headline. It said, there's a helium shortage and helium's used to cool down the magnets of the MRI because helium can get down to minus 450 Fahrenheit. And I thought, I never thought about that. So are we going to be able to do MRIs in the near future because there's a helium shortage? Is there a helium shortage? What's going on, Steve?
I think it's gotten better, but there still certainly is. And so for the high field magnets, they're cooled with helium.
Okay.
For the low field magnets, the ones that are open MRIs and the lower field magnets, they don't need helium. So, maybe we'll go to that. We're actually installing a low field magnet at UCLA. Maybe you are too there. And if the images come out good, we wouldn't worry about helium.
But right now, you're using helium with the prostate MRIs.
Yes, for the 3 Teslas and the 1.5 Teslas, yes.
Such an interesting thing. It's a business everywhere.
It's all related.
All related. We're all interdependent. I also read someplace where I always find it interesting in an MRI scan, most of them will say the prostate size, right?
Yes.
Most of them will say 68, 42, 93. It sounds like a quarterback making a call, I know. But I just thought to myself, and I looked at it, and there was a couple formulas. There were 1 or 2 different formulas, and I thought, well, do you feel comfortable that MRI, and you can even comment on PET-CT if you want, is that, because you use it for PSA density, size is important for measuring and using it for certain formulas. Do you find that the MRI is actually sensitive and accurate at measuring prostate size?
Yes. For the most part, yes. But if you truly wanted to know the prostate size, almost any software will calculate the volumetric prostate size. And so that's very sensitive. If you just do a calculation based on the length and the width and the height, that's cruder, but it approximates. So it's not as good. So if you're going to get size, you actually want to measure the true volume, which you're capable of on all those modalities. You can do it on ultrasound. You can do it on CT. You can do it on MR. You got to do it the right way and the right software.
If I see a UCLA or another MRI scan that says my prostate is X in size, I should feel comfortable that's accurate?
Very comfortable. But if we measure it, if we're saying we are calculating the volume based on the tridimensional measurement, length, width, height, that's not as good. That's an approximation.
How does Joe, whoever, know that they've measured it the right way?
They have to ask the question how they've measured it. Yeah. They got to ask. I'm sorry.
I knew this was a hot topic.
I can't tell you because I don't know at center A or B what they do, but
Yeah.
Most people who are good at it give you a volumetric measurement. In other words, it's not a calculation. It's the actual thing you contour the whole prostate, and that's the volume.
So are you saying to me, if I see on a printout somewhere, I don't care what state, it says length times width times height, it gives and it shows the three numbers. Is that an indication that it was measured correctly, or is that just an indication it could not have been measured correctly? I
have no idea unless they say it's a volumetric measurement. If it's a three-dimensional volumetric measurement, it was measured they're giving the three numbers, but they actually measured the true volume.
So they have to tell you whether or not it was a volumetric measurement.
Or a calculated measurement. If it's a calculated measurement, it's not as good.
Right. That's where you can see in some of these equations, actually, it's underestimated. I mean,
underestimates, possibly overestimates. It's just, it's out there. It gives you kind of a number to throw around.
I know, but Dr. Raman, can you understand? This is such a crucial measurement to PSA density. Like,
the ACR is developing standards for all these things, and hopefully, like breast cancer, prostate cancer imaging will be regulated to that degree.
That is really fascinating. All right. The last question is, all these people having prostates out, they're getting radiation to the prostate, and all people talk about is PET-CT, which is the last thing we're going to talk about. But can you please comment? Everybody thinks the MRI is just basically intraprostatic. It's all about seeing the prostate. If you look at an MRI report, it's commenting on adjacent lymph nodes. It's commenting on seminal vesicle involvement. It's commenting on extraprostatic extension. Can you please give a rah-rah cheerleader moment to the fact that the MRI does a lot more than just tell you what might be happening in the prostate? And what if you don't have a prostate? It tells you adjacent structures. Isn't that correct? Very much so.
I will say that the resolution of the MRI compared to a PET-CT. So we got to distinguish between MRI, PET-CT, and PET-MRI.
Okay.
They're three different things.
Okay.
The resolution, that is, how fine can you see the edges, is best on the MRI. If you want to know where the tumor is relative to the edge of the prostate, to the nerves, to the sphincters, both above and below, to the bladder, to the rectum, that's all MRI. That's the workhorse of MRI. It'll tell you all that. And so if you want to know, if a tiny node is active, MRI is not going to be that helpful. It's not as good. The combination of the two with either a PET-CT fusion or PET-MRI, the PET-MRI right now is probably the single best technique we got. PET-MRI. But not a lot of places have it.
Exactly. That's the problem, right? And then
that's a problem. It's a very complicated technique. It's expensive, and there are places that are using it, but it's not in every corner. It's not every imaging center that's advertising that you're talking about.
Yeah, and then what insurance is going to cover a double image?
Well, yeah, exactly. That's the other problem. How do you pay for it? That's always a perennial problem with any of these things.
Well, some people are paying out of pocket. I almost lost answers. So people in California, I'm not against somebody calling the center and saying, how much is this going to cost me if it's not covered? I mean, because what I'm seeing when people do these cold calls, and you can comment or not on it, is that the price differential is pretty wide in some cases. I mean, so I don't know. It
is very wide. And it's worth, if you are, I am very sensitive to the fact that our mechanisms to pay for all these things are very fragmented. Some people, it works out great. Some people have big co-pays depending on where they get their imaging. Yeah. And I think it's worth it to shop around, because ultimately it's better to have it, even if it's lesser quality, than not have it.
Interesting.
Yeah, that's what I tell people. I mean, obviously I would want everybody to do it at a Michigan or a UCLA or wherever, but I understand that you can't, it's just, the pricing structure is such that sometimes it's unaffordable.
It's hard. All right, you want to just talk PET-CT now?
Sure.
Did I miss anything on MRI, or did I just completely exhaust that journey to the point where nobody wants to talk about an MRI all day long again? Or
you're close to that point. You're close to that point.
Is there anything else that I missed that you want to emphasize about MRI that's a key take-home message, or did we cover it?
I mean, the key take-home message is it's not perfect. It's getting better. The problems are with it are it's unequal. So some places do it really well and some places do it really poorly. You got to find, like everything else you do in life, you got to find the best painter for your house.
Yeah.
You got to find the best guy that's going to do your kitchen floors, and you got to find the best person that's going to do your surgery or MRI, and you got to find that yourself. It takes some doing. It's not equal. It's not equal.
No, that's a good point. And then I want you to always remember, as you say that to other audiences, there's Mark Moyad holding the sign going, when are you going to advertise second opinions? When are you going to do it, Dr. Raymond? Come on. Anyway.
We should do it. We just need to clone ourselves into, 15 times. And I don't know where we're going to find these people.
You're going to find it. I mean, UCLA's helped start, well, let's go, we're going into PET CT. I mean, wow, right? Thanks to UCLA and UCSF, they got the first one FDA approved, the gallium. So let's talk a little bit about, how about we just start with the different types of PET CTs? All right, let's just talk about them for a second, and then we'll go into some basics. I just don't know if you comment on them. Look, I don't care to use trademark names like of drugs or all that. I don't work with these companies. And if I did work with them, I'd still use the trade name, because trying to use the generic name makes people confused. So you have choline that's used primarily at Mayo. You have fluciclovine, which is Acumen. You now have several different types of PSMA, the type that you all started at UCLA. You've got these two other types that have come out. All this is exciting. Then you got one that was sitting out there for a long time called FDG. There's another one there. So there's different ones. Do you just want to make a general commentary? I mean, everyone seems to be obviously great, and when it comes to prostate, is gravitating in this direction. But some of these still have roles. And so I didn't know if you wanted to comment on my new list, because the list is getting bigger every year.
I think if you are talking about PSMA PET CT in 2024, you're really talking about the bottom, the one on the bottom. And the reason for that is it's the most widely available, and overall performance for gadolinium or Polarify or Posluma is right now the best that there is. There are certain situations where you could use Acumen. It's not quite as good as pretty good. Yeah. And there are certain situations where it may be positive and the PSMA is negative, but those are the distinct minority. So most people aren't going to be using choline because they don't get it. They can't get it. You can get it at Mayo, but you can't get it anywhere else. So, okay, if you're at Mayo, great. But you can get Acumen everywhere. Generally not as good as the 3 PSMA agents. In a few, again, like a few percentage, we're talking about less than 10% of the time, some prostate tumors show the Acumen, but they don't show the PSMA because they don't express PSMA that much. But that's less than 10% of the time. 90+% of the time, your PSMA scan, whether you get gallium or one of the other 2 agents, is going to do a great job for you if you do it at the right place. Yeah, it's going to do a great job. And again, we can't get into the weeds because we'd be there all day. But yeah, if we're talking about 90% of the time, it's that good. That should be good enough.
Yeah, you sort of get to the philosophy where it's the bigger point is just getting one done versus fighting over which one necessarily is better.
Exactly. Getting one done and getting one done at a good place.
Yeah, a place that reads these things. Again, not one of these mom and pop pop-ups.
I hope not. And I mean, some of them do a good job too. You just got to know who does a good job.
Right. Yeah.
Hopefully your urologist knows, or your radiation oncologist knows. I don't know. Somebody should know who are the good people.
And then I'm going to throw in some terminology that comes after you get one of these scans. Can you kind of explain this a little bit? Because I'm going to jump around here because of the sake of time. I always see this thing say is SUV. And when I think SUV, I think of a car, right? I don't standard uptake value. And they see these numbers on their, patients get their reports now as they should. They should, like they have just like they have a file for their taxes, they should have a file for their reports.
Very important.
So you see this word just bandied about all the time. SUV, it's SUV this. SUV is important. High SUV is more concerned. How do you put your hands around this in your position explaining SUV to patients?
I explain it kind of like in the old-fashioned light bulbs when they had wattage ratings. Yeah. That's what an SUV is. How bright it is a function of how much it expresses PSMA on its surface. So low SUV would be like a 20-watt light bulb, and high SUV maybe a 100-watt light bulb. So generally, the 100-watt light bulb or high SUV means it's, number one, it's probably real, and number two, it's probably going to be a higher grade type of prostate cancer. There is a range, but in general, when you go from Gleason 3 to Gleason 4 to Gleason 5, the curve goes like this. The line goes like this, meaning that the majority of the Gleason 5s, higher Gleason groups, the higher PIRADS groups show more SUV.
So
it's brighter on the wattage index.
So the higher the SUV, the more likely it is it's a shark?
More likely to be a shark.
Really?
To get a bigger boat.
Yeah. See, you're going to use that in your next talk.
I am.
Right? You'll be driving home.
I should have put more Jaws in there, but I figured, well, it's 2024. Does anybody remember Jaws?
I know, that's a good point, but there's a lot on the internet there. But you'll be driving. I was going to say after this talk, you're going to be driving home, but probably not. In LA, you'll probably be bumper to bumper home.
I'll be crawling home.
Crawling home. Good. So SUV is important. But keeping in mind that, well, I'll go into that in a second. But the other thing is, I want to talk the Achilles heel of PSMA PET scans, because I want to talk about this. What about these false positives? Are there false negatives? But what about these false positives? And before you answer the question, I want to talk to you. I went through a couple of your papers, and it was explained well, and also some of the videos. False positives occur, and here's where some of the reasons for false positive, right? You got some rib fractures or other fractures, maybe a spinal compression, I don't know, Paget's disease of the bone, right? And then here was one I saw on a talk, uptake in a ganglia, which is sort of a nerve bodies, and there are lots of little nerve cells around. So I'm seeing all these, and then I saw this one called after you get radiation, you can get an increase in PSMA that might not mean that you have cancer. So, okay, I hate to overwhelm you with this, but I'm finding lots of reasons for false positives with the PSMA PET. How do you answer this?
Okay, so let's take the situation of early in the diagnosis.
Okay.
So early in the diagnosis, there generally aren't a lot of false positives. So in the prostate, certain kinds of BPH nodules can give you some PSMA uptakes. So let me take one step back. The PSMA protein is expressed on lots of things. It's expressed in blood vessels and other tumors and certain reactive processes. So there's always a background amount of PSMA kind of expression throughout the body. It's overexpressed in prostate cancer cells for the most part. So that's what we're using. Hey, this cancer overexpresses this protein, and these agents bind to that protein. So even if this protein exists throughout the body, I just saw a case last week. A kidney cancer was brightly expressing on a PSMA scan because that particular tumor happened to overexpress PSMA.
Wow.
And that's the answer to your question. So yes, if it makes sense, if you have a primary tumor and a node in the right area, that's probably real. If you have a primary tumor and some other random thing that shows up somewhere else, that's probably not real, and you have to try to explain it some other way. So again, it comes down to expertise. Just because it's bright, high SUV or intermediate SUV doesn't mean it's real. If it's really high SUV, it probably is real, but you gotta look at the underlying imaging. Is there a rib fracture? Where is this thing?
Yeah.
But in my mind as a radiologist, I'm always asking, what else could it be? Am I right when I give a diagnosis? If you don't ask that question, you're going to make mistakes.
Does the MRI help you figure those out?
Yes, in many situations, yes. So the MRI, two together are better together.
I know, man. I'm so excited about that, but I know a lot of people watching are going to go, how am I ever going to get two? I can't even get one right now, with insurance and all this.
I mean, one is good, but two are better. So I can't say everybody needs both, but I'm just saying that the answer to your question, it's complicated, but you got to look at the underlying reason for why something is bright.
Yeah.
Most of the time it makes sense. When it doesn't make sense, you got to have an alternate explanation.
Well, and that brings me to PSMA. So the false positives happen. I should say that. And then, so basically what you're saying is after radiation, you can just see like a flare. You can just see.
Yes, you see that on bone scan. You see it on other things. You can see it sometimes on PSMA.
And that doesn't necessarily mean the cancer's there,
No,
back.
you just know not to image too early. You give it a kind of a window before you start imaging.
But then what do you do about all these people on androgen deprivation therapy? How does PSMA do on hormone therapy, or that has no role right now? I mean, how do you think?
I mean, again, I think when you're dealing with things like that, it's complicated because it's going to decrease the PSMA uptake for sure. It's going to change the way MRI looks after. When you have androgen deprivation, the MRI looks gray. And that's why the dye makes a difference. That's why if you're on androgen deprivation and the PSA is rising somehow, the dye helps. PSMA may help, but we don't know. It takes a certain amount of PSA level to get that.
You mean the dye helps for the MRI?
The dye helps for the MRI to figure out where the tumor is in the prostate or in the surgery bed.
Really?
PSMA, you don't do it too early. So if the PSA is really low, under 0.5, it's not going to be that good. You're going to be false negatives.
Yeah.
If the PSA rises above 0.5, it's much better.
Well, that brings me to something when I'm about to show this chart that's advertised everywhere. So you're looking at things metabolically with a PET CT, right? So PSMA. Yep. So sometimes the dilemma is not just whether or not the PSA is high enough. It's also how it's trending or the kinetics, if it's moving fast. Now, when I think of metabolics, I want to believe that if a PSA is still low, but it's moving up quickly, that's a good time that a PSMA can catch the cancer on the scan. I mean, in other words, is it not just the number and how high it is in terms of a chance of a scan being positive after primary treatment, for example? What if it's low, you're doing an ultrasensitive PSA, but it seems to be moving up quickly? Do you catch more cancers with velocity moving, or does that have nothing to do with it anymore?
I don't think that same concept really applies to the PSMA scan. I think the total level matters. The velocity may matter. I don't know. I don't know it well enough to tell you that answer that question. But to my knowledge, a high velocity at a low PSA value is not going to help as much.
Okay. Now, I just want to announce to the world, I'm about to introduce Dr. Raman to another controversy. Here it is. First, I'm going to give him kudos. This is what they advertise. So after you've had surgery or radiation, you want to catch the cancer early. You could still get a second shot at cure. We know all about this stuff.
Yeah.
And the lower the PSA, the higher. This is from the Condor trial. So if the PSA is less than 0.5, because a lot of people advertise, they get all fixated with 0.2. Once my PSA hits 0.2, I want my PSMA. But only about a third of those scans lit up, right? So,
true.
But when
that's what I was trying to say. Wait for it to get to 0.5. You got to wait.
So, see, that's what's interesting, because that's not what's advertised. What's being advertised and suggested out there in PET CT land is the moment you hit 0.2, let's move. So you're saying you're more excited about hitting that 0.5 threshold, right? Where it becomes 51% or higher. And tell me if I'm wrong here though, Steve, honestly, these are old numbers from an older trial that was published in 2021. Some of the readers are getting so good. And I looked at the confidence intervals on these, these numbers are getting better and better at the lower PSAs. Am I right?
I think you're right. I just don't know that they're that much better at less than at 0.2. At 0.2, I mean, you can get it, but a negative scan doesn't mean it's negative.
Right.
I would do it with the MRI with the dye. I would do it. I would do the two together if possible to catch that extra percentage of the ones that are the ones that light up with the dye versus this where they may not quite light up here. So the combination of the two will be more sensitive.
Are you saying that the combination of the two are more sensitive if you want it done at a PSA of 0.2? Or are you still saying wait to 0.5? So if you're one of those people that say, I'm not waiting to 0.5, I don't care what Dr. Raman says, I'm going to get it at 0.3. You're saying, well, then at least get both?
I would say get one, get this one. If it's negative, then get the second one.
That is interesting. What about if it does hit 0.5 or go higher? You're feeling much more confident in the PSMA.
Much better. Yeah, much better. again, if we did a PET MRI,
Yeah.
we wouldn't have this problem.
Yeah.
But these numbers are still relevant. And that's why I say 0.5 is where we start getting comfortable that the PSMA is going to do a good job.
You know why I yelled out to the world about the controversy, right? Because the longer you let the PSA rise, for example, after surgery or radiation, that's when the radiation oncologists go, hey, I want to hit this thing earlier. The earlier the PSA, the more chance for a cure. Why are you waiting, Steve, for this to go so high? What say you?
I can say that the scans are what they are. So I would say do it, but you can't rely on a negative result. It's only rely on a positive result. Yeah.
Yeah. Okay. I mean, I think these aren't bad values, but this is not what I see advertised in.
No, you're right. And that's why, again, we gotta tell it for what it's worth. These are tests and they have ways to perform. And there's so many variables that go into a good performance.
Yeah, but that's really, your commentary is really, really interesting. Are you seeing any, this was early on, because, I'm a food guy. Early on, there was some concerns of certain liquids or foods or exercise impacting a PET CT scan, PSMA. Have those fallen by the wayside that you don't need to do that? You don't need to have any dietary restrictions or exercise restrictions. We see that with choline, actually. And there's actually, for the Axemin, there's actually some mention of restrictions. How are you feeling when it comes to that and the PSMA PET right now?
I think the restrictions are increasingly less apparent, but I don't know all the details about exactly the restrictions.
Yeah.
You got to check with your individual center what they want. I don't think it's a uniform set of recommendations.
No, but I feel like those recommendations are people seem less.
They are less important as you as you gain more experience.
That's awesome. So let's just say my PSA is undetectable. I'm doing great wherever I am in my prostate journey, but I just don't want to rely fully on PSA. Maybe I'm seeing a little increases or decreases. Some PSAs are variable, and I just go, everything looks fine. My doctor's saying, you're doing fine, Mark, but I go, I just want to make sure there's no disease activity, even though I'm under therapy, let's say systemic therapy. I want to get a PET CT. Do you ever run into that where someone seems to be doing good on paper, but they want the image to tell them that they're really doing good? What say you, Dr. Raman?
I mean, it's an anxiety-based thing, and I understand. I mean, we're all going to be anxious. And the good thing about imaging and the power of imaging is you can see it right there. It's there or not there, and you can't argue with that most of the time. So yeah. I understand that anxiety. We all have it. We're all going to have it to varying degrees. So it is much more comforting to know what you're dealing with than the unknown of not knowing. So I understand that. Whether it's validated for that, I don't think we have that answer, but I understand the anxiety, and it's reasonable to get it for that reason.
And you feel comfortable in a lot of these scenarios that what it's telling you is what it's telling you.
Yeah, and that there are limitations. If PSA is low, it's not going to be as good. You just know you have to deal with that.
Yeah, because it's weird, isn't it? I mean, we have these cutoffs like biochemical recurrence, right? We have these cutoffs of 0.2, and then you have this equation for radiation that says +2 from the nadir, and you're kind of going, should we be waiting that long? Because when I look at research from Dr. Raman, it says the higher the PSA, the higher the chance for extra prostatic extension. So should I be relying on these equations? Maybe I should be asking for a PET CT earlier in the PSA rise.
I think it's reasonable. It's a reasonable question to answer and ask, and you have to talk about it with your urologist or radiation oncologist. And they should be guiding you as to where to get it done, who's good, and all those things. They should be, in your local area, they should be the people telling you these things.
What's better in prostate cancer screening, MRI or PSMA PET? Just screening.
MRI is simple. It's a 10-minute exam, 10 to 15-minute exam. So I would say that if you're talking about just looking at PSA and because the negative, that is, if it's totally normal, that's over 90%.
Okay. But how long's an average PET CT take a patient? How much am I dedicating my time to that?
It's radiation, and it's an hour probably. Okay. Hour of your minimum an hour of your time, plus whole body radiation. So I wouldn't use that as a screening test. No.
Okay. How about active surveillance? Which imaging test do you really like in active surveillance patients? when they do
MRI. I go with MRI so quick, no radiation.
Okay. Are you concerned about the radiation? Some people say we're overblowing it. These are older individuals. We're not depending on mitosis and meiosis and all this. It's more, the radiation is more concerning from imaging when you are 15, 16 years old. Is there a concern?
Yeah, you're right. No, that's definitely true. It's not that. It's not that the radiation risk is so much in older patients, older than 65, but I still don't want it.
Yeah.
I don't want it. You don't know how long your lifespan is going to be. That being said, I don't know of a single case of a documented problem from repeat radiation, meaning diagnostic imaging related radiation, but I still don't want it if I can avoid it.
We were playing the game of what imaging test is best with Dr. Raman. He said prostate cancer screening, he likes MRI. Active surveillance, he likes MRI. How about rising PSA after surgery or radiation?
Depends on how fast it's rising, but I think there you're looking probably at the combination of the two, depending on what the PSA level is.
How about if I just want to make sure my no PSA after treatment means no cancer? We touched about that briefly.
I mean, if you really want to know that, then I would just do a PSMA or a PSMA PET CT or PET MRI. You want to know the ultimate test that we have right now for that? That's the test.
What about a rising PSA on hormone therapy? It's really moving.
Yeah, I mean, most of those recur probably in the prostate, so I think an MRI would be the right answer, but I think the combination would be better than either alone.
I love it.
Or I guess in that situation, just a PET CT might work. I don't know. It depends on the PSA level for that.
Your last paper, you had your name on it, I really liked this paper a lot. It was a whole group. And
I'm glad somebody read it.
No, I'm telling you, I read the whole thing. It was called Impact of PSMA PET on Prostate Cancer Management. And here you are. I circled your name on it. And this is in Current Treatment Options in Oncology 2024. And the reason I liked it is it walks you through all the places that PET CT is now used, the PSMA PET CT. And probably one of the only ones we haven't talked about together is oligometastatic disease. So oligometastatic disease and PET CT, because I know that you guys and gals are seeing these isolated spots, these oligometastatic spots that's not quite overly concerning, but then again, it's not contained, and you're excited about using PET and PSMA there.
I really like it because like in other cancers, we can treat it. And we have all sorts of little tools to treat it. It's not just radiation. We have all these ablative technologies we can use to treat it. You can even surgically resect it maybe, but we have all these ways to treat it, and not necessarily all radiation based.
That's awesome. I mean, really, if you think about it, and the one we didn't touch on, that's for a different talk, but the only one we didn't touch on was radioligand therapy.
Yes.
But can you explain something to me, Steve, since you and I are just kind of hanging out at the bar, we're having a beer, maybe we're having some tea, maybe I'm being PC here, we're just having some herbal tea together, we're bonding, and I'm saying, okay, when you use radioligand therapy like lutetium, in these clinical trials, the VISION trial, all these things, if you light up on a PSMA, you qualify for these radioligand therapies.
You do.
But I'm leaning over to you going, but the cutoff is not a light switch. How do you know you've got enough PSMA expression that I'm actually a good candidate for any of these therapies? I mean, is this intuitive where you see a scan and go, wow, that's a lot of PSMA, or there's just enough there that would be a good candidate? I mean, where are we with deciding the cutoff?
I think the cutoff is SUV based, and I think it's the higher the better.
Does that
it's higher the better. So I can't tell you. I mean, there are some floors. I don't know the exact numbers.
Yeah.
But the low expression ones won't do as well. You know that for sure.
So what if you have a high SUV on just a couple lesions, a couple spots?
Are you saying
good about
saying meaning are those the only two spots, or are there other spots that don't take it up?
Both. You brought up a good point. Both situations where
yeah, exactly. If there's only 2 spots or 3 spots or 5 spots, treat those individually. You don't need radioligand therapy for that. If you have more than that or multiple areas, diffuse, that's where it comes. It has no competition when it's diffuse. That is more than the number you can count. If you can count them, you can probably treat them with a combination of different things. So you probably don't need it for that.
Why don't I do one of them?
And in a situation where you want radioligand therapy, the more PSMA your tumor expresses, the better off you are with that.
What if I do one of those? I don't know, it was the therapy trial. One of those, what they did was, I think they included the FDG PET, right? Why? So to explain to the audience, if your FDG PET lights up and you're not getting much activity with your PSMA, maybe you've got a neuroendocrine tumor, you got a different tumor type.
Tumor type, yep.
Do you rely on that? Do you do that? Do you do FDG PETs on some of these people in your department just to decide whether or not you qualify for radioligand therapy?
I think only if you are suspecting that, yes. Only if you're, again, when things don't make sense, you got to go to a different explanation. Why do you seem to have all these widespread Mets? Why is the PSA high but everything negative? Then you got to go to FDG PET. Yep. Again, we're talking about less than 10% of the time, 5 something percent. By the percentages, PSMA works for most of them.
But remember, less than 10% of the time. That's a lot of people who come to our site. That's a lot of people who call Alex on the phone or Mark.
It is. And right. And then on a case-by-case basis, you got to decide.
There's all this concern about PSMA PET scans. I forgot to talk about it. And you know how you excrete it in the urine? It can create these what's called halo artifacts. So the bladder kind of lights up, and that can obscure a possible cancer that's near it. Are you seeing this problem with the PSMA scans where you have these called halo artifacts where the scan is bright in an area where there could be a tumor? So you're not seeing the tumor? Oh, yeah. But what do you do there then?
Again, the answer to me is you got to localize it really carefully. And the best way to localize really carefully is do the PET MRI.
Because again, I had not to be biased toward UCLA. A couple of people that went there that couldn't, they had a rising PSA, even though the PSMA was negative. They were MRI'd and boom, they found it. Boom.
Because, again, it's a mapping problem. You got to map, you just got to, again, you're going to find the shark, but you got to map the shark. Like, where the heck is the shark? Is it, where is it relative to everything else? And if you map it on the PSMA, you can map it directly on the MRI if you get the two of them together. You can approximate it if you fuse them. So in other words, you get a PET CT at one place, MRI at another place, you fuse it. It's not quite as good, but it's better than not doing it.
Well, I'm feeling good about the fact that Dr. Raman wants, after primary treatment, for example, he wants a PSA of 0.5 to feel more comfortable that he can find it. But let's say it's 0.5, 0.6, 0.7, and you still can't find where the tumor is. MRI or repeat PSMA when the PSA gets higher in general to 1 or 1.5.
You have options. You could do an Axumin. Maybe it's Axumin. Maybe it's an Axumin avid lesion. Maybe it's FDG avid. So you could do other tests to also see if it's one of these variants. But again, the chances of finding something is low, but not zero.
But you're feeling, I'm feeling some Michigan confidence here. I'm talking about football confidence.
I know.
I'm feeling
talking about UCLA.
I'm feeling Michigan confidence. Like when you hit 0.5, 0.6, you're feeling pretty good about. I know now if you can't find it, you've got these other types of scans, but you're feeling pretty good about the percentages now.
Very good. Yeah.
Okay. And now we come to the end. I'm sorry, my friend. This has been very refreshing. This is really, I appreciate how candid you've been. I appreciate the fact that you had no idea what was going to be thrown at you. I'm sure you're kind of going, what? This guy's throwing everything but the kitchen sink at me. But you're answering it all, which I love it. So now I'm going to put you in a very positive light. Dr. Raman wins $1 billion, but he can only use the $1 billion to study things. He can't use it on a trip to Iceland, which I know he wants to go on very badly.
Go back.
Sorry. So Dr. Raman wins $1 billion. And today we talked about MRI and PSMA. You can use $1 billion to do the Dr. Raman study that he will just dream of doing before he leaves this earth, whenever that would be. I want to know where he would spend that $1 billion when it came to imaging. Where should the money be put to get to the best answer in Dr. Raman's mind and his profession? where would he spend the $1 billion?
For sure, I would spend it on understanding how to maximize the imaging that you do. So whatever you can get, what is so in other words, I'm going to step back. I want to see what the cheapest, most widely available, and most reproducible imaging technique we can get to help the most men to then predict what their individual prostate risk is going to be. So can it predict? Can it eliminate tests? Can it eliminate all the genomic scores? Can it eliminate a biopsy? Can it predict what ultimately your own individual shark is? And so that's what I want to see. And what's going to help us get there? Will it be an imaging program? Will it be an artificial intelligence program? A combination of the imaging and some kind of blood test. Yeah, or urine test. And that's what other people are using. You know, I gave credit to Paul Boutros earlier. They're using imaging tests, a urine test, simple urine test to predict these bad actors, bad DNA, bad proteins. Can MRI either predict those or be used with those to make a simple test that everybody can get and that we can interpret centrally, maybe with artificial intelligence, to have one unique metric for prostate cancer? That's what I'd spend $1 billion.
That's awesome. Plus, the money left over, you could theoretically do an experiment in Iceland.
I could take a budget airline there, yeah.
So in the next few years, if I'm getting a PIRADS 3, I'm getting a lot of people aren't sure about the spot they're seeing, and this goes on for years and years. And I want to have my second opinion just to make sure with Dr. Raman. I'm so sorry I'm doing this to you on the very end. I'm thinking after today's talk that in a situation where it's just ambiguity, and this goes on forever, that you would possibly take a look just to give a thought. Your team would.
We would, yeah. Our team consists of everybody. We have a weekly meeting with all these players, the radiation oncologists, the pathologists, urologists, and everybody else.
Yeah.
And we discuss these tough cases. Yeah.
Fabulous. You just made my day. Now let's give him. Okay, so when we're getting your address, let me show you what, I'm going to ruin the surprise. Let me show you what we're going to show you in a second. What we're giving you as a gift. We give all our speakers a gift. Money's no object when we give gifts. We may miss a mortgage payment. We may not be able to send our kids to college, but as long as our speakers are happy, that's all that matters. Okay. So I thought, what does Dr. Raman not have? He probably has everything else in this world. He's got the looks, you know, he's a runner. He's at a good institution. He's a nice guy. He's got everything, but there's probably one thing he doesn't have, and it's a coffee mug with a certain saying. So can we bring that up, Peter? The coffee mug he's going to receive at his house within the next week. There it is. He's showing them it's a coffee mug that says peace, love, and radiology. Do you see that coffee mug? Peace, love, and radiology. Has anyone ever given you such a coffee mug?
No. I will. As long as my kids don't drop it, I will, be drinking coffee from that every day.
I knew you'd love it. Hey, I don't want to go overboard here. Like I always say, like an Oscar speech, but I've done this a long time. This is one of the most enjoyable, most interesting sessions I have ever been a part of. And you're just a gem. I really just appreciate your time and your knowledge, and thanks for everything you do. Thanks for joining us today, Steve, Dr. Raman. I really appreciate it.
Thanks, Mark. Thanks to the foundation.
Thank you, Dr. Moyad, and thank you, Dr. Raman. That was awesome. Now, our next speaker is Dr. Brian Helfand, and he is the chief of the Division of Urology and the Ronald L. Ches Family and Richard Melman Family Endowed Chair at North Shore University Health Systems. Today, he's going to be talking about the ins and outs of genetic and germline testing, and not only giving us an overview, but teaching us really what are these and what are the important concepts that we need to know. Right after his talk, he's going to be speaking with Dr. Moyad, where they're going to do their Q&A session and answer our questions. So without further ado, here is Dr. Helfand.
Hello, my name is Brian Helfand, and I'm a urologist at North Shore University Endeavor Health. in Chicago. And I would like to start by thanking the PCRI for the opportunity to speak today about a topic that is near and dear to my heart. And that is, I think, a very exciting topic in the field of prostate cancer that only continues to get better and better over time. And that specifically is the topic of using genetic testing for making prostate cancer decisions. So today, I would really like to address, should every patient get a germline genetic test along the prostate cancer journey? I'd like to just disclose that I am an advisor and a speaker for GoPath Diagnostics, which is a genetic testing company in the field of prostate cancer. And certainly, when we start talking about genetics and genetic testing, I've always found that a lot of people go to sleep, and that's just because we are so used to the concept of genetics in our biology classroom, and we were just trying to get through the day in high school. But it turns out that genetics itself has become and it always probably has been, a very, very exciting field. And certainly the use of genetics has only increased, and that's just because of the technologies that we've used to uncover and get genetic testing have become more advanced, more sophisticated. So we can sequence now everyone's DNA from start to finish. And that cost of that, which used to be thousands and thousands of dollars, we can do at very, very inexpensive fees. So because of that, genetics has really exploded, and its utility in making decisions within medicine and all aspects of medicine has only increased. So today, I'd really like to start off with the basics, and that is really talk about some of the genetics and then ultimately how we use that along the prostate cancer journey. So when we talk about genetics, it's a large field, and there are many, many different aspects to it. But specifically, we're looking at DNA. And again, just to remind everyone, that is the substance in every single cell that is ultimately passed down from generation to generation. And that generational type of DNA is something we call a germline. Okay, and again, that is in every single cell of your body, has the same copy of your DNA. And that's what makes you makes you unique, and other people unique to themselves. And again, every single cell that is normal in your body has the same germline DNA. On the other hand is sometimes we are exposed to toxins, or we're predisposed to form tumors. And as those tumors start to divide, their DNA within those tumors starts to change. Okay, and we talk about tumor DNA a little bit differently than we talk about that DNA that's passed from generation to generation. So that tumor DNA is known as somatic DNA. And that also is really unique to every single tumor, but it certainly has the ability to be different than the germline DNA because it's acquired mutations. So as an example, if a patient has a DNA that has codes of what I'll call A, B, and C, and then that person is exposed to the sun, and the sun hits the skin, and in a certain part of the skin, there are mutations accumulated, and those the DNA is now ABD sequence, that ultimately those ABD sequence cells are called somatic changes or tumor changes and are unique to that tumor, versus the ABC DNA, which is passed from generation to generation, is in every other part of the cell that doesn't, every other part of the body that doesn't have that tumor. So that's really kind of the basis here, is that what we're really talking about today is germline testing. That is the stuff that's in everyone's body. We are not specifically talking about tumor DNA changes or somatic changes. That is the subject of a different lecture that we hopefully will give at a later time. So germline DNA is really, really important. And as I said, is that we now have the ability to use DNA tests to better understand that DNA that we bring with us that is in every single cell. And by understanding that, that can give us insights into what is the risk of us developing certain diseases, just like prostate cancer. It may give us insights into, are we predisposed to a more aggressive type tumor, something that may need treatment? It may give us insights into what other type of related cancers or diseases we may be at risk for. And so it is a very important piece of our DNA to understand. And historically, all we really used to understand our germline genetics, what we were inherited, was family history. And family history remains the gold standard. And that's just because, number one, it's cheap. You don't need any tests to understand family history. But it was historically the only tool that we had. Did your parents have a certain disease? Did they have a risk of heart attacks? Did your father have a risk of prostate cancer? And so certainly if you had a risk of that family history, we want to know that because that does increase your risk of being diagnosed with a certain disease. And in prostate cancer, we do know that family history information is really important, right? So that if you have a father or a brother, what we call a first-degree relative who's had prostate cancer, your risk of developing prostate cancer is higher. Specifically, if your father had prostate cancer, your risk is about 1.5-fold that of the general population. So it's higher because your father had prostate cancer. And the more relatives you have that same history of prostate cancer, the increased risk. So if you have two relatives, your risk is about 2.2-fold higher than if you had no relatives that had that family history. And again, family history has historically been not only the only tool, but that's all we've had. What we've learned throughout time is that family history is limited. And that's because of several reasons. Number one is that if you have a family history, you may not know it, especially as a male gender. We may not understand who had it. We don't talk about a lot of it. And so if we were ignorant and didn't gather that ahead of time or didn't have that opportunity to talk to our family members, it may be there. We just didn't know about it. Additionally, it can change over time, right? My father didn't have prostate cancer, but tomorrow he goes to the doctor, he's diagnosed. Now, all of a sudden, I have that risk. So it can change over time. So ultimately, family history is still important, but it's not the most reliable. We still recommend, and it is very important when you're looking to assess a person's risk of developing a disease, obtain a family history. Throughout time, we've also been able to test our DNA, test our germline DNA specifically to look for specific DNA alterations that we call mutations in certain genes that ultimately can predispose to a certain disease, including prostate cancer. These mutations are generally considered rare. Okay, so we actually refer to them as rare pathogenic mutations. And these occur in a lot of genes that make the media. So breast cancer, as an example, has really highlighted certain genes, including BRCA1, BRCA2, that have become really more of a household name, if there is such a thing. So those BRCA genes themselves have been known to increase your risk of breast cancer, ovarian cancer, et cetera, and they alter a lot of decisions that women make around screening and treatment, even prophylactic treatment regarding breast cancer. It turns out that those genes, along with some others, are also very important in prostate cancer, and we should test those genes to see if you have those mutations to see your risk of prostate cancer. So again, part of an important genetic assessment in germline DNA testing. The newest part to the scene is something that we call single nucleotide polymorphisms. So these are not mutations in a gene, but these are variations throughout everyone's DNA. And I'm going to talk subsequently specifically about what they are, but we can count the number of these SNPs, or these little variations throughout everyone's DNA that are specifically associated with prostate cancer, and create a score called a polygenic risk score that estimates a man's risk of developing prostate cancer. And so when you look at a true genetic assessment for prostate cancer as an example, you can look at the relative importance of all of these components of a genetic history. Family history can explain about 7% of the heritability of prostate cancer. It's important that we assess it, but again, it doesn't really explain the whole story. When we look at those rare pathogenic mutations, such as BRCA2, et cetera, that's about 2% of the population of men who ultimately develop prostate cancer. And finally, if we look at a polygenic risk score, that at simplest explains about 20%, but that can be up to 40% of the reason why men develop prostate cancer. So as I said, we're going to touch throughout this program a lot on polygenic risk scores. And again, polygenic risk scores is just a score that's created by looking at the presence of single nucleotide polymorphisms, or SNPs. Again, every cell in your body will contain these SNPs or variations. Again, the easiest way to think about a SNP is that they are blips or variations throughout everyone's DNA. And if you look at everyone's DNA, there's about 10 million SNPs that exist within the human genome. So these are interspersed throughout the entire DNA and genome that any individual has. And there are certain combinations of these SNPs that have been associated with specific diseases, meaning that there's about 300 or more that have been reproducibly associated with increased risk of prostate cancer. There are others that are associated with breast cancer. There are others associated with colon cancer and heart disease and things like osteoporosis, and you name it, that there's usually a combination of SNPs that can be used to create a score that can be used to estimate a person's risk of any disease. And for prostate cancer, these can explain over 40% of that heritability disease risk that we talked about. So it is a very important part of that genetic assessment to realize that they not only exist, but to be used potentially along that prostate cancer journey. So as mentioned, we can use those SNPs to create a polygenic risk score. And that it sounds like a whole mumble jumble. But what a polygenic risk score is acknowledging and testing a patient for these SNPs, looking at how big of an effect the SNP has, meaning that if you have a SNP, how much risk does it actually impart to prostate cancer? So you can count up the number of SNPs that any individual has, take in account their effect size, and then put all that into a fancy mathematical equation to create a score known as a polygenic risk score. And we've tried to make this easy for clinicians as well as patients to understand it by creating a specific type of polygenic risk score known as a genetic risk score. And basically, a genetic risk score makes it so that anyone can understand it. And so if you have a genetic risk score equal to a value of 1, that means that you have average population risk. That means that the number of SNPs that you have are average. And that means that your risk of prostate cancer, an example, is the average in the population. As an example, an average white male in the US population has about a 1 in 8 lifetime risk of being diagnosed with prostate cancer. If you had a score that was higher, so a genetic risk score that was, as an example, 2, that means you're 2-fold higher or double that risk. So that individual who had a score of 2 would have a score of 1 in 4 chance or lifetime risk of being diagnosed with prostate cancer. And if you had a genetic risk score value that was lower, about 0.5 or 50% less, that individual would have 1 in 16 chance of being diagnosed with prostate cancer throughout the lifetime. So again, we can use these genetic risk scores to really tell a patient what is their lifetime risk of being diagnosed. And this is just to show you that I'm not making this up. This concept of using genetic risk scores or polygenic risk scores have been utilized in many, many studies and that involve hundreds of thousands of patients, both with prostate cancer and without prostate cancer. And as you can see here is that there's a spectrum that's generated, right? So on one hand of the spectrum, you may have an individual who has almost a 6-fold higher risk of being diagnosed with prostate cancer. That patient is at high risk of being diagnosed. And so we would envision that that person should probably be screened early or more frequently because they have that inherited risk that can be used. On the other hand, on the other end of the spectrum, there are patients who have 80% lower risk of being diagnosed with prostate cancer, and therefore they're a lot less likely to be diagnosed. And so we probably can temper or de-intensify their screening practices. And again, just to compare it to what would be still considered the gold standard, is that we use family history. And family history itself, really, do you have a father with prostate cancer or not? And if you have that positive family history, it only imparts a 1.5-fold risk, and that's to every man who reports that family history. So when you look at something like genetic risk score, it is a lot more informative because it really is personalized to what your risk is, but it really spans that spectrum, and you can envision how that can help you make a more informed decision, especially if you're in this, you haven't been diagnosed, you're unaffected, so to say, with prostate cancer, and you're undergoing prostate cancer screening. So now that we know the basis of genetic assessment, including family history, including rare pathogenic mutations, including the polygenic risk score, how can we use that along the prostate cancer journey? So as I said, is that this can really be used in the diagnosis, right? So when we take unaffected men who are undergoing screening, can we use genetic testing, all of those components, to identify men who are at high risk of being diagnosed with prostate cancer? Every single authoritative guideline that we have out there all recommend earlier and potentially more frequent screening among men high risk. Can we use genetic tools to identify those populations that are of highest risk of being diagnosed with prostate cancer and potentially even aggressive disease? Can we use genetic assessment for prognosis? If a patient is newly diagnosed with prostate cancer and he seemingly has a lower risk, less aggressive type tumor, can genetic testing help us identify those patients who actually will go on to develop a more aggressive or metastatic cancer? Can it help us guide in that setting? Can genetic testing, once a patient has advanced prostate cancer, meaning that it's spread to lymph nodes or bone, etc., can genetic testing be used to identify those patients who are most likely to respond to specific chemotherapies or radiation therapy? And finally, can genetic testing be used not only for the patient, but also their family members to help screen better? Meaning that if any of these genetic tests not only increase your risk of prostate cancer, are there other insights that can be provided because they have higher risk of developing other type of cancers? As an example, if you have a BRCA2 mutation, we know that you have increased risk of prostate cancer, but it also imparts increased risk of other tumors, including breast cancer, ovarian cancer, pancreatic cancer, etc. And knowledge of that can help us better screen those patients and their family members as well. So to go through this a little bit more detailed is, can we use genetic testing to assess the risk for unaffected men, identify those high-risk populations, and help us improve our screening behavior? And so again, we've talked about family history, and that's still the gold standard, as to say, if we use family history, we identify a high-risk patient. Yes, it is recommended that those patients start earlier testing. When we then switch to something that is a little bit more nuanced, obtaining a genetic test. So that's going to look at their DNA, and that's going to evaluate a panel of genes that include BRCA1, BRCA2, HOXB13, ATM. There's a whole panel of genes that we now test for. And that panel we always call multi-gene panel testing, meaning that there's more than one that we look at. We sequence the entire gene and we look for mutations. We have recognized that there are specific mutations in certain genes that increase your risk of prostate cancer. And we've done many analyses, and these have been performed in hundreds of thousands of populations. The study I'm showing here as an example looked at over 90,000, almost 90,000 patients. About 5,000 of those had prostate cancer. We compared them to those who didn't have prostate cancer. And 4 of those genes, a gene we call HOXB13, BRCA2, ATM, and CHEK2, all significantly increase your risk of prostate cancer. And again, without sharing all the details, not only did that significantly increase your risk 3 to 5-fold, et cetera, if you had one of those gene mutations, but if you generally had one of these mutations, you formed or were diagnosed at much earlier time points. So that's where, again, the recognition, if you have one of these mutations, we want to start screening you earlier, just so that we know that we're going to catch it at a time that's very treatable. HOXB13, I like to always point out, is a prostate cancer almost specific gene, meaning that men or who have mutations in HOXB13, really the disease that you're most likely to form is prostate cancer. There's not a lot of other cancers associated with it. I always bring it up because it generates a lot of excitement because there are not many genes that are specifically associated with prostate cancer. That is one of those genes. So if you hear about it, it certainly makes the news every once in a while. But the other ones, BRCA2, ATM, CHEK2, are also very, very important. But I'm saying these names really to help familiarize a lot of the listeners here on some of the genes that we deal with on a daily basis. I think it's obvious, and I think I went through this a little bit, but I think one of the most important tests that we can use in unaffected men is that polygenic or genetic risk score. And I think I've already stated the importance of that, because not only does that increase that risk, you can actually tell every patient at an early time point before you even start screening, what is your risk of being diagnosed with prostate cancer? Is that 6-fold higher than the population risk? Is it 80% lower? Is it somewhere in between? And based on that, you can have that shared decision-making discussion and talk about when the appropriate time would be to start your screening. Because the other part about that is that the higher your genetic risk score, the higher your polygenic risk score, the earlier the age of diagnosis. And certainly we know that if patients, and if you look on this side of the screen here, the left side, is that those patients who have a higher genetic risk score, certainly greater than a value of 1.5, are going to be diagnosed at much earlier time points than if you have a genetic risk score that is lower. So if you're lower than less than 0.5, indicating less than 50% of the risk compared to the general population, you tend to be older at the age of diagnosis. And when you look at that differential, there's over a 10-year difference in age between those in the highest 20%, meaning the who have high values, and those who have low values. So if you're going to personalize a screening strategy for patients, and you know that they're high risk, you want to start their screening earlier, potentially more frequently, and that if you had a lower genetic risk score, you can actually wait or delay or de-intensify their screening practices. And again, as a comparison, if we use a current standard of family history, that really doesn't distinguish that difference. There's maybe a 2-year difference between those who had a positive family history and those who didn't. So yes, it is important to take into account, but it's not as dramatic in making that decision. So if we're going to identify a high-risk population that may benefit from earlier screening, it's going to be those who have the highest genetic load or the highest genetic risk score. Moving on along that journey is, can we use genetic testing to help us better understand the prognosis for patients who are newly diagnosed with localized prostate cancer? Again, we do know that about 40% or more of men are diagnosed with lower risk tumors these days. These mean men who have Gleason 6 or low volume Gleason 7 type tumors. We know that a lot of these patients are safe for programs like active surveillance that we can watch over time. But is every man who's undergoing or active surveillance or who has a seemingly more indolent type tumor, are they truly good candidates for active surveillance? Question mark. And two is that, can we utilize genetic testing to identify populations within those seemingly low risk men who actually are predisposed to more aggressive type tumors and are actually not good candidates for active surveillance? And so we have, again, done many studies in this space. And if we look at patients who have prostate cancer and we say, well, do any of the mutations in those rare pathogenic genes predispose to metastatic cancer or lethal cancer, meaning those men who have tumors that have spread outside the prostate or who ultimately went on to succumb to the disease? Do any of those patients have mutations in any known rare pathogenic mutations? And it seems that at least 5, if not more, of those genes do increase your risk of really aggressive type tumors. Those include BRCA2, ATM, CHEK2, PALB2, and a gene called NBN. And because of that, if you have any of those mutations, you are more likely to have an aggressive type tumor, significantly anywhere between 5 to 10-fold. So again, it should set off some kind of red flag. But can we prospectively evaluate that? Can we look at that among men undergoing active surveillance? And so it's not surprising that when we've looked at our own active surveillance populations, and certainly Johns Hopkins and our collaborators there have also looked at this, and men with specific mutations, whether it's BRCA1, BRCA2, ATM, have all done poorly, if you will, in active surveillance, meaning that those patients who have these mutations, certainly in any of the 5 genes that we talked about, are significantly more likely to progress on active surveillance, meaning that over time, they're more likely to develop a higher Gleason 7 type tumor or an 8, 9, 10 type tumor, something that has a lot more potential. And while not shown here, we have reported that not only are they more likely to progress on active surveillance, but they typically will quickly go from a Gleason 6 to a Gleason 4+3, 8, 9, or 10 tumor. So that's about a 3.5 to 5-fold risk for a gene like ATM, meaning that men who harbor an ATM mutation have a significantly higher risk of progressing to a really unfavorable or high-risk tumor. So based on that, they may not be the best candidates for active surveillance, and caution should be raised if you identify those patients to putting them on active surveillance compared to an upfront treatment with either surgery or radiation. What is the role of polygenic risk scores in this space? And this is still a little bit of a moving target. Certainly, we do know that the higher your polygenic or genetic risk score, it is highly associated with the number of tumors that you have in your prostate. So again, prostate cancer doesn't just form as one area or one tumor in a man's prostate, but it forms as multiple tumors simultaneously. Certainly, that appears to be dictated by your genetic load, meaning that if you have a high polygenic risk score that measures your genetic load for prostate cancer, you're more likely to have, a number of tumors throughout your prostate. And therefore, based on that, we question, and there are active trials in this space currently, is if you're considering these days something like focal therapies, meaning that you're going to destroy just one area of your prostate with technologies such as irreversible electroporation or HIFU or cryoablation, you may not be the best candidate if you had a high genetic risk score, because even if you're destroying one area, you may be leaving multiple tumors behind. Does it have a role in active surveillance? Again, somewhat of a controversial topic because the results have been a little bit inconsistent, but it does appear that in some studies that your higher your genetic risk score is associated with a higher chance of failing active surveillance, meaning progressing or coming off of active surveillance. The concept isn't that far off or hard to understand, but the background there is that genetic risk score does not always predispose to more aggressive tumors. And there's a lot of controversy and mixed data there. But there is some suggestion that the higher your score, the more likely you are to fail. And this is a study by which we were a collaborator on, which was an international study that looked among men with active surveillance, looked at their genetic risk score, and then looked at their outcomes along active surveillance. And if you look at this left graph here, that genetic risk score for prostate cancer, the higher your genetic risk score, shown in yellow, the more likely you were to come off of active surveillance and require treatment with either surgery or radiation. I think the study needs to be validated, but again, for this purpose of this talk, it's just important for the listeners to be aware that these type of studies are currently underway and actively being investigated. I think the best known space for genetic testing, and this is somewhat driven by drug companies, is the use of genetic testing to evaluate therapeutic response, meaning that are there certain genetic mutations that predispose you to have a better or worse response to chemotherapies or radiation therapies or immunotherapies? And the answer is overwhelmingly yes. And so there are many trials now in the space. A lot of this is among men with advanced prostate cancer. Again, it's expounded and expanded outside of the prostate in lymph nodes or in bone. These are either hormone sensitive or castrate resistant spaces. But there are certain gene mutations that include that BRCA family that do respond better to certain therapies. Those therapies include classes of medications such as what we call PARP inhibitors. So again, this is a type of oral drug that patients take that works specifically on those pathways that BRCA and their associated genes are known to be involved in. Those pathways are called a DNA damage response or DDR response pathways. And again, if there's a silver lining to having a mutation in one of those such genes, it is that it imparts for select patients an improved response to certain therapies. And this has now been evaluated for PARP inhibitors. It's been evaluated for platinum-based therapy, and certain genes known as mismatch repair genes also seem to respond really well if you have a mutation in those genes to immunotherapies. So again, this space continues to expand. But this is in the era of personalized medicine, saying that if we evaluate patients for these type of responses in your germline DNA, you are likely to have a nice response to your hormone or chemotherapy. And while I'm talking about germline DNA, remember there's a whole nother side to this, which is tumor or somatic DNA. And certainly many of these same gene mutations, which we're talking about here, are also very relevant in the somatic DNA testing space. And so if you have one of those mutations there, you're also likely to respond well to these type of therapies. So it is something that is actively being evaluated in the clinic all the time now as part of almost routine care in the setting to better match up with chemo and hormone therapies to improve patient outcomes. There's not a lot in the polygenic risk score in this setting, meaning that polygenic risk score does not associate with specific chemotherapies at this time and to our understanding. However, there are certain SNPs or variations throughout the DNA that do appear to predict some response. And there is a variation in a gene called HSD3B1 that has reproducibly been validated to associate with the time of response to hormone therapy, meaning that prostate tumors respond well when you starve them of their testosterone. And so many therapies that we call androgen deprivation therapies work by getting rid of testosterone. And certainly there are variations throughout the DNA, this one called HSD3B1, that are associated with a decreased response time to those hormone therapies. And as you can see here, if you have 2 copies of that variation shown in red, you're less likely to respond for a sustained duration. So it is one of those where we're taking note of that now, because many of these patients, instead of just upfront and solely maintained hormone therapy, once they start failing, we should have an earlier threshold to institute a different type of chemotherapy. Again, this has been validated in many, many studies, and its routine implementation in clinic is certainly becoming more increasingly observed. So in summary right now, germline testing is really important. It's important for clinicians and patients to make better and personalized decisions along the prostate cancer journey. It's important for unaffected men because it can really identify who's at risk or actually at lower risk. And based on that, it can help, really personalize your prostate cancer testing or screening. So again, higher risk men, we're going to screen earlier and potentially more frequently. Lower risk men, we can potentially de-intensify the timing and the frequency of screening. Genetic assessment is used for newly diagnosed men and certainly can help provide caution for those men who are undergoing active surveillance or focal therapy if you have certain mutations. It can help identify the right chemotherapy and the timing of that chemotherapy for men with metastatic disease. And finally, although we didn't talk about it as much, is that it helps that patient as well as family members improve their screening practices for cancers that they may also be at risk for, whether that's breast, ovarian, pancreatic, melanoma, et cetera. And so knowledge is power, and early genetic testing, really at upfront and an early time point in a patient's life, really can help us make improved decisions. So I believe it should be used along that journey for every single individual. So what's new? Did I spill all the beans already? There's a lot of excitement, and I do believe that we only have really touched the tip of the iceberg, and the best is still yet to come. And I think just to show you on some latest projects that we and others have been working on is how can we apply genetic testing to look at other aspects of prostate cancer. And so one of the projects that I think is most exciting and has a potential for a large impact here is that, as I said, is that there are men with advanced prostate cancer. A standard of care treatment usually involves androgen deprivation therapy, or ADT. And these include classes of medications that get rid of your testosterone or block the synthesis of testosterone or hormones, or block the testosterone from acting on receptors in the cell. And there's a lot of these type of medications. Certainly historic ADT, usually most people think about leuprolide or degarelix, etc. Those are the ones that are most commonly used. And although they're really good for treating and containing prostate cancer, certainly we've realized over the years that there is nothing benign. And even though they're good and again, they don't cure, but they control prostate cancer, there are certainly side effects and long-term side effects that we're become aware of. And certainly it's becoming increasingly important, not only for clinicians and patients to recognize that you are at increased risk, even with one dose of things like depression. You are at increased risk of osteoporosis, meaning your bones become frail and you can fall and break your bones. You are at increased risk of cardiovascular disease if you have exposure to hormone or therapy or androgen deprivation therapy. So knowledge of that is important. And the question is, can we use genetic testing specifically to identify those patients who are most at risk of developing these side effects? And the answer is yes. So can polygenic risk scores, that what I talked about, be used to predict adverse events from androgen deprivation therapy? And again, these are not polygenic risk scores that are specific for prostate cancer. So these are different than the one I just spoke about, but these are polygenic risk scores that are specific for osteoporosis, that are specific for depression, that are specific for cardiovascular disease. And so I just want to give you a little bit of insight into some of the projects that we've looked at, both in large data sets, but we've also now validated in our own institutional data sets. And that is to say that if you're going to undergo androgen deprivation therapy, what are your risks here? So we used a data set called the UK Biobank. So this is a prospective data set that involves over 250,000 men that have been followed for over 15 years out of the United Kingdom. And some of those men were diagnosed with prostate cancer, and some of those men were diagnosed and ultimately developed metastatic prostate cancer that went on to kill them. And so what we can use that database is to say, well, if you've had a metastatic prostate cancer and you were exposed to androgen deprivation therapy, do you have increased risk of cardiovascular disease or osteoporosis or depression? And certainly when we look at all prostate cancer cases, the answer is yes. If you have risk of all of that, even if you just were diagnosed with prostate cancer. But that risk is really exaggerated among men with metastatic cancer who were exposed to ADT. Because as an example here, if you didn't have that androgen exposure and you just had localized cancer and treated, you have basically average population risk of heart disease. You have about 2-fold higher risk of osteoporosis and about 1.4 higher risk of depression. But if you had metastatic disease, you have about 1.5-fold higher risk of heart disease, about 5-fold higher risk of osteoporosis, and over a 2.5-fold higher risk of developing depression. So, okay, so that's there. Are there tools even among those cohorts to help us better risk stratify that? And again, the answer is yes. So if we compare those men in that same data set with metastatic to non-metastatic disease, metastatic patients who had advanced prostate cancer because presumably of that the hormone exposure, that they have almost a 1.4 fold higher risk of being diagnosed with cardiovascular disease. If you specifically look at men who have a low, an average or a high polygenic risk score for cardiovascular disease, you can then stratify that patient population with metastatic prostate cancer. Meaning if we look at patients in the red line here, those are patients who have the highest polygenic risk score for cardiovascular disease. It turns out they are 10-fold higher at risk of developing a heart event, like a heart attack, throughout their follow-up period. And certainly, if you're at low risk, you're only about 1.3-fold higher risk. So again, you can stratify patients. And again, so if you imagine that you see a patient in clinic who has advanced prostate cancer, and they're so worried about their prostate cancer, and you're there as their treating physician, and you're really focused also on their prostate cancer, but you get a polygenic risk score for heart disease, and it says they're 10-fold higher risk of heart attack, you're going to make sure that they're seeing their primary care physician, their cardiologist, to ensure that we can do things to maximize their heart health and hopefully prevent those cardiac events. That's really how we are envisioning using a germline genetic risk assessment for heart disease to better risk stratify patients undergoing hormone therapy. The same results we're seeing for osteoporosis, and then I'll show you depression, is that if you compare men with metastatic prostate cancer versus non-metastatic prostate cancer, there's over a 2.6-fold higher risk of osteoporosis among men presumably undergoing hormone therapy. And again, that risk can be stratified by your genetic risk score. So if you have a genetic risk score that is in the high category, in the top 10%, you're going to see that those patients have over a 16-fold higher risk than the average patient in the population of being diagnosed and treated for osteoporosis versus those who are in the lower risk. Again, it's a risk stratification tool that really allows us to identify those patients who are more likely to develop that phenotype of osteoporosis, be proactive with them, put them on the appropriate medications to prevent that osteoporosis and the bone degrading side effects of that hormone therapy. And certainly depression is really becoming a focused topic among patients with prostate cancer in general, but also specifically with metastatic prostate cancer. It's important for myself as a treating provider to recognize it, to screen for it, because again, so many patients have increased risk of depression. Specifically, if you have metastatic prostate cancer, that's 2-fold higher than patients with non-metastatic prostate cancer, and actually almost 4-fold higher than patients without any cancer at all. So it is one of those where we really have to pay attention to it because, again, that is a treatable thing that certainly affects quality and potentially longevity of life. And when you look and you use that same type of risk stratification, there is a separate genetic risk score for depression. And again, you can identify those patients who are 5-fold or 4-fold higher risk based on that. So it is, again, something that not only is forced to call our attention to those high-risk patients, but if you are going to put a patient on an androgen deprivation therapy, I do believe that it is important to get that genetic testing, not only because it makes you, it forces you to look and identify those high-risk patients, but again, it's to hopefully be proactive and force you to be proactive in treating those conditions before they even develop. And so I'm going to end this by saying that certainly a lot of this is here and now. And while we always have ongoing studies, a lot of this is actually commercially available. As a just full disclosure, I do not get any money from this testing at all. I do believe in testing, and certainly we have partnered with GoPath Diagnostics to help develop prostate cancer specific tests that do incorporate a lot of this type of rare pathogenic, the polygenic risk scores for prostate cancer, for the osteoporosis, for all those associated diseases. If you are interested, whether in a study or certainly in obtaining genetic testing, you can use this QR code or the site that will kind of help direct you to therapies to obtain that. There are, as part of that, genetic counselors who can go through this with you. But it is, again, if it's a clinical test and you choose to get it clinically, there can be an associated fee with it. Again, most of that is associated or is covered by insurance. These days, as I told you, genetic testing has decreased in price substantially, and most of that type of testing, if you were going to pay out of pocket, is generally between 200 to 250 US dollars. So again, it is available if you are interested to participate or obtain your genetic risk. And so with that, I certainly thank you for your time, your efforts, and your attention. And hopefully you find this valuable. And I have made you a believer that germline genetic testing is an important tool that should be implemented as routine practice along that prostate cancer journey. So thank you guys very much.
And there it is. The great Dr. Helfand giving a Helfand of a talk. How do you like that?
That is something. I haven't heard that since grade school, I think, maybe.
Really? You went to grade school with some very smart people. It was an excellent talk. So people understand. I've seen Dr. Helfand talk many times. Here comes the quick ego boost. There are very few people we want globally to give this talk more than him. This is what he does. He's out there. He does the meetings. He publishes. He works with a lot of advocacy groups. But so when we thought we need someone just to explain some genetics, we immediately thought of him. And unfortunately, he gave me his cell phone. And I called in on a whim when we tried to add the subject at the 9th hour, and he graciously agreed. But I don't want to go through your CV too much because that's already on the website. But when it says North Shore University Health System in Evanston, I thought of something interesting. So if it's North Shore Urology, is that in Hawaii, right? Are you a bunch of surfing urologists? So tell us about North Shore and what it's affiliated with, because even though it's in the booklet and I know, I'm not so sure the audience knows. Is it in Hawaii?
I wish it was in Hawaii. Our weather is not quite that good, although with global warming, it's getting better and better. We are on the North Shore of Chicago. We actually sit on Northwestern University's undergraduate campus. It actually is the oldest hospital in the Chicagoland area.
Wow.
We've had a lot of kind of weird breakthroughs through the years that have been at least initiated here in terms of a lot of like pertussis vaccine. And I think that was the kind of start of fame. And although it was years ahead of my time, a lot of even the initial genetic studies started here as well. We were actually the original Northwestern Hospital. We used to be part and associated with Northwestern, and then now about 13, 14 years ago, we separated ways and are part of University of Chicago. So that's the politics of Chicago, that everyone's kind of mixed and hybrid. And the nice thing is we're all friends, and we just call each other different names based on the time of year and day and who we're associated with.
Yeah, but you're the endowed chair of urology there, correct?
Correct.
But really, you also are the director of this clinical research in the program for personalized cancer care. So you wear that hat too. You wear a lot of hats besides being, your bio is interesting because when I read it, it says internationally known. And between me and you, and a lot of doctors say internationally known, no one's heard of them. But you're different, right? You do all the meetings. You do all the publications. So this is a real treat for everyone. What I didn't know about you, and I thought we would share this a lot, is, I was probably this close away from getting a PhD in pathology, and I went, that's okay. I don't want to do it. You ended up doing two things I would want to do if I could come back in another life, but I couldn't do it because I was too wimpy. The first one is you finished a PhD in cell and molecular biology and genetics from Northwestern. Dear Lord, that's got nerd written all over it. That's beautiful. I love that. And so you really, this was what you studied going before you went into practice and all that, right?
It was actually, everything was very fortuitous. And I initially ended up, if you want to really unveil the curtains here, I did a lot of research when I was an undergraduate at Emory University. And a lot of that was because I was trying to help pay for college. And then the opportunity to use that and join a medical scientist training program where they paid actually for medical school became very attractive to me. So unlike a lot of my colleagues, I don't have that debt or never had that debt. And so I then use that as an opportunity to really get involved in research. And one of the cool parts of a lab I joined was that I had the opportunity to go out to Woods Hole, Massachusetts every year and study things like squid axons and genetics and all that kind of stuff there. So it allowed me to travel and do really cool things. But really, I was getting, as you said, kind of nerded out by all of the stuff that was really just kind of coming of being. So a lot of that genetic technologies and stuff were really just starting. And as I ultimately then started my endeavor in urology, I was introduced to Bill Catalona, so considered one of the grandfathers, if you will, of prostate surgery. And he looked at me and said, "Oh, you do genetics. Do I have projects for you?" So that's really, and I thank him and just a lot of good opportunity that he got me involved very early on with a lot of these groups.
That's awesome. The other thing you did that I wasn't able to accomplish is I applied to Emory University for college and I was waitlisted. And when I did the interview there, it was the most classic bumbling of an interview I've ever had in my life. The person interviewing me, who was in the administration, this is a true story, said, "Well, why do you want to come here?" And I said, "Well, partly I want to play college basketball because I played in high school and I was pretty good." And I didn't realize at the time when I'm doing the interview that they didn't have a college basketball team. So she informed me that they didn't during the interview, and I thought, "Oh, geez, I don't know if I'm going to get in here now."
You could have been the original, the OG.
I could have been the Shaquille O'Neal of Emory University, or the Kobe, or I don't know. I could have been somebody. All right, and you didn't see this. The last part of your bio says his best friend in 2024 is Mark Moyad. I threw that in there, by the way. I thought you might.
That is true.
All right. Thank you. I got a couple of genetics jokes, and then we're really going to hit it hard and see if I can put my head around this really tough topic, okay? All right, so I thought I'd come up with some genetics jokes and see how you would rate them on a scale of 1 to 10, 10 being the best ever, 1, it sucks, get away from me. Why did one DNA strand get mad at the other one? Because he claimed he was being copied.
Oh, that's a good one, actually.
Thank you. What did one DNA strand say to the other? "You complete me." What did one DNA strand say to the others? "Do these genes make me look fat?" What does Dr. Helfand?
Can you say that you used to write for Hallmark?
I don't. It doesn't matter.
I like these.
It doesn't matter. All it takes is one laugh, and I'm encouraged. What does Dr. Helfand and his team look? Why? Sorry. See, you could tell I just worked on these. Why does Dr. Helfand and his team look forward to casual Fridays? Because they're allowed to wear jeans at work.
Oh, jeez.
Or to work. Sorry. These are the best I can come up with. And then what do you call a genetically engineered cow? A mutant. I'll be here all week. Don't forget to tip your wait staff. All right. Last important point, most important point, to get to know Dr. Helfand before we get into the weeds. He wanted to go to Michigan. Remember that. He told me it secretly, so now it's out in the public. Yay or nay, Dr. Helfand, you actually wanted to go to the University of Michigan, the national football champions of 2023-24.
You know what? I have a very soft part in my heart for Michigan. I always will. There we go. That's what I was hoping for one day. So much of my family has gone to Michigan, but when it came down to deciding, somehow my parents said that I would have to go to our local state school, which is just, and kudos to University of Illinois. I love them, but it they dissuaded me because of financial reasons more than anything else from Michigan. But Emory was great as well. But yes, I have a very strong fondness for Michigan.
Okay, we got through 6-7 minutes without not even talking about genetics. So now we're going to buckle up. I got my green tea with L-theanine, which is sort of a relaxant, it's a stress-free hormone. Actually, it's an amino acid. And now we're going to talk about genetics. Ugh, is what I say. All right. Are you ready for my first question?
I'm ready. Bracing myself after those jokes.
I don't joke. I know you'd give them 10 if you had a chance to give them 10.
For sure.
Let's go through the basics again of your talk. See, this is where people get confused, including healthcare professionals. There's two types of genetic testing. Germline, which is what we focused on today, and then people get it confused with somatic. And can you walk us through that again? Because you said this in a talk that I went to. You go, look, germline are the genes you were born with. You had them on the day that you were a baby when you had those, and you have them the rest of your life. Somatic is what your tumor itself is showing. So somatic is reflection of the tumor, and germline is what you were born with, and you're going to continue to have your entire life from birth to death. Do you want to expand on that, or am I get that right?
I think it becomes confusing because every cell in your body starts off with normal germline DNA. That's what we're born with. That's what we pass along. That's what we inherited. That is you from the time you're born to the time you die. A tumor only changes. It takes your germline DNA, and there are changes that happen to that because of it's a tumor, and it accumulates that damage in the DNA, and that is just locally grows, but that's not passed on. So that's the biggest difference, is you cannot pass on your tumor DNA.
Ha. This is why we got a bunch of questions and people get confused. So germline is what you're stuck with the rest of your life, like it or not, and you could pass that on. Somatic is what the tumor is showing. You don't pass that on. I mean, theoretically, sometimes things could pop up, but you don't pass it on, right? So here's what I'm going to jump ahead and then come back, and you're going to see this is all over the place. But I took some of the questions that I get from doctors, healthcare professionals, and what we got at PCRI. Okay, so let's just play this game for a second. I'm going to jump ahead. Someone goes out and has advanced disease, okay? They have a BRCA2 mutations found on a somatic test. So you talked about germline. Does the family need to be tested? Brian, I can't tell you how many calls that we've received that actually this question came in. In other words, somebody with advanced prostate cancer came up positive on a somatic BRCA2. And then the family member is like, oh my God, I got to get with a genetic counselor. I got to get tested. My germline has to be tested. Do you want to comment on that?
I do, actually, because it's a sensitive subject for two reasons. Number one, just to rephrase the question to make sure everyone understands it, is I have a prostate tumor, and we biopsied that tumor, and we found that there was a BRCA2 mutation in that tumor.
Yes.
And the reason why that's sensitive from a testing standpoint is that not every single company tests the germline automatically. So meaning that if you think about BRCA2 mutations in a tumor, that can happen one of two ways. That can happen because a patient who is born with the BRCA2 mutation, and it's in every single one of his cells, forms a tumor because we know that they're more likely, and then that exacerbates it, so we detect it in that tumor. Or it could be a spontaneous, if you will, type of mutation, meaning, as I used, because I think it's easy to understand, is the patient is outside in the sun hits an area of the skin, that area of the skin forms a melanoma, and that melanoma has a new mutation in a mutation in BRCA2 that's not in every single cell, so it's only in that melanoma tumor. So it's important that if you find a somatic mutation, that patient is also tested in their blood, their germline, right? So take a tissue type that it doesn't have cancer, test that, make sure that it's not a germline mutation. If it is a germline mutation, then the answer is yes. Not only does that have implications for that patient, but it also has implications potentially for their family members if they also have that type of mutation. But if it's only just in the tumor, then it doesn't. So the reason why I think it's sensitive is a lot of companies don't offer that germline reflexive testing. And why the harm of that is really, again, we obviously care and focus in on the patient, and the patient is fine in getting treatment just based on understanding that somatic. But I think it's important to understand the whole patient, including their family.
Yeah.
So we don't want to miss that opportunity, because if those patients' family members are at increased risk, it will certainly help screen them so they don't end up in a similar type of spot.
So just because I have a BRCA2 on my tissue or my somatic test, it doesn't mean I'm going to have it in my germline. And the only way it means that is what you're saying, if you test germline, which now brings up the next incredible question that I want you to answer, because again, we talk about advanced disease right now for a second before we go back to the rest of your talk. I just want to get these out of the way. These are important. So now let's say you find a BRCA2 on your somatic test, right? Should you then just go ahead and do a germline anyway? In other words, think about the ramifications of this question. And this is why I just get so excited about this geeky stuff that you get excited about. Everybody's running around in advanced disease, right? And this is going to apply earlier. They're getting a somatic test. They're being tested on their tumor for BRCA, Hawks. It doesn't matter, any of these mutations. Should they just keep sticking with the somatic, or should everybody also get a germline test who has advanced disease? In other words, should they always request both? Because the doctor is more than likely going to request the somatic. Wouldn't you agree? Probably. What do we do with the germline test on an advanced person?
This is really what motivates the drug industry, right? Is because if you have a somatic test, it's going to, somatic mutation, I should say, and it comes up BRCA2. And number one, it can change throughout time. It can vary. You may not have one, you may form one, depends on, as that tumor progresses, depends on what we expose that tumor to, hormone therapy, chemotherapy. Your mutational landscape will actually change over time. So it's not inappropriate to test somatically the tumor, whether it's in the tumor itself or in circulating tumor cells throughout the blood, et cetera, periodically as that disease state changes. But at some point, because all of those patients qualify, and certainly I say qualify because it's covered by insurance, that they should be tested for their germline tumor, again, because it has implications, certainly for the patient, but also their family members. Again, it's that holistic care of the patient that we're really concerned about.
Let me repeat that for the audience. Anyone who's being tested with a somatic test, generally speaking, you are a fan of, at least at some point, since it's a one and done test for the most part, they should also get a germline test. That's what you're saying?
That's what I'm saying.
Thank you. All right, that makes me happy. I'm not just saying my opinion-wise, that makes me happy, because a lot of people have to understand the difference, and you can get multiple somatic tests over time. But just getting that one germline, why not just get it? And I think that comes down to advocacy. I think a lot of people don't get a germline test because they aren't able to advocate for themselves. It's not offered. I don't know. Am I causing controversy? Are you?
No, I think it's a moving target. And I think, unfortunately, again, a lot of this has been based upon insurance rules, right? Only certain populations considered high risk based on family history. And I already think I said is that there are limitations to that. And actually, just to add in, 60% of patients who don't meet criteria will actually harbor a mutation. So it is.
Can you repeat that statistic? Because this is what I learned too this past week. I don't know if we're talking about like the impact study or some study out there, but will you repeat what you just said? Because this is mind-blowing. 60% of patients
who don't meet insurance criteria based on family history will actually harbor a mutation.
What the Helfand?
That's
I
what
mean,
I love
come
it. I love it.
on.
It's a verb now too. I love it.
I know, right? I mean, this is okay. This is really good. I'm sorry. Were you going to say more about that? Because I'm so tired of people not mentioning that. They make it sound like if you have family history, oh, if we can figure it out, then we can, you know, I can't tell you how many times they'll say, well, there's not a family history there. So then why do the test? Because 60%. In other words, it's an imperfect system. That's why you ask for the test.
Right. And again, it's when you compare the cost of genetic testing these days to so many other costs out there, it's peanuts. It's peanuts to what we're spending in healthcare. And again, if you get these tests, and because they're multi-gene panel, et cetera, you can get them early on. And hopefully, I've convinced some people out there that that information can be used upfront before you even have any type of tumor to really help guide your screening in a more precise fashion. Again, it's just a quantified, like a test that we can use to really assess your risk of disease.
Insurance not going to cover it. People don't want to cover it. Let's just say, how much are they going to charge me if I just want a germline test? Do you think, ballpark?
In the US, almost every single genetic testing company that I know of, again, these are DNA-based tests,
Yeah,
are offered. Most of them have a deal, and I think they've competed with themselves that it's $249 or less. That's almost uniform across the board if you paid out of pocket. Now, again, for those patients who meet criteria for genetic testing, that's almost always covered.
$249. Look, I understand the expenses, but some people go out to dinner and spend $249. So I don't work with any of these companies, but I'm just telling you, we're going to get back to this controversy, which shouldn't be a controversy. Okay, now I can breathe a little bit more. I just want to focus in on something you talked about a lot. Then I want to leave it again and then go back to the sort of some of these main mutations that people are familiar with. You talked about genetic risk score and polygenic risk score, right? But so here's what I'm thinking of, because these are germline. When would I know to even get these? Because when people think of genetics, they think of BRCA2, they think of ATM, they think of BRCA1. They don't think of genetic risk scores and polygenic risk scores. Are these ready for prime time yet? And are they ready for prime time? I'd like to know a little about the costs. And then I'm going to tell you what your critics are going to say against you after you tell me about who gets it, who's watching. Do I actually ask for this? Any guide there?
Right. So even though they're well studied, okay, and just as a comparison, before we go into any details here, is that when we talk about rare pathogenic mutations, and those are in, again, genes like BRCA1, BRCA2, they're rare, right? And so when we look at the incidence of these mutations in the overall population, if you look at a whole group of them, less than 3% of the population will have any of these. That's a whole panel, right? So if you look at an individual BRCA2, it's about 0.2%, right? So it's a very low risk of having these mutations. And even though they're so low risk, that makes them really hard to study, right? So it's taken us years to accumulate enough patients with these mutations to ultimately get a story out of them. And even then, we group all BRCA2 mutations together, right? Because you can have a whole gene and you can have a mutation in one spot and someone with a mutation in another. And we say, everyone has a mutation, but we really don't know if they're really the same. But they're so rare, it's hard to make that conclusion. And so, but somehow, and a lot of this is because of the influence of pharmaceuticals and the money there, we just accept this as fact, and everyone should be tested for these because of the clinical implications, which I'm not opposed to. But then we take something like polygenic risk score, which has not only been studied for a long time, but has been validated in countless numbers of populations, in countless number of patients with diseases, without diseases, but we're a little bit more reticent to bring it in. And that's because it really doesn't follow what we call Mendelian genetics. So Mendelian inheritance, when you have 2 copies of a gene, 50% of the time you get one gene, it goes to, one offspring, 50% goes out. That's what we're used to doing. And that's what genetic counselors and genetic medicine physicians are really used to talking about and counseling about, et cetera. Polygenic risk scores kind of take that and explode, right? It says, hey, the average person like myself who doesn't really know that much, I can use that because I know in medicine how to use odds ratios. I know it says, hey, this is high risk and low risk. And that's how we're really used to making decisions. It hasn't been implemented because it hasn't necessarily received that support from a lot of the groups because it's controlled a lot by medical genetics. They're starting to understand, and certainly the more progressive ones are the importance of them, because there's a whole another side to this, is that, as I said, is that certain genes like BRCA2 increase your risk of pancreatic cancer, increase your risk of melanoma, prostate cancer, yada, yada. And so if you have a high polygenic risk score for breast cancer and a low one for prostate cancer, you're more likely to develop, if you have a BRCA2, breast cancer than prostate in that. So it actually can modify the BRCA2 effect. So there's so many uses of it that I think we're just starting to see the implementation of the polygenic risk scores.
Well, then are you recommending people that are watching this dealing with prostate cancer, they don't go in and ask about a polygenic risk score to add to their prognosis? They just kind of are waiting to see how this is going to play out. This is just what's coming next. How would you have the audience look at this?
So I'm biased. I'm totally biased because I do this type of testing all the time. And, to be frank, in the setting of screening, in the setting of newly diagnosed patients, while I get so excited, which sounds really, talk about nerd, so excited when I see a patient with a rare pathogenic mutation, it's the polygenic risk score that affects my practice and affects patient behaviors, if you will, more frequently than the rare pathogenic mutations, because it just there's a lot of higher risk patients we identify.
These are the patients coming in for screening. They haven't been diagnosed yet. Or are you saying you're using this PRS, polygenic risk score, even right after they're diagnosed, to give you some more information?
Just information about why they may have formed it, and even more in unaffected men who, kind of present to the clinic and are asking, saying, hey, should I get a biopsy? Should I not? We do know, again, that the polygenic risk score, it stratifies your PSA value. So if you have an elevated PSA and an elevated genetic risk score, the patient with an elevated genetic risk score is going to be more likely to harbor prostate cancer on a biopsy than those without it. So it is one of those where it helps stratify my decision making.
It does, but it sounds like it really helps you right now in terms of deciding whether or not to biopsy, whether or not you think someone might have cancer. But it's not so much used right now after the diagnosis or someone with advanced disease. Is that fair?
That is fair. It's really that upfront. And then as we talked about, the rare pathogenic mutations become more and more important as the journey progresses.
Yeah. Well, can I tell you what people say about you behind your back?
Totally.
Okay.
There's a lot of...
Not you specifically. It's what the literature says about these polygenic risk scores, because they're exciting, because you've taught me about these SNPs, these single nucleotide polymorphisms. So even though I called it a mutation, it's a tiny type of DNA variant. I think I like the word you said. And ultimately it's a fingerprint, right? It's something that's going to give you more information in the future. And that's exciting. What the critics are saying about using all these risk scores right now is they're saying, look, it's not showing us whether or not someone could possibly die from prostate cancer, is going to get aggressive disease or have lethal prostate cancer. So it's just telling us who might get prostate cancer, which is just a lot of people. It's not telling us the significant prostate tumors or whose life might be threatened. So it's not really being that helpful. That's what your critics say. And what do you say?
Again, I think the holy grail in prostate cancer and prostate cancer screening is identify those patients who are most at risk of dying from prostate cancer. That's where
Right.
we're going to get it. Unfortunately, I personally believe that holy grail doesn't exist. And the reason why, and again, I'm just a skeptic, is that the tumor changes throughout time, right? Or you can have a new tumor develop that is more aggressive. It's a multifocal cancer. Each cancer has its own ability to have its own aggressive potential or not potential. And certainly where we pick patients up in the screening process really confounds our interpretation, right? Because we thought at one point that if you had a family history of prostate cancer, that predisposed to aggressive disease. And it turned out that actually, if you have that family history, you're more likely to have a lower risk type tumor because we're over screening you. So screening influences that kind of path. So I think really the purpose is to really narrow down our screening pool. Meaning if you don't have no information on patients and you say, well, or even just family history, you're going to say, well, if we take the whole circle, we'll be able to take about 7% of that population, focus our screening there. Even though others are at risk, is that really informative? Probably not. But if we add polygenic risk score, that's going to focus our spotlight, our flashlight on a patient population that's most likely to get prostate cancer. And we can focus and identify our winners early on so that they don't develop those metastatic tumors.
Are you using polygenic risk score right now for your active surveillance patients?
They do all get it.
They do all get it. Okay.
That's the research protocol. So those patients all don't know we do, but they don't know it. We don't know it from behind the scenes, but it has some utility there. And again, we have certain trials in focal therapy saying, hey, are you a really good candidate? If you have a high polygenic risk score, are you likely to have a recurrence in field pretty quickly?
Okay, let's talk about let's talk about things around diagnosis and early stage disease and just cover this is going to be just all over the place. You more than anybody made me feel good about me because I have argued at some of these meetings, but I think you argue it more eloquently and you argue it with more data that what does family history really mean? I think somebody could give an entire lecture on the fact that in prostate cancer, you can chuck a lot of family history out the window that we're not really sure what we're doing or people know what they're doing. So before you answer the question, the reason why I thought family history was so strange is that every time you talk to a practitioner or a patient, their definition was varied. There was no standard definition. Was it the number of prostate cancers in your family? A lot of people think that's it. Or how about, is it the number just of aggressive prostate cancers, or the ones that had prostate cancer early at an earlier age? Some people believe it has nothing to do with any of that. It's just the total. Like in my family, we got a ton of cancer of every type. Does that mean I have a strong family history? Every one of these scenarios and more, to me, in my career, has been defined as a significant family history. And that means to me, we don't really know what we're doing when it comes to family history. What is a family history to you?
You know, and it's changed because I think, like most urologists, I think we're from the start, when we talk about prostate cancer and we talk about seeing a patient in clinic, we always say, well, do you have a family history of prostate cancer? Yes, no, I don't know. I don't talk to my family about that. My father had some procedure on his prostate. I don't know what that was. So that's what we were based on. And the truth is, it's not that it wasn't somewhat informative. It just was only a small sliver of the pie. And so ultimately, what excites me more these days, and it's because of the association with finding a rare pathogenic mutation, is it's not just prostate cancer. It's those families that actually almost sometimes have very little prostate cancers, but they have other cancers, glioblastoma, pancreatic, breast cancer, and all of that stuff, lymphomas. Those are all more likely to harbor those mutations. So that I get more excited when I see an extended family history. Now, when I talk to a lot of clinicians, they say, Brian, That's great. You're, what are you, making a pedigree in your office? I mean, are you calculating this? No, I don't. We do have programs built into our system that if we want to do that family history pedigree, we can. I'm not a genetic counselor. I do nerd out by looking at a lot of that. But on the other hand I think just having a list of 5 or 6 cancers, I always run through and say, well, do you have a family history of cancer? That includes, do you have a family history of breast, ovarian, colorectal, pancreatic, endometrial, melanoma? That takes me literally a nanosecond to reel off, but it at least spurs that patient on to start recalling and saying, well, that person had this. So you're recording that. Now, I also record age of diagnosis of those cancers. Yeah, my sister had breast cancer. It was age 45. Did she die from it? She went on, unfortunately, to die from it. So that I also record. Again, that whole type of history doesn't take very long to do, but it is very informative of who's more likely to have that. On the other hand, is what I think is that this blows it all out of the water and saying, you know what, I don't have time to do it. I don't want to. Just get that test. It'll be a lot more informative up front because it serves as a quantified family history. And that's really a polygenic risk score. It's a quantified number that tells me what is your risk of prostate cancer that I care about.
To me, you're saying that all of this, maybe why people haven't done a great job is because all of this actually makes a difference. The number of prostate cancers, the age at which they were diagnosed, whether or not they were aggressive, what age, like I mentioned, age, total number of it seems what you said in your answer is that because all of this matters, so why don't we just get a test?
Correct. Right. And you're barely, all those words barely fit on a page, right? There's a lot of things that matters there. So when you talk about time constraints in clinic and you want to get that information, a lot of practitioners get nervous of saying like, hey, I just don't have time for all of that stuff. So this is what can easily replace it, and I think is a lot more accurate.
Yeah, I wish the questionnaire said that. Number of total cancers, age at which diagnosed, did anyone die of those cancers? What about these other specific? Oh man, that would be a great one-pager. And that's why, you made me think about that. Maybe that's why family histories become so difficult. So again, can you remind me that even if you do a family history, the vast majority of men who come up BRCA, for example, positive, don't necessarily fit in that family history is what I think you said.
60%. So that's where there's been a call to our guideline committees to say, maybe we need to be more inclusive. Maybe we shouldn't be so restrictive as these insurance companies continue to try to hunker down and limit it. We said, this is not a place that you should be limiting.
Okay. So then that takes me to active surveillance. All right. I want to set this up, just give you some context. When we were doing the big national meeting and we're doing it again in the fall, it was probably 3 or 4 years ago. We would say, well, why doesn't everybody with advanced disease, maybe longer, maybe 5, 6, why doesn't everyone with advanced disease just get genetic testing, somatic, germline, what we talked about? And then it came, right? Now that's a part of guidelines. Okay. Everything you said, everything I said brings up this question, and I'm still shocked by some answers. Active surveillance. Why? No, and this is an honest question. Why isn't every man tested for BRCA or just get some type of germline test? I put family history as a wimpy guide. I didn't mean to do that. Anyway, I forgot I put that in there. Anyway, but this is the $1 million question of part of your lecture. Active surveillance. Why isn't every man tested for BRCA? Because my understanding is, and you can give us some background to all this, in preliminary research, men who are BRCA positive and have some other types of mutations are much more likely to come off of it because they have a more aggressive type of disease. Their disease is more likely to progress. And these are people that might not be good active surveillance patients. So again, my question is, can you give us some background? Why isn't it standard of care today that everyone on active surveillance, if you want to be on it and stay on it, you've got to be genetically tested?
It's a variable that you can definitely factor in. This comes a little bit to yield, right? Is that and I'm playing a little bit double sides of the coin here, is that, on one hand, I believe everyone should just have genetic testing up front and we'd have that answer going in, so it really wouldn't be an issue. But under the current guidelines and when you look at everything is that the frequency of genetic mutations increases in proportion to Gleason score and stage. Okay. So you're going to have ultimately higher numbers of patients who have mutations with higher Gleason scores than lower. It's not foolproof by any means. And you can certainly see patients at lower risk. So right now we're still restricted based on family history guidelines in terms of that. But I do think that if you identify those patients, and again, they're rare. So in the active surveillance, which is it's a little bit more similar to the general population, really less than 2 to 3% of those patients will harbor those mutations, that they say, hey, that's not a high yield patient population to look at. Although we do know that if you are one of those patients who has those mutations, the chance of you progressing, failing active surveillance is a lot higher. And again, it's not one of those where you go from like a low risk grade group 1 to grade group 2. You generally go from a grade group 1 to a 3, 4, or 5.
Okay. So what you're saying is it is true right now. It's not called for yet in guidelines to test active surveillance patients with a germline test to see what's going on. But in studies thus far, it has been a predictor of who might not want to stay on active surveillance. Potentially, it's not solid data. So again, I go back to the question, do you test all of your active surveillance patients with germline testing, or are you waiting to get more data?
I offer it to every single patient.
You offer it to everyone.
I offer it to every patient with an explanation of, if it's not covered, you may be responsible for a $249 bill. Again, that doesn't have to be decided at the visit. They can talk about it with the company, the genetic counselor, et cetera. But that's why I explain the utility of it. Is it may explain why you have prostate cancer. It may influence how we treat you.
Okay, so at least you offer it to everybody on active surveillance. I have one place in your entire talk that I'm totally biased. I don't understand it. We have a genetic test. It's a germline test. It's $250. We have all this criteria of what it takes to be on active surveillance. Patients go through a lot of criteria to be on active surveillance. Not everybody agrees on that criteria. Why part of that criteria is not to universally offer germline testing? Nobody's ever going to convince me, I'm sorry to say, as to why everyone's not getting it if they want to be on active surveillance. Look, if your germline testing says you have this variant, BRCA2, and you still want to be on it and someone wants to follow you, great. But at least you have that extra knowledge. I thought that's what active surveillance was about. PSA density, getting the volume, PSA kinetics, doing some genetics. I thought all of this was about more information and then making the right decision. So I don't know if you have one more word. I just will never understand why everyone in active surveillance isn't getting it. That's all I have to say.
So I'm an information geek. So the more information, the merrier, because I think that makes decision-making better. I think the more knowledge you have, the more powerful and informative your decisions are. So right. I, again, recognize that, there's a balance, and we certainly have to recognize that the national healthcare crisis and the cost. I get that, but we're still talking about relatively a very cheap test to help us make decisions.
So if I've got a small segment of Gleason 4, because now these intermediate guys on active surveillance, they got these small percentage of Gleason 4. Oh, yay, I can be on active surveillance. Good for you. That's great. Isn't that person more likely to have something show up on a genetic test?
So that risk goes to about 4 to 5% of the population, so higher.
Yes.
Once you get to higher volume Gleason 7, or certainly 4+3, that goes to just under, at least in our series, about 10 to 12%. So again, it increases. So, and again, if you're one of those, it's very impactful. But certainly, I think most people would say, well, I don't. 3+4, it's a gray zone area anyway. So if you have a piece of data showing that those people are really a lot more likely to progress, that's going to push you over. That's going to tip you to say, let's not monkey around here.
What if I have some of these different types of variants in the pathology? I have intraductal, I have cribriform pattern, large type. These are more likely to have a variant that would show up on a germline test, right?
Yeah, so it's also a moving target because it's called a lot more by the pathologists these days. But
Yeah.
intraductal is still, or at least at one point, was part of the guidelines to consider testing because there was a higher number of patients in 2 studies out of the West Coast showing that there increased likelihood of a BRCA type mutation. The other warning I'll say is anecdotally, but supported by some of the evidence from in the literature, that a lot of these patients, while we always think that prostate cancer is the snail, the slow growing one, we always have a huge amount of lead time. We still have lead time, but if you harbor one of these type of mutations, specifically in one of those 5 genes I talked about, the chance of you going from 0 to 60 without a lot of signal or change in your PSA or ancillary type test is high. So a lot of changes happen kind of underneath the cancer, so that when you check it, even a year later, you're like, holy cow, we missed something here. And that's where I've, again, try not to use anecdotal data, but that's where I've been burned several times, or again, without that knowledge initially, that those mutation patients are a little bit more sensitive.
Well, if active surveillance was 100% accurate, if surgery was 100% accurate, radiation, focal therapy was, we didn't have, you can always work on the recurrence rates to lower those recurrence rates. Well, maybe one of the ways you lower the recurrence rates is you catch the disease truly earlier or figure out which one's aggressive, which takes it back to germline testing. So I appreciate this today, Brian. I went from 99.999 repeating that everyone should get a germline test when they're diagnosed to 100% thanks to you, even though I know that was not your intention. Now let me bring up the NCC, the big guidelines. And look, this is a respectable group. They're an incredible group. No one's not saying that they're not an authoritative group. They're saying, tell me which ones, if anything's changed. They're saying you should get germline testing if you have a personal history of aggressive prostate cancer, a family history. I think that's my favorite. Intermediate risk, so you have intraductal or cribriform, a history of cancer. And then they put, so even if you get a germline, you should get at least all of these tested. Do you agree? So this is the latest list. BRCA1, 2, HOXB13, which is specific to prostate, like you said, ATM. Is this list, are we adding to this list, or should there be more on this list? What do you think?
Again, it depends on the setting. And that's what my big problem with NCCN for this recommendations are. It's taking a huge panel and narrowing it down to 11 to 14 genes. Not all of them are implicated in prostate cancer susceptibility. Not all of them are implicated in forming aggressive tumors. And HOXB13 doesn't form aggressive prostate cancer. It forms prostate tumors, including aggressive forms, but doesn't differentiate. So it is one of those, we have to understand what we're doing. And when we move into the advanced setting, and we're now starting to look and say, well, do you pair up with a chemotherapy? Why do we want such a small panel? What, don't we want the 150 genes that are included in the DNA repair, gene panel? Isn't that more appropriate to look at? So that's really where I advocate to say, we don't want to share all the information at once because it gets confusing, and I understand that. On the other hand, is having that in our locker and saying, hey, at some point, if you become metastatic and we start needing these chemotherapies, why don't we call up that list and say, hey, what do you match up with? Because it's not going to change. It's germline, and we have that now ability, and that makes it a little bit more systematic.
A couple other things on this topic, and okay, I'm going to put away these NCCN. Not that these guidelines aren't great. It's just that I looked at this recent study. I should have provided the reference. I blew it. Some of these obstacles to genetic testing were cost, but like you said, germline is only running about $250. Lack of genetic counselors. I don't know if you want to comment when I'm done with this. Lack of healthcare professional knowledge and confusion. People admitted that we don't know. We're not Brian Helfand, so we don't know what the Helfand is going on here, So, and then health disparities, race, SES, socioeconomic status. So again, if these are all obstacles to genetic testing, can you please, I don't know if you want to add to it, explain to me why people don't get germline testing?
Right. I mean, I think they're all obstacles, and I think we still have a long way to go. I think we always have to adapt to technologies. We always have to adapt to new information. I do advocate that it's worthwhile for most urologists, treating clinicians, et cetera, familiarize yourself with the basics of genetic testing and what we're really looking for. Yes, certainly, I think we have collaborations with genetic counselors. They're a very, very important part of this whole experience and counseling. And I think we can make it easier on genetic counselors if they are limited in your area by doing some of that initial discussion of saying, what are the risks and benefits of genetic testing? What are we looking for? What are VUS, things like that. But we can start informing patients of the reason, the rationale, the potential harms and benefits of testing ahead of time. Order that genetic test. And certainly if someone comes back positive, those are the patients that you're going to refer over for additional kind of counseling on other non-urologic type of diseases. Because again, I think as a urologist, we're very well positioned to counsel on the implications of these mutations in urology, but all the other things, the screening for melanoma, pancreas, get them over there and they'll kind of sort them out. I do think for the shortage of genetic counselors, a lot of these companies, whether it's Ambry, whether it's GoPath, whether Invitae and other companies kind of to and fro, they do provide genetic counselors as a service that you don't have to pay for. That's part of that genetic counselors. They do have things like bots, so computer generated programs that kind of talk you through a lot of that initial and post testing counseling. So I think that can certainly be overcome, and certainly in the era of telemedicine, all of this can really be done virtually. So it's becoming a lot more prominent. I do think that educating physicians and now patients is, kind of also at the crux, and we shouldn't be intimidated. We shouldn't go to sleep when we hear genetics, but rather embrace it, because I do think that increasingly it's going to become a part of the journey for prostate cancer, but so many other, cardiovascular disease, all that kind of stuff is really going to invoke or at least involve a lot of the genetic testing.
I think it's interesting that we're running around with all these PET CTs and PSMAs and all these different molecules, and they're changing the staging game. We really don't have long-term data on them in terms of how much they're going to change it, but everybody agrees, oh, let's get that done. It's the latest in technology, but we can't come to an agreement on genetics? Anyway, all right.
We all think that we can interpret a picture, right? So when you show an image, you're like, I got it. When you show a piece of data, and a lot of the reports that are generated make it easy to look at and understand the genetics, what to do based on where you are in the prostate cancer journey. But we need to still overcome that.
Thank you, because Brian, genetics is also a picture. It's a piece of the puzzle that adds to your puzzle in general that helps clarify your picture. You need the piece when you need. I'm not even a big fan of aggressive testing in public health, but with genetics and being diagnosed and active surveillance, okay, now I'm going to bring up something. Now we're going to get into the meat and potatoes as we finish it off, okay? Wait, that might not be PC in today's world. We're going to get into the beans and kale. All right, let's get into the beans and kale. See, I'm just the trend center, baby. All right, so I'm going to bring up something that you haven't talked about in your talk, and I understand why you haven't. You've talked about it with doctors, but I want to talk about it to show you again why I believe your talk is so relevant to everybody watching this. Let's talk about a syndrome, which I had no idea until I knew you were speaking, that can occur in every 1 out of 300 people, and that's called Lynch syndrome. Lynch syndrome. So Lynch syndrome is another one of the most common hereditary forms, well, the most common hereditary form of colorectal cancer, I guess. And you can explain it better than I can, but the genetic test that you're calling for can also identify whether or not you may have this Lynch syndrome, which is actually a lot more common than people believe, because we now believe that some people with Lynch syndrome might have a higher risk for prostate cancer and aggressive prostate cancer. And I'm done talking. Tell us about Lynch syndrome.
Right. So again, our knowledge continues to expand. And certainly when we think about the prototypical type genes, everyone says, I know BRCA genes, therefore I know everything. Well, there's a lot more relevant genes in there. And so there's a class of genes known as mismatch repair genes, yada, 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 that again confuses people. Who cares what they are? I do, but it doesn't make a difference. But these are genes like MSH1, MSH2, MSH6, and there's a whole series of those genes. And if you have mutations in those genes, statistically, you're still most likely to develop colon polyps. And the Henry Lynch is the guy who really identified that association between Lynch syndrome and these polyps, and helped really lead to the identification of many of these gene mutations that predispose to it. And so certainly what we've recognized is, hey, a lot of these guys who have colon cancer are also getting prostate cancer, and some of them are even kind of lethal, aggressive forms of it. So we, as well as others throughout the world, did a study of these type of patients. These looked at Lynch syndrome patients. We kind of piggybacked that onto other mutation carriers who had BRCA2, et cetera. So we included them as part of a subset of the study. And we found that men who had mutations in MSH2, MSH6, were significantly more likely to not only develop prostate cancer, but really aggressive tumors. So it is, something that really excites us, because again, it's another, area that we should be screening them differently. But certainly the other exciting part about these is that if you did have a mutation in them, you may be more, and you had advanced prostate cancer, you may be more susceptible to immunotherapies. These are a different category of drug therapies, if you will, immunomodulation, that excite the immune system and help you treat your aggressive prostate tumor. Other part about this is that if you do somatic testing, one of the things that they now look for are something they call MSI, or microsatellite instability. That is also a mumble jumble. But what that is that they can take a tumor and they can look at the length of certain parts of the DNA. And basically, based on that signature, they can call people that are tumors that have a lot of this microsatellite instability, or MSI. They can call them MSI high or MSI low, meaning they have a lot or a little of this type of DNA signature. And if you're MSI high, you have a significantly increased likelihood of harboring one of these mutations. So a lot of them are now, as part of the normal somatic testing, looking for that, and then going back and doing both germline and somatic testing for the other, for these mismatch repair genes.
So I just think it's interesting. The NCA, to all fairness to NCCN, if you look at they're asking you to pick up on some of these Lynch syndrome mutations. So Lynch syndrome is supposed to be a part of everyone's vernacular, but why aren't we talking about it more? So Lynch syndrome, if an active surveillance patient ends up having one of these mutations and has Lynch syndrome, do we know enough now to say maybe you should be treated or not?
It is one of those where it's very rare. Even among the mutations, it's very rare. So it takes a lot of patients to really get the data. In our series that we collaborate again with our institution and Johns Hopkins, it does appear that they may have a higher likelihood of progressing on active surveillance. So again, we put high caution there, but it's going to take years to get enough of those inactive surveillance to actually monitor that. The other caution that I put out, because it is urology, and this is a urology fan base here, is that Lynch syndrome is also highly associated with tumors in the upper tract, so in your kidneys, in the tubes of the kidneys, and bladder. And so again, there's not a formal or recommended screening protocol, but certainly if those patients have blood in the urine, they should definitely take that seriously.
It's incredible to me. If you look at the company you advise for, other companies, and you look at the panel, the prostate panel, everyone's got a prostate panel. It's different between different companies, but some of them are in full agreement. The BRCAs, the ATM, the CHEK2, and the Lynch syndrome stuff. It's like, come on, man, why aren't we? This just goes back to why I can't sleep at night. What kept me out of the good schools is why this just stuff makes me this wacky when I think about this. All right, couple more things before we jump completely and leave. I had to bring this in because I've never asked you this, and I've never seen anyone ask you it. So now I'm going to ask you it, and I want you to tell me if this is right or wrong. Okay. And this goes back to genetics. Do heart-healthy lifestyle changes, the stuff that I advocate, right? Do you believe it delays or eliminates the risk of aggressive prostate cancer? In other words, the million-dollar question that we are not, I think, explaining enough is, what am I doing if I'm taking care of myself and I haven't been diagnosed with aggressive prostate cancer, or even if I have been, is it possible that the lifestyle changes I'm making, dietary changes, exercise, you name it, all the things we love to talk about, can that actually change the expression of some genes? Because in breast cancer, the consensus is it's preliminary, but it does. So can you comment on being really healthy in terms of your lifestyle? Because look at you. When I saw you 2 years ago, you've dropped a little weight. You're working out before you do rounds. I mean, you're looking like you could be an international male model, not a urologist right now. I mean, you're looking really good. You're taking really good care of yourself. But the question doesn't come up enough. If I take care of myself, can I actually change my genes or change the expression of my genes? Or am I stuck with those genes the rest of my life?
That's really the beauty of germline testing. That is the beauty of and nothing is fatalistic. Meaning that just because you are born with a certain genetic load or predisposition to certain things, for many of the diseases that we're testing for, it doesn't mean that you have to get it, or it doesn't mean that if you get it, that it's the end of the world.
Right.
And that's really the point of screening, et cetera. But certainly lifestyle changes and lifestyle modification can exert powerful effects over this, right? So we do know, and Adam Keibel published a study on this out of the Boston system, showing that the polygenic risk score, which we know is associated with increased risk of prostate cancer, men who live healthy lifestyles, who eat heart-healthy diets, who exercise, are at actually a slightly lower risk of being diagnosed with prostate cancer. So that's awesome, right? So if you take, and the only thing you do is change your lifestyle, you can modify what your genes are telling your body to do. So that modification and the influence is awesome and gives us a lot of hope. And that's why we set up screening programs to say, hey, if we know you're genetically at risk, let's be proactive. Let us get you involved in a lot of these programs. If we know that you have a genetic risk of heart disease, and this is now being incorporated into their guidelines, is if you have that genetic risk, go get on a statin, make sure you're getting screened, stay active. So we're trying to prevent that based on what the genes are born. We can't control the genes. That's what makes us all special. But what we can control is the lifestyle that we're kind of given. And as a somewhat parlay of that is that, one of the things I talked about was the effect of hormone therapy. We're giving you a drug that's a modifier, and that's going to increase your risk of osteoporosis, depression, and cardiovascular disease. So in that way, the lifestyle is doing a disservice. But if we're aware that you have that predisposition, we can at least try to counter the effects of the hormone therapy ahead, proactively. And that's really so the environment is very powerful, good or bad.
Well, what I'm seeing in the literature lately, and again, I drink this Kool-Aid, so I want to believe it. I'm seeing in some cases, not all, and maybe even a minority of cases, that at least when you take care of yourself, besides having a better quality of life, the chances of a certain gene being expressed or rearing its ugly head, maybe later on, maybe not at all, increases in your favor, right? It's like androgen deprivation to me when you're doing, and you should let me know before we're done today when you're going to when we're going to be able to test for this on a polygenic risk score in terms of side effects. But, you know, if you're already taking care of yourself and doing everything possible, you would agree that those side effects are much less severe in general when you take care of yourself versus when you don't. But we all want to predict who's got a higher rate of depression on hormone therapy, who's got a higher rate of osteoporosis. So you talked about that at the very end. Is this test ready for prime time? Are we looking at a year or two or what?
No, we can actually get it now. I mean, again, a lot of that polygenic risk scores for these are used for other diseases, right? I mean, for heart health, and our cardiologists order that test now. So it's just using that test in our favor because we are intentionally giving you a lifestyle modification, ADT, hormone therapy, that's inducing that risk. So we want to see who's at risk and use that as a signal to the dumb urologist like myself to say, that person's at risk. We're giving them a drug that's going to increase the likelihood of inciting that bad event. Let's stop it.
People get genetic tests all the time. And we got to admit, one of the problems, besides the cost, is they'll get, and I call this what the hell fan. You mentioned this. They get something that comes out in some kind of words that say gene variation of unknown significance. Not sure what this means. What the hell fan is that? I mean, like, what are you supposed to do with that? Because it's screaming at you on the report. The patient sees it. How what do you tell patients when they get this?
Right. So we don't want to ignore them. And basically what a VUS is, or a variant of unknown significance, is understanding that our DNA and our sequencing is very complex. And there are so many different variations throughout everyone's DNA. Some of them have implications, meaning that if you have that variation or mutation, it causes the disease. And others, we don't really think so, based on where that variation is in a gene, that it's not really predicted to cause a problem. But nonetheless, most people don't have that variation, but does that cause the cancer? Probably not. So when you look statistically, if patients have this kind of unknown variation, we don't think it's a mutation, it's never been reported as a mutation, that ultimately we call it a VUS. And what that is that we look at and we say, well, how many VUSs are actually ever recategorized as pathogenic, meaning that they cause a cancer? Less than 10% of them. So 90+% chance that it's going to be recategorized at some point as benign. But usually when I see a VUS, I counsel patients and I say, hey, there is that possibility you could have that. Right now, we don't think so, and we should not act on it like you have a mutation. We should not act on a VUS like you have a mutation. We can send you over to genetic counseling for further discussion of it. But just so you know, is that there's a 90+% chance it's going to, at some point, the company is going to recontact you and say, you know what, it's benign, don't even think about it, done. I've actually had one ever that's been recategorized as positive. Most of them have been recategorized as negative.
So this is just, they kind of just scream at you, but they don't really have any hoopla behind it. It's just non-actionable. Okay.
They shouldn't get your heart rate going.
Okay, I love that. Here's another one. I'm in the world of OTC. I love, as you know, I love the world of OTC, over-the-counter medicine. I love when more medicines, I don't care, supplements, whatnot, that at least have evidence come and are available and people have control and they can get it if they want. The one thing that's making me nervous, and I don't want to get in trouble here in the OTC world, is there's a lot of testing going on over the counter. I know there's good companies and bad companies. What I don't think, and you have to tell me if I'm wrong, what I'm seeing is if you start doing BRCA and some of these other highly specialized tests over the counter, they'll be looking at maybe a handful or more of variants in BRCA. They won't be looking at the largest number that we have on file right now. In other words, not all BRCA tests are the same, is what I'm seeing. Some are high quality. Like I know that the company that you work with and other companies that you mentioned, they are high quality testing. They're really looking at the latest and greatest variants in BRCA. What worries me in all this talk of genetic testing is some of them over the counter don't have that expansive list. They're not looking at all of that. Can you put that in better words than I can? I think that that is an alarm that should be discussed with all of the audience.
It's not dissimilar to most things we do in medicine, right? I think most things we do in medicine, there's going to be some error. right? It's very rare in genetic testing that is something as a false positive, meaning that we called it a mutation, it's actually not a mutation. Most of the time we see it's something that was called benign that actually is a mutation that was missed. That happens very, very infrequently. There are a lot of public data sets. ClinVar is one of them that most people use, that you can actually check so when a company takes a gene, they sequence it from start to finish. And it lists off, if you will, the address, the sequence of that gene. And if they find a mutation in that, they can check with various public data sets and they say, yes, this is, or it's not. But there's also an art form to it. And there's also other databases they can be checking. And also they can do modeling of that protein based on that. So there's a lot of things that they can be doing behind the scenes. So not all companies are set up to really do that in a high quality fashion. Most companies out there are pretty good. They're pretty good. On the other hand is, yes, there is going to be some variability. I think if you go with some of the kind of more well-known commercial companies, you're never going to go wrong because they are really set up, and they actually are set up to advise on prostate cancer and the implications there versus other cancers, et cetera. But I again, as the cost of sequencing decreases, all these companies are kind of popping up a little bit.
Yeah.
So there should be some caution there, but for the most part, it's not going to be so variable between so many companies. And most of the companies that are offering these type of tests, have some pretty good reliability.
Yeah, this is one of the areas I think patients should go to the doctor they trust and say, hey, what's a company you recommend? Otherwise there's so many,
Right.
And they can say, well, do you have any conflict of interest? But at the same time, why do you think that's a good company? And where do you think I should go? And why do you go there? And I think that they would be happy with the answer, because most of the clinicians out there, I think, want to find the best company for the patients. I mean, okay. Now we're leaving germline testing for good. For the most part, you can take off your seatbelt, and I want to throw in one more controversy. I got this text yesterday from a friend. If I get more of these texts from friends, I could start up a business answering this question. So there are all these somatic, I call them somatic, they're liquid biopsies. And they cost close to $1,000 right now, and you can get them even if you don't have cancer, right? If you don't have cancer, the companies are saying, and some of the well-known companies like I do, they're saying, just give us a couple tubes of blood. We're going to look for fragments of DNA that could come from cancer, and we'll be able to tell you whether or not you got cancer before anybody else can, so you can act on it. So do you want to comment on these? Because I think this is interesting, but it's also scary. Do you want to comment on these new tests available where you can just submit some blood, and then they can look at to see whether or not you have, 20 different types of cancer, and they think they can tell you early? How do you feel about these?
You don't ever want to be falsely assured by these tests, right? Because sometimes, and I've seen this, is people will obtain these tests. They don't have cancer. They had a negative signature. And then several months later, all of a sudden they are diagnosed with cancer. How is that possible? It's possible because tumors can form at various stages. And unless you're repeatedly tested with these, which again is not recommended at this time, although
Right.
that's what they want you to do. That's one. Two is we have to understand that not every cancer is the same. And certainly prostate cancer, as an example, is very, very different than skin cancer or bladder cancer or kidney cancer, et cetera. And behaviorally, the ability of cancer cells not only to spread, but to shed cells and DNA into the bloodstream is also variable based on cancer type. And certain cancers, colon cancer, are potentially a little bit more amendable to tests like that because they do have a lot more DNA that's put into the bloodstream we can test. But things like prostate in general aren't the best at these type of assays. So they do typically offer a prostate test. The actual validity of them is called into question when we've delved into a lot of the signatures that they're looking at. In my opinion, for whatever that's worth, are not always the best, and certainly don't pick up most tumors, and certainly aggressive tumors. just because prostate cancer doesn't shed a lot of that DNA, and the DNA signatures they're looking at aren't the best. So I think it's a moving target. The concept is awesome, right? You can get a blood test, it tells you everything. Hey, I feel assured, I don't. But it always also has to be followed up by other testing. So if you test positive for colon cancer, you're always going to then go and undergo a colonoscopy, because that's the gold standard. And so it's not meant to replace any of it, it's to supplement it. But I don't think, in my, again, opinion here, it's really ready for prime time, and it should be really more in the experimental stage right now.
I appreciate that, because I see also a lot of criticism in the medical journals that one group in the UK said, look, until you can prove that you reduce the risk of dying of that cancer, you could be doing more harm than good. I thought it was, I love the technology. It's incredible how many people now are hearing it. So I got friends from college going, hey, should I get this? Like I said, I got one yesterday, and I thought, I got to ask Brian. So I hate to even bring this up, but artificial intelligence, I mean, I'm not even sure what that means anymore. I mean, people are applying all sorts of definitions. Are you going to see it seems to me that if artificial intelligence is what I think it is, that it's going to have a role in all stages of prostate cancer pretty soon, because it's going to be boop, 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 boop. You type in a bunch of stuff and it outspits your statistics or what your probabilities are. How do you feel about artificial intelligence and prostate cancer? Is it going anywhere?
I love it. Actually, absolutely love it. I think there's a lot of potential, and I really think, number one, it's never going to replace being a physician. It's never going to replace touching a patient. It's never. But what I think it has the ability to do is take a lot of different pieces of data, and that includes genetics, that includes imaging, that includes serum, blood tests. You name it, lifestyle, et cetera. And I think it's going to have the ability to extract even a deeper level, a lot of things that can impact that, kind of outcome of that patient. So it has a better potential to analyze those mixed data sets, right? I think that some of the confusion by a lot of physicians currently are that we're really comfortable if all the arrows point a certain way. The patient has Gleason 8 cancer. They're a BRCA2 mutation carrier. They have MRI that's positive. Hey, that patient needs treatment. There's no question about it. But somehow, when we look and we say, well, we want all that data, but some point a certain way, other point another way. It's not aggressive on my MRI, but it is aggressive on my genetic. How do we reconcile that? That's where AI is going to, I think, help smooth it over, because I think it has the ability to make a little bit decision-making on complex data simpler.
Most important question of the day. Michigan plays Northwestern in football in 2023. This is hypothetical, 100 times. All right, just 100 times in 1 year. Like, this is a realistic question. How many of those games out of 100 does Michigan lose in the past 12 months? They play Northwestern.
No, that's not, it's just not a fair question, because
I put this into artificial intelligence.
It may be there. It may be there. But right now, I would say Michigan's winning every time. But
okay, that's interestingly enough, that's the right answer AI gave me.
But with the new stadium coming at Northwestern, you don't know, right?
I know, but plus, I'd be fair. Northwestern's a geek school, so maybe they're not the greatest athletes, but they end up being all the bosses. I have to answer to Northwestern graduates, they're the smart ones who maybe didn't get invited to the prom, but now they run the show. So cry me a river. Is there a question I did not ask you, which you wish I would have asked you, or anything like that? Anything you can think of?
I think the overwhelming thing I always like to leave people on is, don't get intimidated by genetics. The word turns people off. The concepts are actually quite simple. They'll help identify who your population most likely to experience an outcome is. That's all it's really doing. And so if you just think about it simply, everything else is easy.
Yeah, and remember, just keep like you did a good job. Keep it separate. Germline is what you were born with. First focus in on that. Do you need that test if you are worried about getting prostate cancer or another cancer, or you're in active surveillance, or you were just diagnosed or just treated? First have that discussion about Germline. That was the point of all of this. And the other 2 points I want to make sure is, your last slide had a QR code. Please remind the audience of what they can do with that QR code. And please remind the audience, if they want to come see you, are you still seeing patients? I mean, I know you're seeing patients, but do you have openings? Can people still come see you right now? And what's with the QR code?
Yes, I still see patients. I still see tons of men unaffected and affected with prostate cancer at various aspects, and always happy to, as you can probably tell, talk about genetic testing and its importance. In terms of genetic testing, if you want, again, the QR code leads you to a company that does have polygenic risk scores as part of their testing. It's right now one of the few that specifically have the polygenic risk scores, but also combine that with the rare pathogenic mutations. And again, it's divided into the patient journey. So the report, when they generated it, looks at where that patient is along it, whether it's unaffected, newly diagnosed, metastatic, et cetera, and hopefully explains it in more understandable terms. So again, it's there as an option. There are research opportunities, I think, that are also part of that. And certainly, I think it's kind of a cool test. And I wish I could say that I had stock or benefited in some way. But it is really just was an advisor to help do that really for patients along that journey.
That's awesome. And you and I talked about it. You do a type of BPH procedure that needs to get a little bit more attention in terms of the pros and cons. It's very popular. And you and I will be talking about that next time, and possibly the next conference. Isn't that correct? I'm just putting you on the spot, so you say
there
yes.
we go. Yes, I will be.
Okay. Now we got you a gift, because money's no object of the PCRI when it comes to giving gifts to our best speakers. So if we miss a mortgage, we miss a mortgage. That's the way it goes. So there's a gift arriving at your house today, according to what Alex tells me. So Peter, Alex, can you bring up the gift that is arriving at his house today? It's a cup that says, "I love DNA." I swear that's the truth. You're getting a coffee cup that says, "I love DNA." Now, has anyone ever given you such a gift?
I have not had such a gift. I have not. I have one that says "I love prostates," which is also equally as nerdy, but I love it.
Everyone loves prostates, man. But I love DNA. Good. So that says it's slated to arrive today at your house, Brian. Without sounding like an Oscar speech, that was a powerhouse lecture. It was great Q&A. You're a pleasure to be with. I love the fact that you help explain such a tough topic so easily. And I just appreciate your availability and your kindness. And thanks for doing what you do. I really appreciate it.
Well, thank you and the PCRI. I truly love these things. So hopefully we change some people today.
I think so. At least we got good objective information in there. Thanks again.
Thank you.
Thank you so much, Dr. Helfand, and thank you, Dr. Moyad. That was really helpful. Now, our next speaker is a PCRI alumni. He's been speaking for us for years, and he's Dr. Eugene Kwon, and he's a urologist from Mayo Clinic. He does an incredible job breaking down advanced prostate cancer and what we need to know. And so, in 2021, he launched a series with us that's called the DIY Prostate Cancer Combat Manual, and you can go ahead and check out that playlist on the front of our video channel. You know, it's really important because what he does is he breaks down advanced prostate cancer and talks about options that sometimes a lot of people are not talking about. I would strongly encourage anyone who wants to learn about the treatment of prostate cancer to watch his entire series. Each talk gives practical information on how to handle the disease, options for advanced situations, and hope. Dr. Kwon has spent countless hours developing these talks, and it shows. He has an incredible heart for patients and wants, through this series, to share what he wished every patient knew. So again, you can see that on the front of our YouTube channel. Now today, he's going to be doing a series called Fact or Fiction, where he answers a series of questions that we have, not only from the YouTube channel, but we've had submitted before this conference. And he and Dr. Moyad are going to go through them extensively. We're really focusing on getting your answers and patient empowerment here, and I hope you find this helpful.
I'd like to thank you, Alex, for the wonderful introduction, and I'd like to thank the PCRI, as always, for providing me with the opportunity to speak. It's a great honor and privilege. And I also want to mention, of course, that I don't think that we've would have been this successful were it not for Mark Moyad, who is a phenomenal host for these different presentations. If it weren't for Mark Moyad, I would be extremely boring and unidimensional. So I just wanted to point that out. Before I talk about other things, I would like to kind of let everyone out there know what my motivation for the do-it-yourself or DIY combat manual for prostate cancer is all about. I've been in practice for many years, and I've seen a lot of patients over that period of time. At the present time, obviously, we're seeing somewhere between 6,000 to 7,000 annual visits for our patients. And I've learned a lot of lessons over that period of time. When I first started out, as a physician, I would come crashing into the room and I would have exchanges with the patients, and very often, patients would be very disappointed. They'd say, you didn't spend enough time, you didn't talk about these various things. And I could tell that patients were very upset because when a patient comes to you, they're entrusting that you will spend a lot of time with them. And I think that they feel like you should know that their life hangs in the balance. And they're hoping that you're going to be able to treat their situation with the appropriate amount of seriousness that it really requires. Over the years, I would say certain things and patients would say, I don't understand what that means. I don't understand what that means. What did you mean by that? That sounded very dismissive, so forth and so on. So after doing this for many years, I finally realized that we have to have a better solution. And especially now when patients are going to their physicians don't have time for them. And a lot of physicians say things that they don't explain. I just thought that it was very, 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 very important to fill in all the blanks and try to make it possible for patients to understand what the terminologies are, what the treatments are all about. Um, I basically wanted to answer as many questions as possible by doing this DIY video series. And actually, the source of everything that I provide in these presentations is really generated based on interactions with the patients. I try to remember, patient asked about this and wanted further explanation. So I try to incorporate those into my various presentations. And it's been a real privilege and honor to put these talks together for the PCRI. And I sincerely hope that these presentations are helpful to the patients, because I definitely feel your pain and I feel your struggles and I understand what your concerns are. And I apologize for any times that I have personally come up short as a physician when I interact with my patients. Um, Obviously, the other motivation behind the combat manual is the fact that there's a lot of information out there, and sometimes it's hard to adjudicate what's good information, what's bad information, what's true, what's false, so forth and so on, what's new and what's old. These are all things that, we don't get a chance to explain with our short interactions that occur in the clinic. So the goal of my DIY series is really to provide a 1 or 2 or 3 hour free consultation for any man that is dealing with advanced prostate cancer. I hope that it is useful. It's useful to all of you. And it's been really a lot of fun to put this together for everyone out there. Finally, I just want to say one thing. I have had a number of patients over time that have come to me, and they come to me out of disappointment or anger, sometimes with their local providers. And that has also been a huge inspiration or motivation for me to put together this series. Specifically, the one thing that always really upsets me is when a patient is told that there is no hope, there's no prospect for cure, there's this is all we have to offer, get used to it. Don't expect that we can fix this problem. You only have X number of weeks or days or months to live. That really upsets me a lot of time, especially when I know that there's much more that can be offered. And my analogy is basically related to the last scene of Scent of a Woman, the very famous movie where Al Pacino comes in as Lieutenant Colonel Frank Slade, and he delivers this soliloquy to the Baird School, and basically says that, when you do this kind of thing to this individual, you're essentially executing the soul of that individual. When my patients are told there's no hope, when they're told prematurely that there's no future and that they should be planning on their imminent death or demise, I feel like you're executing the soul of that individual. And until proven otherwise, I do believe that it's very important to shake the bushes and think hard about how to solve the problem. For advanced prostate cancer, there's a lot of solutions. And I feel that it's very important to tell patients that there's a lot of hope, because oftentimes there's a tremendous amount of hope, and there's a tremendous route you can take with the patient that can provide many, many, many years of additional high quality of life. So that's one of my motivations for making these combat manuals. I want to make sure that anyone out there who is sad or worried about their future understands that hope is not lost until you've exhausted all avenues of evaluation and treatment. So I wanted to say that about the videos. And then, of course, these are the videos that we are putting out there. If you scan this code, this little QR code will take you to the combat manual, which is available online through the courtesy of the PCRI. And I just want to say one more thing. The PCRI is a phenomenal organization. I think that the services that it provides by giving these educational conferences and so forth is just simply outstanding. And out of all the activities that I've been involved with that pertain to the practice of medicine or the conduct of high levels of research or so forth, I think for the amount of time I put into PCRI, I think that that's gold. I think it's truly a valuable resource and activity, and I applaud the PCRI for all it does on behalf of its patients. So Dr. Moyad wanted me to pick some favorite slides that I've used in the past, and the ones that I've chosen are the ones that I think patients talk about most of all. One of them is the concept of thinking about prostate cancer as not just one entity, but breaking it into various entities. And when I think about prostate cancer, I always think about it as a spectrum of diseases, and we've created some nomenclature for that spectrum. So when prostate cancer comes back after initial treatment, sometimes it comes back as local disease. Sometimes it comes back as focal disease, which means a couple spots that can be attacked more directly. Local disease typically means the disease is growing back by the roots in the pelvis, so we call that local disease. Zonal disease is a term I made up, and basically that means that the prostate cancer is predominantly coming back in a zone of the body. And by knowing that it's zonal, sometimes you can focus your attack on that zone of the body in order to knock out the prostate cancer. And then finally, diffuse disease is the one that everyone fears and dreads, and that's when the cancer is spread pretty much throughout the body, like little bits of dust or particles throughout the body. So that's one of the slides I think that has been very useful for the patients that have seen the combat manual and for my patients in the clinic when we're talking about how prostate cancer comes back inside the body. Another thing that I haven't talked about, and I'm cheating here, I've just introduced this. Metastatic prostate cancer is also referred to as stage 4 prostate cancer. But what you have to know is that just because someone says stage 4 prostate cancer is there, it doesn't necessarily mean that you have a lot of prostate cancer. So people a lot of times are alarmed when their doctor tells them that they have stage 4 prostate cancer, and they immediately equate that with almost a death sentence. And that's simply not true. And that's something that I want to put to sleep as part of this presentation. When you have metastatic spread prostate cancer, some people call it stage 4, but what you have to remember is even for stage 4 prostate cancer, you can have a little bit, you can have a little more, you can have even a little more than that, and you can have lots. So the guy on the right has lots of stage 4 prostate cancer. The guys over on the left-hand side have very little stage 4 prostate cancer. And that goes back to that original slide, local, focal, zonal, and diffuse. Those are all stage 4 forms of prostate cancer, but they don't denote or point out necessarily a very serious or high volume of prostate cancer that's coming back. Okay? So here's another slide from my previous talks that I think patients have enjoyed. And this really hits a number of points. And the most important point is people think of prostate cancer as all being one cell, and every cell is the same, but that's not true. So the idea that all the prostate cancer cells are identical came from the clonal model of cancer progression that was talked about back in the 90s. And the idea was every time a prostate cancer cell replicates, it makes another prostate cancer cell that's identical. And when it spreads, all of the sites that spreads to, the metastases or the sites of spread, are all composed of identical cells as the original prostate cancer tumor had within. And that's just not true. The reality is that prostate cancer is heterogeneous. And every time a prostate cancer cell replicates, it makes different cells. And every one of those cells can spread and make another batch of different cells. So prostate cancer, by definition, is genetic instability that is going wild, okay? So every time a prostate cancer cell divides, it can make a different cell. And because of that, it's hard to manufacture or create one drug that is going to hit all of these cells. So that is why it's very important to realize that you're not targeting one type of prostate cancer cell when you're treating. You're targeting a multiplicity of cells that are constantly changing. And for that reason, you should generally use either a strategy that's going to address all of those different types of cells, or you're going to use multiple treatments that's going to try to encompass all of those different types of cells. So in our world, one of the things that we've been working on originally was immunotherapy, because immunotherapy really capitalizes on a bunch of different cells that look foreign to the body. And the weirder the cancer gets, the more foreign it looks to the body, and therefore the host immune system can target the cancer eventually. So when you have this level of heterogeneity, the tumor starts to look very foreign to the body, and it increasingly becomes a good candidate for immunotherapeutic treatment. And immunotherapy, of course, means using the immune system to attack the tumor and then kill it off. And as you are familiar, I'm sure there are several forms of immunotherapy that are very effective against other malignancies. Those include the checkpoint inhibitors, such as nivolumab, which is Opdivo, pembrolizumab, which is Keytruda, and ipilimumab, which is Yervoy. Those are all forms of checkpoint inhibitors that are used to treat a lot of other malignancies and that are often useful for prostate cancer, especially in late stages of disease. Dr. Moyad also wanted me to definitely include these slides. These slides are all of the current systemic forms of therapy that are available for treatment of advanced prostate cancer. And I took quite a bit of time to assemble these slides and to make sure that I had on the slides all of the different names of the drugs, because it's quite confusing. It's so confusing, as a matter of fact, that the first time I ever showed these slides to anyone, even our residents in training here at Mayo Clinic said, "Oh, could I have a copy of those slides?" Because there are so many names, there's so many different drugs and compounds out there that's useful to have them all on one slide as a reference. So this is the list of all of the therapies that are now available as of 2024 for the management of advanced prostate cancer, meaning prostate cancer that has spread outside of the prostate into other parts of the body. These are all the systemic treatments that are available, and I won't explain those. Those are all explained in the combat manual presentations I've given previously. These are all the directed forms of therapy that you can use for the treatment of prostate cancer. So a directed form of therapy means that you're targeting a region or a part of the body that has prostate cancer in it. So for instance, if you see prostate cancer that's growing on the bone or in the lungs, you might be able to use some of these different directed therapies to go after that cluster of disease with the intent of wiping out that disease. So believe it or not, we have patients that will have a couple spots in the chest, and our chest surgeon will come along and pluck those out and remove them. Other patients will have a spot on the bone, and sometimes our radiation guys will target that spot on the bone. Other times our cryotherapy guys will stick a needle in that spot on the bone and freeze that area. So those are what we call directed forms of therapy. And increasingly, directed forms of therapy have been demonstrated to be extremely effective and very viable options for treating focal or oligometastatic or even zonal areas of prostate cancer involvement that are identified on a PET scan. Okay? Finally, this slide is basically just our list of how we follow patients. And as I've mentioned in previous talks, I think it's very important not only to concentrate on how you're going to treat the disease, but also to talk about how you're going to follow up. Follow up is the most important. No matter what anyone does to you, you can never be 100% sure that the cancer is gone forever. We have patients that we've treated who come back 25 years later and they have recurrent prostate cancer. So it used to be that, we used to tell patients, oh, you're 5 years and out, you won't have prostate cancer come back. That's old fashioned. That's no longer true. There's no finish line here. The bottom line is once you've been treated for prostate cancer, you probably are going to require some form of follow-up to make sure that the prostate cancer is not coming back. And as I have tried to explain in the past, that follow-up should typically include blood testing for PSA, but also imaging, because not all forms of prostate cancer come back with PSA in the serum. More and more, we're finding in my clinic that many forms of prostate cancer actually come back but do not produce any form of PSA in the bloodstream. So I would say somewhere between 12 to 20% of patients we are seeing will actually have visible cancer on their PET scans with no evidence of rising PSA in the bloodstream. So it is imperative that you use imaging in combination with PSA follow-up at regular intervals to keep track of your status after you've undergone some form of therapy for your advanced prostate cancer. And I think that's all the slides. So hopefully that's a good start to today's discussion.
Dr. Kwon, it's your BFF, your brother from another mother. You know who it is. Your best friend, Dr. Moyad. I'm so glad. I was worried that to the audience, I said, please pick out your 10 or 5 best slides from DIY. And he did that. And that makes me really, really happy. So thank you for doing that. Hey, remember, we were going to, just for the audience sake, we added Dr. Kwon as our extra speaker because anytime Dr. Kwon wants to be a part of the PCRI, you can ask Alex and Peter this and everyone else. We always have to say yes because he's so popular. He's the popular kid in class. So when the popular kid in class wants to be a part of your group, we can never say no. But I said, I know you don't have time this time to do a presentation. And when we talk off hours, because what people don't know about Dr. Kwon is he'll call me all the time at 6:30 or 7, just randomly. And I think he always thinks I'm going to answer the phone, which I actually always do. And we were talking months ago, and we said, why don't we do a segment where we don't have to show slides, but we call it fact or fiction. And then you can answer these facts. There's so much fact or fiction going on in medicine that we decided to put this together for the next hour. So are you ready to play our game called fact or fiction?
I think so.
See, I call it Moyad Kwon. Notice how I put my name first. So it says Moyad and Kwon show called fact or fiction, or we have to admit that sometimes things are a little gray. They're a little bit in between, right? So that's what we're going to play. And so how do we play this? Over the many, many phone calls that I've had with Dr. Kwon at 6:30 in the morning, he's mentioned a lot of things that bug him. And so every time something bothers him, he didn't mention the Burger King thing, but every time something bothers him, I write it down. And I thought, I'm going to make signs for that. So now let's go through the signs that you've never seen that I've created based off of our conversations, because I'm so dedicated to your work and that of the Mayo Clinic. All right. And by the way, thanks for the great introduction early on and your checks in the mail from me for saying those nice things. Thank you. All right. The first one, you were not fair. You touched upon during your talk, but I want you to talk about it again because this is one of the first ones of fact or fiction that made you and I wacky. Here it comes. Stage 4 prostate cancer. And here's the words that you hear often on the internet, or you'll hear it right from patients, that somebody told me to put my affairs in order, meaning it's toward end of life. You've got to put your affairs in order because you are stage 4. So fact or fiction, if someone says I'm stage 4, do I have to put my affairs in order?
And that obviously is the whole reason my clinic exists. So if you have stage 4 prostate cancer, it does not mean necessarily that you're incurable. It doesn't necessarily mean that you're even all that sick. When I first started my clinic, there were a lot of people that were told that they had stage 4 disease because their PSA had gone up and they had already received either surgery or radiation therapy and some hormone therapy. And the minute that the PSA started going up again, they were just told, you must have metastatic disease. You're going to die. Just get your affairs in order. As a matter of fact, I mean, a lot of patients that actually made clinic appointments in the early days, 20 years ago, they were in hospice. They were being put into hospice and they were being told there's nothing further we can do. You're going to die. And these patients very politely would call me and say, I'm in hospice. Do I really need to be here? Do you have anything that you can do to help me? And I'd say, well, if you can make it to my clinic, we'll run you through the scanner and see what you got. And some of these patients, in fact, had forms of stage 4. So stage 4 is just a designation that in the old days basically meant it was outside of the prostate. But as I tried to diagram earlier, you can have just one spot out of the prostate. You can have 10 spots outside the prostate. They can be spread far and wide. There can be a few of them. And sometimes you can just treat them and get rid of them. So a lot of the patients would come and we were shocked because their PSA is going up and we'd run them through the scanner and there wouldn't be necessarily a whole lot of disease there. I still can remember a gentleman that went to 4 of the major institutions over a period of 3 years. And he came to Mayo Clinic on one of my busier days when I was getting started. And I remember walking into the room and he was really upset with me because I think that he thought that we're going to just be the typical group. And he was so frustrated about how much other people were not able to offer a solution. We ran him through a PET scanner because his PSA was going up. He was on hormone therapy and he had one tiny nugget of cancer, one tiny nugget. And we set him up for surgery the next day. We plucked out that little nugget. His PSA went to 0. We were able to take him off hormone therapy. And he cried. I mean, he literally cried. He could not believe that he had been through that much and he had been told that he has stage 4 disease and that he's going to die, over that little tiny thing. So so the fact of the matter is stage 4 prostate cancer is not synonymous with widely metastatic fatal disease. And until proven otherwise, I think that you have to treat it as a disease that you can treat.
Yeah, that's a really good point because until you're adequately staged, and this is what goes back to your original talks when I first met you and the imaging that goes on, somebody could call something metastatic that is just right outside the prostate. They could call something metastatic that has gone to your shoulder. They can call something metastatic that has gone to the spine, sure, but the word metastatic is such a buzzword, it's right. But the reality is truly defining it is an art. Like where exactly has this metastasized to?
Yeah, there are two things that are still kind of treated like a flashpoint for danger. One is rising PSA when you're on hormone therapy, and the other one is the concept that you might have stage 4 disease. So still, even now, patients are seeing their doctors and they're being told, you have stage 4 disease, there's nothing I can do for it. Or you have hormone resistant prostate cancer. And somehow they make the hyper jump to it's hormone resistance, PSA is going up, ergo it must be stage 4 or metastatic, ergo you're going to die. And that's just simply not true. You can have a patient that has a rising PSA after primary treatment while on hormone therapy, and all you're dealing with is a pimple.
Yeah.
And it can be knocked out.
Yeah.
And that's why I started making these combat manuals. And that's, from the first time you guys invited me to PCRI, I think in 2011, back then, having a rising PSA while you're on hormone therapy was synonymous with you have castrate-resistant stage 4 disease with a median life expectancy of somewhere between 13 months and 1.5 years. And that's just not the case. So, thank God that you guys let me come back and speak a couple times, because I think that now finally people are starting to realize that that paradigm is shifting.
I think that's really well put. So if someone ever tells you you're stage 4, make sure you really do your homework with your medical team or your other folks that you're working with to figure out really what is actually going on. Because in a lot of cases, I'm not saying in all of them, in a lot of cases, you're getting a label which has a variety of definitions. And that is a trap that often people fall into. So here comes your next curveball. I like this one a lot. Fact or fiction? The higher the PSA, the more aggressive the cancer. Because if you're ever in a crowd, come on, you've got to admit this. If you're in a crowd and someone goes, I saw someone with a PSA of 10,000. I don't know. Okay, before I finish my question, what's the highest PSA you've ever seen?
Over 100,000.
Okay.
Yep.
Okay. And 100,000, right? So I've never heard of one. Wow, that's it. That's impressive. Over 100,000. Okay. Then you hear that and everyone goes, oh man, stage 4 or whatnot. But there's a story behind the story. So just because you have 100,000 or 10,000, fact or fiction, the higher the PSA, the more aggressive the cancer. Do you want to talk about that?
Partially true, but not absolute. And in some regards, some of the worst cancers we see have the lowest PSA. So what people have to understand is that PSA is a product of cell function. And if a cell is functioning fairly well, a prostate cancer cell, it's going to produce a lot of PSA. However, as the prostate cancer cell starts to undergo what's called dedifferentiation, or becomes less civilized or less organized or more aggressive, a lot of times it will stop producing PSA as it goes on this kind of highway to chaos. So what people have to understand is that a guy that's standing there with a PSA of 0.4 with a history of Gleason 10 prostate cancer, he could be in more dire straits than a guy that's sitting there with a PSA of 120 and a Gleason 7 prostate cancer. And we see that all the time, as I've kind of pointed out multiple times. We see, I think right now, 12% of the patients we see in my clinic have an undetectable PSA, but they have full bore, widespread, serious metastatic disease. And as a matter of fact, I think that we're going to be revising those numbers with the advent or introduction of PSMA PET scanning, because we're picking up a lot of patients who have an undetectable PSA but have demonstrable metastatic disease on PSMA PET. So, in general, you can't just say if the PSA is high, that's a sicker person than a person that has a low serum PSA.
Oh, that's really well put. I'm glad you separated that fact from fiction. By the way, every time my dog hears you talk on the computer, he runs up the stairs and he came up. I swear, I can't make this up. Every time
Gracie?
Yeah, he runs up. Now,
Gracie.
So every time he hears you, this is no kidding to the audience. He's in the bedroom far away. He always runs up. I don't know. You guys have some kind of strange bond.
It's a lot better response than some of the other dogs that hear my voice.
Well, I want to go back to that fact or fiction, because you've helped me with that. Other people have helped me with that. And also I've personally seen that someone can have a PSA of 100,000 or 10,000. And a lot of times they have differentiated cancer, which means a number of those people, I'm not saying all, will go on therapy and the PSA will go, whoom, it will go down. So I try to always look at the glass half full. When someone says I've got a 10,000 or 5,000 and they've had no treatment at all, you're thinking, ooh, this thing has room to come way down because it's still very much like a prostate cell. It's still making PSA. It's still functioning. It's got the machinery. So I'm really glad you separated that out because you see a lot of people with very low PSAs that have cancer in a lot of places because the prostate cancer cell itself is no longer acting like a normal cell. It's acting like a strange factory, right?
Yep.
Okay. You have another one here. There's so many, I don't even know where to. I'm gonna come back to PSA for a second, but this is fact or fiction. This is another one you texted me that I forgot to make a sign. There was so many you texted me, and that is, you kind of answered it already based on this PSA. If my PSA has been not moving for years and years, or is undetectable for years and years, and I come to see you in the clinic, everything should be fine, right? Because I've had an undetectable or a PSA that's just not moving for a long period of time. What say you?
So we're trying to understand this a little bit better because you don't want to necessarily make a blanket statement. In general, I try to get across the point that you can't rely on your PSA alone if you have a history of prostate cancer, period.
Yes.
So basically, if you have an undetectable PSA, I personally think that you need to get some form of imaging to really know if you are out of the woods at that particular point in time. If you've got a fairly complicated history, I think the risk is much higher that you could have active disease that's spreading even without a detectable PSA. Meaning, for instance, if you've been on systemic therapies for known metastatic disease previously, you can't rely on your PSA to tell you where you're at. If you're simply a patient that had your prostate removed,
Yeah.
and your PSA is remaining undetectable, and you haven't had radiation and you haven't had hormone therapy, then chances are you're not going to see metastatic disease. And the PSA is going to be more reliable to tell you something's happening. But the bottom line is, if you've had systemic forms of therapy or radiation or hormone or whatever, and you haven't been imaged recently, you can't rely entirely on your PSA to tell you you're out of trouble. And for those patients, when they come see us, we automatically get a PET scan on them the minute they come see us.
Yeah, it's the more treatments you've had, the more you've gone through treatment, the more you can't rely on just PSA as telling you how you're doing.
Absolutely. That's the best way, yep, to phrase it.
Okay, I should not ask for a second opinion because it could insult or upset my physician or medical team who is treating me right now. Fact or fiction?
That's just false. I mean, as a patient, you have rights. And I think one of the rights is basically to ask as many doctors as you can to find out what's going to be the best care for you. And to some extent, I have to say that if a doctor gets bent out of shape because you're going to ask for a second opinion, that may not be a good fit right off the bat. And I have to be honest, when a patient sees me and spends a lot of time and then says, well, thanks for the information, I'm going to go see someone else. I always feel bad about it because I feel like I didn't deliver the definitive answer that, kind of would put them to peace or put them at peace. But at the same time, I think that it's important to realize that it's not about me. It's not about my feelings. It's about the patient. These patients are fighting the battle of their life. And I think they should be courteous, obviously, but I don't think that they should worry about hurting the feelings of doctors. I think that they need to get the information they need.
You still hear that today. I'm worried about what so-and-so is going to think or so-and-so on the team. I don't know if it conjures up thoughts of 30 or 40 years ago where what do they think, that they're going to stop treatment or stop being nice to them? I understand, but that's an obstacle to break.
There is practicality to it. You know, the problem I think with a lot of patients is they belong to networks, or they're in a location where there's kind of a limited array of people to work with, and they fear that they're going to somehow alienate themselves from immediate care, and that's
Yeah.
always something that we have to be sensitive about. But at the same time, you know, I don't think that a patient should ever compromise, you know, the decision making just simply based on the fact that one doctor says do it my way or hit the highway. I
Yeah.
think that that's wrong, you know.
It just seems to me, it's always seemed to me that when someone takes it personally, I'm talking about a medical professional takes it personally, that someone wants to seek another opinion, they're putting their personal ego ahead of care. Because it's a blow to their ego, but at the same time, don't you want what's best for the patient? You want them, if you're so confident in your skills and you're so confident in your ability, you want them to go out anyway and say, okay, see what else you can find. And if you can find something else, great. The opposite way of thinking of, hey, I own this arena, has always, maybe because my dad was such a good doctor, but it's just such a bizarre way of thinking for me. I just had to get that out.
Well, you know, I'll be the first to admit that I have an ego, and
Yeah.
I'll be the first to admit that there are probably times where I come across that, you know, it's kind of like I'm right, they're wrong. Um, I think that patients need to distinguish though between their doctor getting bent out of shape and having an ego versus making a good informed decision.
Yeah.
Making a good informed decision is the right of a patient. And there should be nothing that deters that. It doesn't matter if Dr. Kwon likes you or doesn't like you. It doesn't matter if Mark Moyad likes you or doesn't like you. Um, it's a matter of, is this the right thing to do for you? And is this the best medicine for you? And I think that nothing should ever stand in the way of that. So, you know, I always feel bad because, you know, I'll come out of a room and I'll say, well, I felt a little bit egotistical or a little bit biased when I said things or whatever. And certainly I've had patients that have come back and said that directly to me in one form or another. But I think that, you know, like I said, as long as the patient is getting a level of care that they're comfortable with, and which is reasonable, I think that's the most important thing.
This is so much fun because you don't know what's coming. So I have a lot of power here. It's almost like I'm the person who can decide whether or not you get a Whopper and fries, not you. All right.
You're kind of like that egotistical doctor, really. I mean, you know, yeah.
Exactly.
Okay. Okay.
I
Good.
got to show ego somewhere. So I'm showing ego as a host.
Yeah.
When an insurance company says no, or they quote unquote deny, there's almost nothing you can do at that point because that's too big of a juggernaut. That's too big of an obstacle. Fact or fiction?
I think that's fiction. I think that the bottom line is that there are methods of appeal. And I do think that the more you appeal and the better informed you are, the more likely you are going to be able to bring the insurance company around to seeing things your way. Um, I've seen a lot of different patients have to deal with this. Some
Yeah.
of them have dealt with it successfully, and some of them have been unsuccessful. But I would say that the rule of thumb is generally that the more you inform yourself of why you need certain testing, and the more you inform yourself about why this is important, and the more you appeal with the insurance company, the more likely they'll come around to seeing things your way. I think the patients that are the best at doing this are the ones that are very, very informed about their disease and very informed about articulating why they need a certain test. And the ones that are most persistent and are willing to escalate this through all the appeals processes, I think they tend to be the most successful.
So the squeaky wheel gets the grease here.
Yeah, you know, squeaky wheel kind of implies that a person's kind of whiny or something. I don't think that's the case. I think that in this case, it's people that are more prepared
Yeah.
and arm themselves with information. I think that they can be very successful.
When's the last time you saw an appeal that was successful?
Oh, it happens every day. I mean, our patients are
Oh, so
very good at what?
Give me, so if it's happened recently, just give me an example of what was denied and how the appeal. Just walk me through an example of what you remember. What was denied?
Well, even PET imaging. PET imaging, a lot of times they'll say you don't need PET imaging, and it'll be a young patient. They'll have sometimes undetectable PSA. Sometimes that undetectable PSA is because they have, as we discussed, some of the worst diseases don't make PSA, right? Some of the more aggressive forms of prostate cancer.
Yeah.
So they will articulate that in a letter saying, you know, I'm a young individual. I had Gleason 10 prostate cancer. My doctor said that you cannot use PSA as the determinant for whether or not I have metastatic disease. And I think that it's imperative that I get this PET scan to see if I have metastatic disease, because it will help me select the proper therapy to optimize my overall health care. Failure to do so could compromise my care and result in, you know, a less favorable outcome, including, you know, shortened lifespan. You know, you just have to put that all in writing, and then you have to follow up over and over. You know, where's this at? And if the first person doesn't get it, then you have to escalate it. I want this to be seen by a supervisor or the manager or whoever, you know.
So when people appeal, is this accompanied by a note from your medical team, or are they appealing by themselves?
A lot of our, you know, quite frankly, we don't have the bandwidth or the resources to do peer-to-peers or to write all these letters of appeal. Many of the appeals that are handled by my patients are handled by my patients alone. And they
Wow.
are very successful.
Wow. And have you seen a situation recently where someone was denied, someone appealed, they were denied and said, forget that, they appealed again, and then they were accepted?
I've had patients that, so whether there's any truth to this or not, you know, this kind of falls into the category of fact or fiction. But I think in general, the concept is the more you appeal and follow it up, the more likely you are going to win. If you give up after 3 tries, or if you give up after a couple half-hearted tries, you're going to lose. So you got to keep pushing.
So the informed and kind squeaky wheel gets the grease. Sorry, I had
Well,
to say.
yeah, just the well-informed person that is persistent or tenacious.
So my last question around insurance is denying is then, okay, I'm excited. And PCRI, I know, can help with that. I know that Alex and the team are working on sort of a standardized form of appeal. We've talked about that. You know, they got the finger on that, the pulse. But here's my question. Now I'm going to play devil's advocate. Okay, I'm appealing. This must be taking a lot of time. Is this taking months and months and months, or 6 months? I mean, when you see an appeal that's successful, is this taking a really long time, or does this actually happen acutely or shortly?
A lot of our appeals center around imaging or treatment, but most of the patients that are very aggressive about these kinds of things, they will usually be able to get the matter resolved within weeks to maybe a month and a half. Yeah.
I love it. I love it.
And you know, patients have to understand that there are resources, right? You know,
Right.
they can try to ask, in our case, they ask for, do you have examples of what we can put into our letters of appeal? So we have some verbiage
Yeah.
that we can hand out. We can also tell patients, especially if it's a fairly egregious type of situation, that they can always speak to representatives in their state.
Yeah.
And sometimes that's very, very successful. But for the most part, it's just dialing the insurance company and trying to reach the right person.
Yeah, I love it. I love that you see appeals all the time and you see successful appeals, because I know there are a lot of denials, and that just makes me happy.
I mean, we're learning, just like the DIY series that I
Yes.
make, virtually everything I do, I learned from my patients. It's not
Yeah.
vice versa. So we just listen to the patients and we see how they do things, and then we try to share that.
One of my private goals, I'd love to see this, and I know PCRI is going to take care of it, is that when people run into a problem of a denial, they can come to the advocacy group and they can get the pieces of the puzzle of how to put those pieces together to get the right picture on how to get a successful appeal won. And I just think, for people watching today, the fact that you see so many appeals that are successful, and the other point you made is it's generally primarily driven by the patient, is just an awesome answer. And it's true.
And I just want to say this very carefully, but it is true. Patients have a lot of reason to be unhappy when something gets denied. And I think that there are wheels turning in that arena. I know that Congress is visiting the concept of pre-authorization. And that's for a reason, because at least to some people, pre-auth seems to be a mechanism of putting up a barrier. And I think Congress is looking at this kind of stuff and saying, well, these barriers should not be existing, or these gateways of handling who gets what, they should not be there,
Right.
because it's just an impediment to good care. Likewise, I think that certain insurance plans are getting certain amount of attention directed towards them, because there's a general feeling that certain kinds of policies or behaviors are unacceptable. So a patient shouldn't feel shy about this, and a patient should not feel like they're doing something wrong because they're outraged because they didn't get something. They may very well be in the right. And this whole idea that, the person on the other side there, the gatekeeper, is some brilliant scientist who's adjudicated all of this information in medicine, and they know what's right and they know what's wrong. That's simply not true.
Yeah.
There are very few people that are in that capacity. And the reality is, usually when patients are arguing for something that they need, typically they are in the right, and they should behave that way.
I'll have to leave it at that. I could not have said that better myself. I love that segment. That was my favorite fact or fiction that we've done. All right, here's one that you threw out to me. I didn't even ask you why you threw this out to me, but I can understand why you made it a fact or fiction. And I don't want you to be nervous. You seem nervous that you don't know what's coming. It's like you don't know if I'm going to throw a curveball or a fastball, or am I going to throw a slow pitch?
I usually write this stuff on my palm and crap like that, but you didn't give me a chance. So
No, but you're always in the clinic. You're always busy. So I had to type these up. You think these signs are easy? I mean, it comes with a lot of ink. We have a very small budget. I mean, look at my background compared to yours. You have you have a beautiful office. I have just two curtains that my wife put together so you can't see what's outside. This is one you actually submitted to me. Once I get radiation treatment, I cannot get radiation treatment again. Fact or fiction?
That comes up quite a bit. So that's false. So there's two ways that's false. So one way is, some patients will say, well, I got radiation back in 2012 and I can't get radiation again.
Yeah.
So the reason that may not be true is because that particular patient may have had radiation only to one spot in their body around where the prostate used to sit. And that's the only place they got the radiation. So you can still receive radiation to other parts of the body as long as those other parts of the body don't overlap with an area that's already been irradiated. But even more kind of important is the fact that more recently, because of changes in technology and our understanding of disease and healing and so forth, some patients are coming back with recurrences inside of areas that have previously been irradiated, and they are still candidates for additional irradiation, either in the form of brachytherapy or a high intensity focus type of stuff, as long as it's being given by someone who's skilled and has the ability to assess the risks. So the reality is that, just because you got a little bit of radiation in the past in no way precludes further radiation for management of prostate cancer or other malignancies for that matter.
Look what on one of our last discussions you talked about, and by the way, you keep saying false, and the game is fact or fiction. So now I'm going to have to change our segment to true or false because you're not saying fact or fiction.
This is like when I say number one,
Yeah.
and then B, and then third, right? I can't maintain consistency, right? So,
That's okay. I'll
sorry
change it.
about that.
I'll change it to true or false, but I'm worried that when I change it to true or false, you're going to say fiction or fact. But that's okay.
I never, I'm a urologist. I don't get invited to play many games,
No, I know. But I'm here to make you look good. So I'm going to keep it whatever vernacular you want to use. You are Mr. Oligometastatic disease. You love to talk about it. You used to talk about it at the conferences, the in-person conferences. How many people do you know received a little bit of spot radiation to a certain area of the body? PSA returned, and then they got another hit of radiation somewhere near that. So they were re-radiated. Can you talk about that? That happens to me, it seems, because I talk to a lot of people. It happens all the time.
Yeah, I think that people have to understand that when I first started giving presentations in 2011, the concept of PET imaging essentially didn't exist.
Yeah.
And now that there's more and more PET imaging going on, our understanding of prostate cancer is shifting to the left. We are seeing more and more early disease, and the early disease is in the form of oligometastatic prostate cancer, which means a few mets or a few spots of prostate cancer in the body. So when we first rolled out these terms and concepts, we'd see a couple spots and then you'd shoot them with a radiation after seeing them on a PET scan, and you'd see how you do. And some of those patients, the disease would go away and stay away. And other patients, you'd shoot, and then it was almost like dealing with the mythological Hydra, where you cut off one head and then two grows back, cut off two heads and four grows back, etc. So with oligometastatic disease, I feel like I'm starting to learn some lessons. Number one, you can't be unrealistic. So the formal definition of oligometastatic disease means 5 metastatic sites of prostate cancer or less. 5, 4, 3, 2, 1. And the sizes of the spots have to be fairly small. In our world, if we see 5 spots, generally we know that if you hit all 5, it's not going to necessarily go that well. So we typically get excited if we see 3, 2, or 1 spot.
Okay.
We get really excited if we see 1 spot. Now, if you irradiate it and then the patient comes back later on and that same spot is still glowing, the exact same spot, you have to assess how much radiation did you give to that spot, and do you feel like it was enough to kill the tumor? if they've gotten a substantial amount of radiation, 2,000, 3,000 centigrade of radiation to that spot, and they're confident they hit it, generally speaking, coming back with radiation to that exact same spot is not a good idea, because that will probably destroy the tissue to the point where something bad will happen. On the other hand, if the area of recurrence is just off to the side, like on the edge of the original spot, then it may be a good idea to give additional radiation to that area with the understanding that that edge was not appreciated at the time of irradiation and therefore did not get an adequate dose. Where I think it kind of falls off the railroad tracks is where, a guy had 3 spots, you shoot 3 spots, and then next time they come back and they have 5 spots in different locations. I think that it's probably not a good idea to keep chasing multiple spots with repeat irradiation. I think that the repeat irradiation is really best for either one additional spot that shows up over time or something that's in proximity to what you already hit.
It makes sense, but then again, I think of one scenario that I wonder from your standpoint when it comes to oligometastatic, if you like to see fewer spots that you can radiate or re-radiate, whatever, and it's 2 or 3, do you like to see the 2 or 3 close to each other in the same neighborhood? Let's say they're in the same street. Or do you like to see 1 or 2 or 3 separate from each other in separate spots?
We're okay with three separate spots, widely distant, but you have to factor that into, what level of risk you think the patient has for other spots.
Yeah.
So someone that has a tight cluster of metastases is probably a different patient than one that shows up with a shoulder blade and a cervical spine and a pelvic lesion, because those are way far apart from each other, and it's pretty easy to envision other breadcrumbs in between those spots.
And how do you feel about not only someone being re-radiated to an area that already received radiation, but let's say now you're going for, and you know these scenarios. I know a doctor right now going through this scenario, and now it's his 3rd time. He's been able to hold off systemic therapy for years, and now it's the 3rd time PSA is rising near that spot. What if they don't want to do radiation as a re-radiation? What if they want to do something that's more in the lines of cryotherapy or something else that can freeze it? Or
we have guys that will have a solitary spot on the sacrum. I know this with the sacrum. Sacrum's a very complex bone. It's got a lot of interstices and crooks and crannies and stuff like that. So we've had guys that have gotten stereotactic irradiation to a spot on the sacrum, and then it comes back again, and they get another dose of radiation to clean that up. And then the 3rd time it comes back, and they say, well, we can't give it any more radiation or something bad's going to happen. So we send those patients usually to our neuro interventional radiologist, and he can either use cryotherapy or thermal therapy to try to go after those sites of recurrence, not using radiation. Yep.
And by the way, where's my sacrum? Where's my sacrum?
Your sacrum, I have no clue. But most people's sacrum is located, that's where it's on the back of your butt.
I just didn't know when you start throwing thermal energy or cryo in these areas like the sacrum, I interrupted you, but you do see success there 3 or 4 times? You do.
Yeah, we have a gentleman named Jonathan Morris here at Mayo. I think he's one of 2 neuro interventional guys that does tumor ablations, and he can oftentimes get into those bones and do corners and crevices. It's unbelievable. I don't even know how he does it, but he can get around the corners, and a lot of times he can do stuff that they can't deal with radiation.
Yeah, because the sacrum it's the sacrum itself. And when you look, it's geographically intimidating, right?
Oh, yeah.
It's like you
Yeah,
say,
it's
it
unbelievable.
looks like a
Yeah.
bad moon landing. It's just wow. I mean, so that's really cool that you have that option. And I know other people can give that option because you can't keep delivering radiation to that spot over and over again. You got to come up with something different. So I love the idea of using one of those therapies.
And we
Cool.
also have a soft tissue guy, Dr. Woodrum here, and we have several of them, Dr. Woodrum, Dr. Atwell, but they can go into areas that have been irradiated, and they can oftentimes deliver either cryotherapy or thermal therapy or some other form of ablation, chemical ablation, to
Yeah.
wipe out these lesions. So yeah, it's pretty amazing.
We receive a lot of that kind of mail for people that have been re-radiated to a delicate area. And now what are my options? So I hope people hone in on that segment and what Dr. Kwon said, even though he's not using the words fact or fiction, but true or false. You're going to love this. I keep saying that for everyone because because I made the sign, so you have to love it. Chemotherapy for prostate cancer is rarely needed today and has too many side effects. Fact or fiction?
So that's fiction. And that's a big fiction underscored.
Big fiction.
So, yeah, I mean, chemotherapy is often needed, and it's rising up the menu as a form of treatment for prostate cancer. So, in our world, and I think I pointed it out in some of those slides that I provided at the beginning.
Yeah.
You can have stage 4 disease. If you have a little bit, you can deal with it one way. When you have a fair amount of prostate cancer, the gold standard now basically is triple therapy, which involves chemotherapy combined with hormone therapy, that's androgen deprivation hormone therapy, Lupron, Eligard, those things, plus what's called ARPI, androgen receptor. I don't know what the ARPI stands for. ARPI, which is drugs like Zytiga and Xtandi and Erleada and darolutamide, which is Nubeqa.
Yeah.
These are androgen receptor pathway inhibitors. So those are used in combination with taxane-based chemotherapy, which is known as Taxotere or docetaxel. Second line forms of taxane-based therapies are cabazitaxel, which is also known as Gevtana. But chemotherapy is now the backbone of treatment for advanced prostate cancer. And I still feel, after seeing a lot of different therapies, I still feel that people that try to avoid chemotherapy tend to not do as well as patients that receive the chemotherapy. And I think that has been supported now in at least 3 clinical trials. One is called Peace 1, one's called Peace 2, and the other one's the Arison's trial. And they pretty much clearly show that you got to give chemotherapy with hormone therapy with an ARPI to get the best outcome. Prior to that, there was already studies that showed that chemotherapy should be used in combination with hormone therapy. That was the Charted and Stampede trials. And those showed that chemotherapy definitely enhances the impact. And the reason behind it, and that I brought that up in one of our previous combat manuals, chemotherapy kills cells. It doesn't suppress them. Hormone therapy and ARPIs are known to suppress prostate cancer. That means put it to sleep. But chemotherapy actually poisons those cells. It causes them to die. And when you use chemotherapy in combination with these other drugs, they tend to, you got to think of it as like a mean Chicago fight. It's like poisoning someone and suffocating them at the same time. You're going to knock out more cells. Okay.
Oh.
So there's absolutely no dispute. Chemotherapy is very important for the treatment of advanced prostate cancer. And in terms of side effects, every treatment has side effects. Every
Yeah.
treatment. Chemotherapy can induce neuropathy. It can induce fatigue. It can have impact on your bone marrow. And then there's all the, loss of hair and appearance and stuff like that. You don't want to try. These are not trivial things, but you can also mitigate against them. So a person that's getting chemotherapy, if they do cold treatments, ice cold treatments of their hands and their feet, you can mitigate against neuropathy. If you
Yeah.
want to hang on to your hair, you can wear an ice cap.
Yeah.
There's a lot of maneuvers that can be used to make the side effects of chemotherapy much more palatable.
So now let me play devil's advocate. Dr. Kwon, okay, you're pro chemotherapy. Who wants to go on chemotherapy for years and years and years? How long am I taking this stuff?
So chemotherapy is given IV once every 3 weeks. And each time you get it IV, it's called a cycle. And generally speaking, for most patients with advanced prostate cancer, you're only going to get 6 cycles total. So the
Bingo.
therapy is going to be done within 18 weeks. More importantly, something that's really important, chemotherapy that's used for prostate cancer bears no resemblance to any other forms of chemotherapy that are used. So chemotherapy for colon cancer, Folfox, FOLFIRI, chemotherapy for lung cancer, cisplatin etoposide, chemotherapy for lymphoma, R-CHOP, and all those things.
Yeah.
Those are big chemotherapies. Chemotherapy that's used for prostate cancer, the vast majority of our patients have no ill effects, typically within 3 to 4 days after getting it. So you can drive yourself to therapy. You can feel good about your therapy. You can drive yourself home. And the next week you can feel, you might feel a little punk and run down, but it's not like the chemotherapies that are used for other advanced malignancies. So I always tell my patients it's like the difference between, vodka and a light beer. The treatments for prostate cancer are like the light beer compared to the big chemotherapies that are used for big malignancies, which are like, taking swigs of vodka.
Yeah. Wow. That's an interesting alcohol analogy.
Yeah, I don't drink, so I don't know if it's any good.
It's okay.
Yeah.
It's kind of overrated.
Yeah.
So, all right, but that's an important point because people are on these hormone therapies for a decent amount of time, but they're only getting, in general, the average is 6 treatments of chemo and then it's over, right? However, now I'm going to play devil's advocate again. Okay, yeah, I can kill some cells with chemotherapy, Dr. Kwon, but I might have a bunch of cells with mutations. They've got different types of mutations. And I heard chemo doesn't do anything against any of these mutations. Fact or fiction?
That's fiction. So sometimes the more mutated cells are actually more targeted by the chemotherapies. Chemotherapies in general work by intercalating or interfering with DNA and replication processes. And if cells have lots of mutations, a lot of times they're even more vulnerable to chemotherapeutic treatment. Some of the angrier cancers, in fact, respond very well to chemotherapy and not at all or very little to the hormone manipulations.
Okay, I love that. And then devil's advocate.
Oh, I wanted to say one more thing.
Sure.
With young patients in my clinic, I can almost guarantee that if you ask a guy, which do you prefer, the hormone therapy or the chemotherapy, almost uniformly the patient will go, I'd be happy to be getting this chemotherapy. Can we quit the hormone therapy? I mean, hormone therapy is not without side effects, as
Yeah.
everyone knows. As a matter of fact, a lot of patients, they would like to discard the hormone therapy if there's a chemotherapeutic solution, because chemotherapies for many of our patients is not that bad.
Really well put. I love this talk about the fact or fiction with chemotherapy. All right. That makes me think of one other thing that comes up with chemotherapy that's out there in the internet sphere all the time. If you read a lot of papers, it says chemotherapy is really good for high volume metastatic disease, but for low volume, we're not so sure. What do you do with that?
Yeah, so a lot of that data came out of clinical trials for advanced prostate cancer. And a lot of those clinical trials were heavily biased with large populations of men with lots of disease. So when they crunched the statistics and they said, where's it working? They said it really works on lots of prostate cancer in these very sick individuals, but maybe it doesn't work so good or as well on guys with just a little bit of cancer on these trials. But one of the things about those trials is that the numbers of patients that had little bits of disease, the overall number of patients participating was relatively small. So the statistical powers to discriminate whether it's effective or not weren't all that great. So based on that, people said, well, it may not work so well on smaller amounts of disease. So that's part of where that came from. The part that I find very confusing is it seems like everyone's got different definitions of small amounts of disease, right?
Yeah.
So, if I have a guy that walks in the door and he's, 50 years old and he has Gleason 10 prostate cancer and he has spots on his lung, to me, yeah, it's a small amount of disease, but looks bad.
Yeah.
And I think that you got to be aggressive in terms of treating it. If it's a patient that comes in, and I've literally faced this. I have a patient, he's got 15 spots on his PET scan, Gleason 10 prostate cancer, 45 years old. And I say, you need chemotherapy. He goes back to his doctor, and doctor says, no, it's small volume. It doesn't show up on the CAT scan. And you sit there, I'm dumbfounded because, you got 10 spots. It's on the
Right.
PET scan. This disease is going to progress. It's widespread. It obviously, to me, denotes a serious situation. But they're using these definitions. Well, you can't see it on a CAT scan, therefore it's small volume. It only shows up on a PET scan, therefore it's not serious. It seems like an irrational or arbitrary argument to me.
Yeah.
So obviously, we don't try to make one size fits all, but if it's a young patient with a couple spots that are in bad places, we take that more seriously than, just saying, well, you're going to do a little bit of hormone therapy. And to be honest with you, hormone therapy, as I pointed out, hormone therapy by itself is palliative. That's a one-way street. You're going to take hormone therapy until it doesn't work, and then you're going to need something else. So that's one of the arguments that a lot of our patients go crazy about. They say, well, my doctor just wants to do hormone therapy until it gets bad. Or they say, I don't want to treat this with chemotherapy until I can see it on a CAT scan when it's much bigger. Those kind of forms of thinking don't really make sense to me,
Yeah.
So I tend to try to look at the individual, try to assess what the goals of therapy are for this individual, try to assess what the relative risk is. Obviously, if a patient comes in and they have a lot of medical comorbidities and they're an older person and so forth, well, yeah, small volume disease, you might be able to treat that with something else. But if it's a young person and they have spots, I don't make a lot of distinctions, especially if the spots are in a place where you can consolidate therapy as a final step. So, for instance, if a guy has 13 lymph nodes in his retroperitoneum and they're all small and they're going down into the common iliac vessels, and I know that my last step is going to be consolidative radiation therapy of all that, I have no problem doing the triple therapy followed by consolidated radiation therapy with intent for cure.
So when you say the retroperitoneum, where do you mean?
It's the back of the tummy, back of the tummy.
Yes, thank you. Back. Right.
Retroperitoneum.
Yeah.
Below the diaphragm.
And those are often tricky, right? Those are often, so that's the great thing about imaging, they can find those.
Yeah, I think that the reason that the discussion is a very relevant one, I would say in this era of PET imaging, we're seeing disease earlier. When you talk about seeing disease earlier, then the next question is, where do you see it? I would say that probably 80% of our patients, we see the disease either recurring in the pelvis, around the lymph nodes, or in the retroperitoneum below the diaphragm. You know, that's a hot zone for recurrence, especially in the era of PET. And that's imminently that's curable disease, provided you see it, provided you treat it aggressively, and then you do something kind of definitive at the end, like
but it's still not too far away from the prostate. You're still handling it with chemotherapy?
Yeah, I mean, if it's scattered about, and if it's evident that it's probably metastatic, and of course, you know, one of the things that we talk about is a lot of times the things that you see are not the things you have to worry about. So if you see a couple spots here and there, that's not what we're fearing. What we're fearing is all the other stuff that might be hiding in the body as micrometastatic disease that you don't even know about.
Yeah.
So that's where really aggressive systemic therapies come into play in terms of, you know, handling what's going on with the patient.
You can explain what the drug does if you want. You probably should. But, you know, we used to talk about Pluvicto, and there was a trial called the Vision trial. There was a phase 3 trial that got this drug approved. It's a radioligand therapy. And a lot of people, you know, this is approved now for castrate-resistant prostate cancer, but there's all these trials going on right now of testing men with castrate-sensitive prostate cancer. So I wonder how you feel about Pluvicto possibly getting FDA approved sooner or earlier in the stages in the situation for men with prostate cancer, not just later on. How do you feel about where Pluvicto is going? First, tell the audience where it is, and maybe you can factor fiction of where it's going.
It is approved for treatment of patients with metastatic prostate cancer who have hormone-resistant forms of prostate cancer and who have previously received at least one form of taxane-based chemotherapy and have had some experience with an ARPI or androgen receptor pathway inhibitor. So it's currently approved. It got approved in March of 2022 for the treatment of advanced hormone refractory prostate cancer, metastatic, which is also evident on a PSMA PET scan. So you have to be able to see the disease on a PSMA PET scan. So we call that the post-taxane space. Patients who have already been treated with taxane with hormone refractory disease. Pluvicto is approved for that. People want to test the utility of Pluvicto prior to getting chemotherapy, partially because it would be nice to be able to treat the disease very effectively without necessarily having to get chemotherapy, obviously. And trials have been conducted in the space before chemotherapy, so hormone-sensitive forms of cancer. And I know that you'll be disappointed, but I don't really have eyes on the inside of this, and it would not be my it would not be good for me to speculate whether it will be approved or will not be approved. I just don't have information on that. But I do know that the studies have been conducted and that the discussions between the sponsor, which for Pluvicto is Novartis, and the FDA are probably ongoing.
But I think that answers the question, and I'm sorry to throw you such a curveball. People have accepted Pluvicto in this space that you described, but what's really happening with Pluvicto is it's being tested earlier and earlier and earlier to the point where I'm kind of going, wow, that's pretty early. So, this is something to look out for. Is this going to be positive or not? But we're going to get that information very soon. I don't know either. I just wanted you to talk about it.
As an opinion, outside of whether it will get approved or not to get approved in that space, which I can't even speculate about, but as an opinion, anything that can be used early on to effectively knock out the disease, I think it's a good thing.
Yeah.
And I think we do have to focus more and more attention on that particular space. And I do, in my mind, see potential roles for radioligand therapies in that very early space. So, if I were able to just pick and choose and say, this is the way I treat the disease and this is the way I want things to go, that would be an area that I would be looking at, definitely.
That brings up the other radioligand therapy that we get a ton of questions on, and I brought it up to you before, and it's being tested right now in Europe and a variety of other places geographically. It's called actinium. So actinium right now is being tested for, correct me if I'm wrong, even for people who have failed Pluvicto or failed lutetium, that this becomes another option. So are we going to hear about the possible approval or non-approval of this new radioligand therapy within the next couple of years?
I think so. Definitely, trials are underway looking at actinium for the treatment of advanced prostate cancer, and definitely for my patients that have traveled overseas, they've had some pretty remarkable responses to actinium even after failing lutetium. Having said that, just like any other drug that's stronger than the previous drug, there's always also enhanced risks and side effects that we're getting our kind of getting our minds around. Actinium is an alpha form of a radiation, and I basically, without actually knowing the actual numbers, when I talk to patients, I just say, it's 5 or 10 times stronger than lutetium, meaning that it seems to be more powerful in delivering a form of radiation to the cells. And I've had patients that flat out not responded to lutetium that have gone to other institutions, most of them overseas, and gotten actinium and had very profound responses to therapy.
Where we've talked about this, I throw you some softballs, but you don't have to get specific, but where overseas are you talking about?
Well, I send quite a few patients to Istanbul, Dr. Kezban. And it's, there's a tendency to think that, you're just talking about sending patients to some random country, but Dr. Kezban practices at a JACO approved facility. So highest U.S. standards. And she is Johns Hopkins trained, and she's an outstanding physician. But simultaneously, there's people like Kratochvil in Heidelberg, Germany, and then there are people in Australia. They're all outstanding individuals. And then, of course, there are centers in the United States that are working with actinium as well.
Yeah.
So, actinium's out there, but overseas, the principal sites are Australia, Istanbul, and Germany.
And when you see him get actinium, I know you see some responses. Is permanent dry mouth still a problem?
Permanent dry mouth can be a real downer.
Permanent dry mouth. Yeah.
So some patients get it, some patients not so much. When patients get it badly, severe cases of dry mouth, it's horrible.
Yeah.
They can't eat, they can't enjoy food, they can't swallow. They feel miserable. They start having other problems, like maintaining their nutrition.
Yeah.
And a lot of people are trying to, it's like watching a action adventure movie. We're efforting that. lot of people are trying to effort ways of mitigating against dry mouth. And, you know, a lot of things are being tested, but no one knows what's going to work at this point.
Well, I see in a lot of papers where people still use the word. I love how sometimes we just use medical jargon to mean something so simplistic. They'll say, "Well, we tried cryotherapy to prevent dry mouth." I'm going, "Why don't you just say you used ice bags?" You know, I mean, like cryotherapy. It's like, come on, just use the regular jargon. So, are the ice bags helping with the dry mouth from Pluvicto and/or actinium, or we just don't know yet?
I think that our group was disappointed with the experience with that, but I honestly can't say that it's been systematically studied. It's a little bit of a hard thing to quantitate. I think now some people are generating the surveys and asking the right questions so that we can start quantitating what's really going on.
Yeah, because a guy I know that went to Heidelberg to get it, they were still putting the ice bags there to prevent the damage to the lacrimal glands or the area that produce saliva. So I thought that was just interesting.
Okay, I got fact or fiction for you. So is it quantitate or quantify?
It depends.
Does it?
Well, in my world, it does. Whatever comes to my mind at that moment seems to be the right one. So
okay, good answer.
What did I use? What did I say?
I don't know what you said, but it just jumped in my head that, you know, I remember when I was in school, people used to slam me for using one or the other, but I can't remember which one is appropriate. Quantitate or quantify?
Well, I don't know. I mean, what do I know? I mean, all I know is what you remind me, because I come from a different world, is that when you talk about most things in life, including diet or exercise or anything, you should always be careful to not just mention quantity or quantify, but qualitative. So you always have to use quality and quantity together. So for example, a lot of people will say, well, my diet has changed. It's a higher quality, but I'm still not able to lose some weight. And I say, but that's only one component. The other component is quantity. So you have to quantify it, not just qualify it. So there's a lot of focus on your quality. It's the same thing. It's like quality of life versus quantity, right? You want to live as long as possible, but if you live a long life and you're miserable, you're kind of going, wait, everybody always wants both. They want the highest quality with the most quantity. So that's what I think of when you bring that up. I'm not smart enough to tell you which one should be used at the right time, because I was probably out back with my friends trying to decide who I'm going to ask out in 5th or 6th grade when I was supposed to be in class. Again, quantity makes a difference. It's not just, so for example, I just had to review a paper the other day that looked at depression and exercise, okay? And I always argue that patients should be exercising and not just be sold on the physical. You should be selling the mental health benefits even more than the physical health benefits, even the cognitive benefits. And so what we're seeing in a lot of these papers where people are improving their mood, reducing their depressive symptoms, reducing their anxiety, is that you hit a quantifiable point where sometimes certain patients in clinical trials, you tell them to do too much exercise, it actually makes their condition worse. So there's a threshold where more is not necessarily better. And I was just reviewing that paper, so I just thought I would throw that in. So my answer is not worthless. There's something to be held there. And by the way, you made me think of that. One of the things I always tell people is as you get older, recovery becomes as important as the actual physical activity. So whenever you're dealing with older and older Olympic athletes, they'll tell you that they'll spend twice as much time recovering as they used to do 10 or 20 years ago, and their times become better and better. We are aging machines. So whether you're getting hormone therapy, whether you're getting chemotherapy, and you still want to exercise, that's great, but you also need to allow yourself plenty of recovery time so that you build up enough energy to get back in the game later. Some people literally work themselves out to fatigue. So that's a whole other factor fixing. You got me all excited. Ready for the next one?
Yep.
Provenge is the one and only immune therapy ever approved for castrate-resistant prostate cancer. Now this goes to, some testing and MSI high and all that stuff. But anyway, The fact or fiction, Provenge is the only immune therapy that prostate cancer patients can ever get. Ever get.
Fiction. So when a patient has advanced disease now with genetic testing, there are two parameters that you can look at that will tell you if you might not benefit from additional forms of immunotherapy. So the two things that you want to look at on genetic testing are levels of tumor mutation burden, and the other one is microsatellite instability index. So if the index for MSI, which is microsatellite instability, if that index is high, then you are a candidate for some of the more modern forms of immunotherapy, the checkpoint inhibitors, specifically Keytruda and Opdivo, which is pembrolizumab and nivolumab, and maybe ipilimumab, which is IPI. Another thing that you want to see on genetic testing that may suggest that your cancer has enough mutations and enough foreignness to it that it might respond to an immune response is something that's called tumor mutation burden. And tumor mutation burden is basically the number of mutations that you will see per segment of DNA. And I think that it's basically how many mutations do you see per megabase unit of DNA. And the number that jumps out is a number of around 12 mutations per megabase DNA or higher. So if a patient walks in, they have advanced prostate cancer, and their tumor mutation burden is 35 mutations per megabase DNA, what it tells me is that the cancer is so chaotic that it's probably going to start looking strange to the host immune system. And the host immune system is no longer going to say, oh, you're part of our body. The immune system is going to say, you're a predator, you're foreign, and we can attack you now. Once you achieve that level of mutation, then there's a chance that you will respond to those forms of immunotherapy, the checkpoint inhibitors. And generally speaking, the medical oncologist can file that information to the insurance company, and they will typically authorize treatment with one of those forms of immunotherapy, whether it be Keytruda or Opdivo.
Really good answer, because Provenge is used so early on in castrate-resistant prostate cancer, and then a lot of people think, well, I'm never going to qualify for another immune therapy again. But what a lot of people might not know about Dr. Kwon is he's actually run some big immunotherapy trials, and you're very excited about the possibility of a lot more men at some point in their prostate cancer journey qualifying for immune therapy. Fact or fiction?
Fact. You know, I was hired by the Mayo Clinic because of my interests in immunotherapy.
Yes.
And it was kind of embarrassing because, you know, they hired me to do immunotherapy, and we all thought that the first thing we'd go after is prostate cancer. And a number of trials were done on prostate cancer using the immunotherapies that we were developing, and those trials were disappointing. One of the trials almost resulted in approval. That was for ipilimumab for the treatment of post-taxane forms of prostate cancer, metastatic. We got close. We got within 0.0035 or something of getting approval there, but we missed the approval endpoint. So then everyone immediately thought, well, the reason that the trial failed is because we went after patients that were too sick. So instinctively, trials were built to go after the cancer when it was earlier on in terms of formation. Those trials did much worse than the other trial. And now, 20 years later, I'm sitting here thinking, well, the reason we failed is because we went in the wrong direction. We should have actually run the trials on guys who had even more advanced disease after failing chemotherapy, because that's when the cancer has become the most chaotic and the best target of an immune response.
Yeah.
So it took me 20 years to learn the lesson, but here we are now.
But now you have your clinics are busy enough that you are testing. You're doing enough genetic testing on a regular basis that you must once in a while see high tumor mutation burden. It's on the form. It says TMB. They just, that's the short of it, TMB. And if it's high, and then you see you look for another thing, PDL1, PD1, and it says it'll take you through whether or not you qualify. And then there's microsatellite instability high. So you must see a million of these reports. How many actually are coming back now that you're seeing that shows that someone qualifies? And then of that percentage, how many do you see actually respond to these newer immune therapies that are approved for so many other cancers right now?
I think that we presented at ASCO this last cycle, or GU ASCO this last cycle, around that. If you follow these cancers successively, these men with prostate cancer, that about 40% of them will show that their tumor mutation burden is rising. And what's really interesting, I've had a collaboration with Guardant, the company Guardant, and they permitted me to look at their data on other malignancies. And it turns out that when a patient goes to their doctor and gets a Guardant test, patients with melanoma and renal cell carcinoma or bladder cancer, they'll have the highest level of de novo tumor mutation burden, which is interesting because those are historically the forms of cancer that are immunologic targets. The cancers that have the least spontaneous mutations are things like prostate cancer and breast cancer. They have very low level of baseline mutation. However, over time, that level of mutation goes up, especially over time and with treatment. And so the moral to the story is that if you fail multiple therapies with prostate cancer, sometimes that looks bad in terms of spirits and morale, but in terms of therapeutic option, it might be a good thing because you may be opening the door for immunotherapeutic treatment. And we do see patients at the very end who have failed 8 or 9 therapies that suddenly become candidates for immune treatment, immunotherapeutic treatment, with excellent response to therapy.
Yeah.
So this is something that we're getting a handle on right now, but it's definitely interesting because it explains a lot. Why we failed with immunotherapy early on, which is the right population of prostate cancers to treat, et cetera, et cetera. Why does melanoma respond, whereas prostate cancer is a little reluctant?
It's incredibly fascinating, but I think, see, you did win the A+ award today because you show on that slide, one of my favorite slides, you show all these immune therapies, and to the average person, they're going, "What? I've never heard of those other ones." And now you've explained how you possibly qualify for that, which then leads us into one of the ways you qualify to see whether or not you may be a candidate for one of these drugs, or another type of drug is a liquid biopsy. So fact or fiction, one liquid biopsy is better than no liquid biopsy. In other words, everyone at some point, you probably would agree, should ask for a liquid biopsy, but you tend to lecture more about multiple liquid biopsies. So I'm kind of answering this question for you, but fact or fiction, just getting one liquid biopsy is better than doing nothing.
That's fact.
Okay.
You want to get a liquid biopsy or some kind of, the bottom line is that the genetic profile of cancer shifts. It changes. It's just like COVID. COVID shifted and changed and mutated. Anything that's natural, any biological system is going to change and adapt, and you have to constantly reassess as you're treating this form of malignancy.
But this is what you wrote in your conclusive slide, that you should be looking to get regular genetic testing, not just to have it one time, but if your disease is progressing or whatever your situation, you're saying, you used the word repeat in your conclusive slide. I wrote this down.
Yep.
You
Yep.
said try to repeat genetic testing, not just one. Can you expand on that?
So if you have advanced prostate cancer and you're on hormone therapy and you got a genetic test before the hormone therapy, and then the cancer comes back while you're on the hormone therapy, the cancer that's coming back is going to genetically look different than the cancer you started with. So whenever you start a new treatment because the previous treatment has failed, you definitely need to repeat the genetics. Because each time you fail a therapy and start a new therapy, you're basically treating a new form of disease. You can't just assume. And the biggest mistake I see is that patients will say, well, I did the genetic testing on my prostate that was taken out 20 years ago. And it's like, well, that ship has sailed. That's irrelevant to where you're at now. The genetics of cancer that spreads to a different part of your body is going to look different than what was in your prostate to start with. 20 years of intervening therapies are going to change what that thing looks like. Genetics change so dramatically that you could fail a therapy 3 months ago and the genetics of your cancer can be totally different. So as part of our regimen, we typically will recheck genetics on anyone that is failing a therapy, even if it's 3 months ago.
Anyone that fails a therapy. So you must deal with patients who get many liquid biopsy tests. And by the way, how do you do a liquid biopsy? Do I have to pull out a piece of tumor, or how it's called liquid? Can you walk us through
Blood
that?
test, just a
Okay.
blood test.
And then how long does it take to get the
The
results?
way it works is they take a blood sample. They will actually enrich that blood sample for circulating tumor DNA. And then they basically will process it to see what genes are represented by that circulating tumor DNA. And typically the results are back within a couple weeks.
Okay, so this sounds great. So every time I'm dealing with advanced disease, for example, I get a new liquid biopsy. Great. So I might end up with 4 or 5 liquid biopsies working with Kwon. Now, sorry to say this, but those things ain't cheap. Are those getting paid for? Or are those things you got to fight insurance for? How's that working?
Sometimes you have to fight insurance, but sometimes they're paid for by insurance. Yeah. It's just like anything we do in medicine, sometimes you have to fight insurance for it.
But if someone's getting a repeat or a second or third liquid biopsy, do you often see those covered, that you don't get much pushback?
We don't see much pushback.
I'm going to make you look good like I usually do. PSMA PET scanning is better than any other type of PET scan. And that means what I'm saying before you answer is PSMA PET scan. Now there's so many different types. We obviously know it's a great option, but there's choline, which you primarily get at Mayo. There's fluciclovine. That's been out there for a while. There's FDG, but factor fiction, the newer PET CTs, the PSMA PET CT scans are better than any other type of PET CT scans. Factor fiction or a little of both, or how do you answer that?
I think that the fact that the PSMA PET scans are readily available to everyone makes them better, because not everyone has choline. We're the only ones that have choline. I think that you also kind of have to define kind of what you're looking for, but I would say that the PSMA PET scans are definitely easier to read than the metabolic PET scans. So even to groups that are not so experienced with PET imaging, or even to physicians that are not that experienced, you can see things easier on a PSMA PET scan. Having said that, though, there's a role of all of those forms of PET scanning, And the more we use PSMA PET scanning to treat patients, the more we're realizing that it has pros and cons in terms of helping us judge what's going on with a patient. So I would say that the future that I see is a future in which there will be multiple forms of PET evaluation for advanced prostate cancer that will help doctors make the right choices in terms of therapy moving forward. Does that make sense? Sort
Yeah,
of?
yeah, but I think what you in the past, what you've driven home, a nice point that you've always mentioned is, first of all, the idea is you want to get a PET CT. You want to realize that's state of the art whenever they're looking for where your cancer is. Second of all, if not, something doesn't show up and people are getting frustrated, they can't find it, sometimes they have to go to an alternative type of PET CT, right?
Yeah, we have to right off the bat recognize the fact that it's been estimated somewhere between 10 to 20% of patients will have forms of disease that cannot be seen on a PSMA PET scan. And I personally, I don't have the data to back it up yet,
Yeah,
but if you already have 20% that don't have disease that's evident on a PSMA PET scan, it's not hard to envision a situation where if a guy has 100 spots of cancer inside their body, how do you know all the spots are lighting up? So, due to the disease heterogeneity and the instability of disease inside the body, I would not be surprised that over the long run, we find out that the PSMA PET scan is only showing us 80% of the disease within a given individual.
yeah.
So,
How
these are
many,
things that we're going to learn about.
yeah, how many of those guys do you know? Rising PSA, no one can find the cancer. They've been treated already. They do a PSMA or they can do a choline, can't find it. And then they just switch to a different type of PET CT with a different radio tracer and whammo, there it is.
And
You
we're
have
really
those cases.
the most obvious manifestation of this discussion is post Pluvicto. So a lot of patients will get Pluvicto, which targets the PSMA positive population, but there are subsets of patients that you treat with Pluvicto. The PSMA positive disease disappears, but the PSA keeps going up.
Yeah.
And then you find out that, and that's why a lot of people are saying, well, you need a metabolic scan, you need an FDG PET, or you need a choline PET, or you need an Axumin PET. So I think that we're learning that, multiple PETs are probably going to be necessary to render a comprehensive overview of what's going on in a patient. And they're going to be required to really follow what's happening with a patient.
I want to go through your last slide just in the Moyad head, if you don't mind, really quickly. All
Okay.
right. I just want to see what makes sense to us. Because patients are going to look at your last slide that you showed at the beginning of the program. Because again, to remind patients in the audience, I asked them to pick his top 5 or 10 slides. You say follow up every 6 weeks to 3 months with your doctor. And I'm going, that's great, but are you implying in person, or that can also be by Zoom and computer, right?
Yeah, I mean, it depends on how doctors set up their practice. For me personally, if there's imaging associated with it, I like having patient in the
Yeah.
room with me so I can go over the findings. I prefer in person.
But you're requiring really regular follow-up visits. I mean, every 6 weeks to 3 months, that's a lot of visits. And this is your standard.
Yeah, of course, in our clinic, we have very high risk patients that can,
Yes.
explode very quickly. So we like to keep a pretty close eye on them. I've been doing this for a long time, and I have not found any shortcuts that work. The reality is that you can never assume anything. You have to image them. You have to meet with the patients face to face, and you have to look at all the data. And, no matter what you think, you can have a patient 5 years later that suddenly catches on fire. So there's just no other way. I mean, other people do it other ways, but that's the way that works best for me.
Well, then that brings me to your second point on your last slide. You say repeat blood tests. I'm going, fine, that makes sense. PSA, but then you throw in a couple curveballs. You say, I also want to see an ALK, phos, and testosterone measurement. Will you please explain why you want that measurement, ALK, phos, and testosterone? Why did you highlight those two?
alkaline phosphatase can sometimes indicate disease that's chewing at the bones. And it can be sinister. I mean, it can happen quite quickly where someone all of a sudden has an increase in their alkaline phosphatase, and you already know that they're trying to develop metastases in the bones. Testosterone is useful because a lot of our patients are supposed to be on hormone therapy. And in that situation, you would expect to see a castrate level of testosterone, one that's very low, especially when patients are getting their treatments through their local physicians or they're traveling around from center to center. You want to know, are they really on hormone therapy, and is the hormone therapy working? Some of the patients confuse, bone therapies with hormone therapies. They think they're on hormone therapy, but they're not really on it. You need to verify all that stuff.
Okay.
And
Then
especially now with the oral drug Orgovix also. So Orgovix is a relatively new drug, and it's oral, and it has a very fast on-off time on it, meaning that if you don't take it, your testosterone can come up very quickly. So it's been very useful for us to gauge whether a patient is maintaining very tight control over their testosterone when they're on agents like on Orgovix.
Yeah, it's a good point. Then you say, try to repeat something. You talk about PET scanning. That makes sense from our discussion. You say obtain alternative conventional imaging once in a while to look at the rest of the body. What do you mean by that?
So PET scanners are brilliant, and they're really amazing forms of imaging, but they do have blind spots. And one of the blind spots that gets me once in a while, and it's really horrible when it happens, is the liver. The liver is hard to see on a PET scan. The liver is hard to see on a CT scan or an ultrasound for that matter.
Right.
So occasionally with some of these patients, I will get abdominal pelvic MRI, especially to look for metastases that might be hiding in the liver, because when they happen, they're horrible. The other reason that you have to get pelvic imaging is PET scan's not very good for looking for little things in the pelvis. So if there's a little thing that's kind of coming back around the bladder, you're not often going to see it with a PET scan because the bladder is so bright with PET agent. So sometimes you have to get an MRI to really see what's going on down in the pelvis.
I definitely asked you twice as many fact or fictions than you probably agreed to. Sorry. But this is part of your punishment for calling me at 6:30 in the morning thinking I'm always awake when you're awake.
You forgot to ask me about this package that's sitting over here.
Yeah, so that's the last thing. I mean, this was very much driven by Alex. She thought, I thought to give you a puppy, and she thought, yeah, he probably can't take care of a puppy. He's too busy taking care of people in the clinic every day. This is from the heart. I don't think you've ever received such a gift in your life. I'm convinced. So
I love gifts.
You're gonna love this. You're gonna love this one. This one really shows how PCRI is family, and we kind of get to know everybody, their quirks, their pros.
By the way, so I was trained as a surgeon, so I should be able to open this, right? But I am having trouble. But I was going to share with you, I tend to be a big fan of eBay, and so
Really?
I ordered. Yeah, my entire outfit comes from eBay, but that's a different story. So the funny thing about eBay is they throw things in these kinds of envelopes, and I have gotten stuff from eBay, and then I've cut it open with scissors and cut right through the thing I got from eBay. So I'm trying to be very careful here.
Yeah, you got to be careful.
Through the first layer.
Holy moly, it's not only got an epidermis, it's got a dermis. I didn't know that.
Now I'm getting excited.
You want me to sing the Quonology song? Quonology.
Oh my God.
Quonology.
All right, here it is.
Hey, what's this say?
Doctor Quonology.
Oh, look at that. It says Dr. Quonology. Huh. And I was just singing that song. What a
Fabulous.
coincidence.
Fabulous. And it's the right size and everything.
Do you see that? You see yourself wearing that in the clinic every time you go in?
Honestly, no.
No, okay. Well, then where do you see yourself wearing that?
I can see myself in my little music studio, definitely wearing this and being nice and warm and cozy for sure.
Well, that's just a way of saying thanks. I mean, we did over 2 hours here of more fun, informative stuff, and you always give so much time, and we have a good time doing it, and we know we're helping a lot of people, and we always get these requests, but we want Dr. Kwon at every meeting. You know, we got this huge fan base. It's like, Dr. Kwon, we get it. I'm trying to get him on there. So
the biggest thing that, you know, I want to convey is, to be honest with you, I just cannot think of a more useful application of my time and energy. You know, the reality is that, you know, patients, I think they benefit from some of these discussions, and at least I hope they benefit from the presentations. And, you know, if we can save various people 5 minutes, 5 hours, you know, any kind of agony, anything, if we can do anything for these patients that makes their life a little bit better just by doing this kind of stuff, then you cannot monetize that. You cannot quantify how wonderful that is for that patient. I constantly think about, you know, if I get a diagnosis and, you know, the agony of making an appointment, the agony of arguing with an insurance company, the agony of dealing with a doctor who's dismissive of my situation, or someone that doesn't understand things, or the difficulty of, you know, getting a scan over here and getting a biopsy over here. And then, you know, these patients that travel from institution to institution. Whenever a patient comes to me, I just am so flattered and honored because they've taken, you know, a big chunk of their life juices to come see me, and they deserve the best attention and care possible. So when we do these things, you know, I don't care how much time I put into it. It always makes me feel better, especially if it's useful.
Hey, I can't wait to do this again. We got another Fact or Fiction coming up at some point. So thanks for everything. I really appreciate it.
Yeah, I've got next year's script in my head. I've already started working on it in my head. So that's where everything has to start. All right.
Yeah. All right. Thanks, Eugene. I'll see you soon. Thanks, Dr. Kwon.
Thank you, Dr. Kwon, and thank you, Dr. Moyad. That was so helpful. Now, before we get to our next session, I just wanted to take a moment to thank our sponsors, Janssen, Bayer, Pfizer, and Dendreon. You know, you can check out their exhibit hall at PCRI.org, but all the information that we're able to give here and give to you for free is because of really great sponsors like them. They have their booths in the exhibit hall, and you can find out more information on their treatments, their resources, and the guides that they provide. There's a lot of helpful information there, so I would really encourage you to check it out. In our next session, we have our extended Q&A with Dr. Mark Moyad and Dr. Mark Scholz. Now, Dr. Moyad has done an incredible job moderating this conference, and we're so grateful for him, not just for his moderating, but all the research he does and the clarity that he brings. I'm excited to have Dr. Moyad with Dr. Scholz again because it's the academic viewpoint and it's the private practice viewpoint put together, urology and medical oncology, and together they're going to be answering your questions. As you know, Dr. Scholz is our executive director here at PCRI. He founded us over 30 years ago, and he's a full-time medical oncologist who's focused his entire career in prostate cancer. If it wasn't for him, we wouldn't have all this free information on the channel. Our team, and I speak for the patients, we're extremely grateful for him. So without further ado, here is Dr. Scholz, and here is Dr. Moyad.
Hey, there he is, the man, the myth, the legend. How are you doing?
Good to see you, Marcos. So glad you can do this. You've been awesome with all of our amazing speakers, and what a joy to be able to kind of go through and cherry pick the really hot stuff.
Yeah.
that catches both yours and my attention.
Yeah. In the words of Donna Summer, hot, hot, hot stuff. So we want to start off by giving you a gift. Is that okay?
Oh, okay. I'm all right with
Okay.
that. What do we got?
Word on the street is that you had a birthday, a very important birthday, and I made you a sign.
All right.
I put happy 90th minus 21 years birthday. Dr. Mark C. Scholz, you are the XY chromosome. Get it? Like you're the man. So you're an XY chromosome. It's you. You just had a birthday, and happy birthday. I think you look incredibly well, and you're definitely fit for your age. And I love it that you're wearing it proudly.
I had a delightful time. There's about 100 miles east of LA. There's a area called Palm Springs, which is a desert area. I know you've been there many times, and it's like summertime out there, even in December. And so Juliet and I go out and we watch tennis matches and go to dinner and slow down. And it was a great birthday this year.
That's awesome. But before we celebrate your birthday present, I'm going to show everyone in the audience what kind of relationship. It's like we're the odd couple. Here, I put Dr. Scholz. Only 2 simple questions correct, and you get free dinner for life every time I see you. All right? All right. The first
These are going to be tough questions, I'm sure.
What college football team won the most recent national title?
I want to guess Michigan, even if it isn't true. So I'm going to guess Michigan.
Correct. 1 for 1. You are this close to getting free dinner for life. Are you excited?
Right.
You should be. The chances that you get this next question right are 0, though, but I'm going to ask you anyway. What team did they beat to win the national title? And I put some powerhouse examples: Alabama, Ohio State, USC, all powerhouse schools. And what team did Michigan beat in the final game to win the national title?
So what are my choices?
For life.
What are my choices? Ohio, USC, and what?
I said Ohio State, USC, Alabama are just 3 powerhouses. It could be those 3. It could be someone else. I'm just trying to show the audience how you don't care about my hobbies.
So that's misdirection then. All right.
Maybe or maybe not.
I'd probably know if it was USC, since my daughter was a fourth generation USC alum. I have absolutely no idea. And I think it was Ohio I would have heard about it, because you guys are really strong competitors, right? So I'll go with Alabama.
Sorry. Thanks for playing, though. In fact, you know what? I have designed something for your birthday, if you don't mind. Are you ready for this? Your first question was right. Your second one, all right? Your second one gets this. Are you ready? Sorry, that means you got it wrong. So the answer is Washington. So unfortunately, you don't get dinner for life from me. And I proved to the audience that all this guy does is prostate cancer and tennis, and he really doesn't follow football, which is incredible how we became friends. I just don't know. But all right, you ready for your birthday present? Let's bring it out. Bring out his birthday present. Happy birthday to you.
All right, what do we got?
To you. Oh, you're going to love this. This is probably the best birthday present we all came up with. Look at that. Look at that. It's a prescription mug of tennis. Read it. See, it has your name on it, right? Read it. Read what the prescription says.
Play for 2 hours as needed until your mood improves. It may cause happiness, laughter, and unexpected brilliance.
Yes.
And then refill when empty.
And it says, for best results, take with friends. Discontinue use if tantrums arise.
Well, this is very timely. This is like my first cup of coffee in probably a year.
But we'll come back to this point. But the reason the cup was so important is that we constantly stress during the Q&A that physical activity and exercise is great to make you feel just physically better. But it really should be prescribed for mental health. It's such an incredible mental health booster, reducing the risk of depression, anxiety, stress, helping
memory loss.
Memory loss. It's incredible it should be a prescription with every single drug treatment, Before we did the Q&A this morning, I said, I'm just going to be on the top of my game. I went running for a little bit more than 6 miles. I'm at the top of my game and I'm feeling good. You're in trouble, baby. All right. Are you ready?
I'm ready. Let's jump in.
All right, let's talk genetics first. I want to get your just overall thoughts on the genetics lecture and just, what comes to mind when you think of the genetics lecture? Go.
What comes to mind for me is the struggle that I have in communicating with patients so that they can have a sense of proportion in the decisions that they make. The talk was beautiful. It was very easy to understand, even though these are fairly challenging concepts, and I enjoyed it a lot, actually. And when you have a talk like that, it allows you to sort of summarize it in its entirety. It had a very cohesive, he talked primarily about the germline type genetic testing. The germline DNA is very relevant in trying to decide if you have, if your children might catch prostate cancer. If you have prostate cancer, are your children more likely? And he went through that in detail, pointed out that yes, indeed. And as you get more and more people in the family with prostate cancer, your chances, if you're in that family, go up. I respectfully disagree, though, in practical terms, with the conclusion that if someone is at higher risk, that we're going to start testing at a younger age, PSA screening, looking for cancer. It sounds kind of logical on the surface, but in practicality, it's so easy to screen for prostate cancer. If we want to catch it, why wouldn't we screen everyone? Having a favorable genetic profile doesn't guarantee you that you won't catch prostate cancer at an early age. It only means that it's less likely. Less likely is not good enough. I think that if people have the resources and the time, and of course there are problems with screening that we've all heard about, where people get sucked up into the system and get an unnecessary radical prostatectomy, which is a real
or radiation treatment, or radiation,
or any kind of fear mongering, even active surveillance. You get diagnosed with a low-grade cancer,
yes,
and you do the right thing and you watch it. There's a lot of anxiety associated with that. So my point is this is a common statistical error, I think, that's made, and we've talked about this a little bit in screening for heart disease. When you if someone says there's a 2% chance of having, let's say a 65-year-old gets one of these heart scans, there's a 2% chance he's going to have a heart attack in the next 10 years. We pat him on the back, say, that's wonderful. You're much better than average. And if someone gets a heart scan and they've got a lot of plaque, we tell them there's a 15% chance you're going to have a heart attack in the next 10 years. And we say, oh, you better take precautions. The trouble is that a 2% risk of something, although it is low, if you're in the 2%, it's 100% for you. You still had a heart attack, and it might have been preventable if you'd taken appropriate precautions. So I think that even though we can show the family history with, germline genetic screening and looking at family history and all these factors, we can tell people you have less risk, you have more risk, but I don't think it argues for changing our screening patterns. I think everyone should be screened, even when they're supposedly at less or lower risk of catching it, because there are still people who catch it. And of course, we want to catch those rare individuals at an early stage, just as we would want to catch the people that are more likely to get it at an early stage.
I see what you're saying. I'm going to bring up some situations where it's a little different from screening, but you just made me think of one of the biggest controversies going on right now is, and again, this is somatic testing. Part of the reason we had a germline testing lecture was that no one has ever tackled that by itself.
Mm-hmm.
And so we just decided, we want to be the first to do a lot of things that we think are appropriate. We get so many requests that, can someone just tackle this subject? And here's someone who basically works in it full time. But it makes me think of, when you talk about screening, and it's a relevant point, right? What's hot right now are doing liquid biopsies earlier and earlier. So now there are all these commercial tests that people want to find out by doing a liquid biopsy, whether or not they have any free-floating DNA out there that might suggest they have a tumor, right? So everybody's talking about, hey, finding it earlier and earlier with these tests, but that has its own set of issues. I don't know if you want to comment on it before I comment on it.
Yes, that is, I think, very relevant to this argument, is that if we have a potential window into catching what would be a rare occurrence, catching a pancreas cancer, a lung cancer, a bone cancer, a brain cancer, at an early enough stage to cure it, which is not usually the case. Usually these tumors, we don't have a PSA-like blood test as for these other tumors. And so they show up when someone says, hey, this hurts. And it's a metastatic spot, and the disease is no longer curable. So PSA, because it gave us that early window, changed the landscape, and now we don't think of prostate cancer as being anywhere as nearly as dangerous as those other cancers that I just listed.
Yeah.
So now that we have these cell-free DNA tests where they can look if in your bloodstream for very tiny amounts of cancer-related DNA, will that be the onset of a PSA-like test for these other very scary cancers? And there's no doubt that the technology is able to, in certain instances, catch these other more rare, they're not rare tumors, but catch them at an early enough stage where they may be curable. As you know, there's going to be all the same problems that we had with early PSA testing, where once these cancers were discovered, it wasn't realized that at least half of them, half the prostate cancers, were of a harmless variant that never spreads. And one of your speakers pointed out that over 1 million men have had unnecessary surgery and/or radiation. The people that were saved were blessed, and we're very grateful for that. The people that got unnecessary treatment were cursed by it. So that is also a risk with these new cell-free DNA tests, because if you find something, then finding the actual tumor when it's small may be difficult. Could it create a lot of unnecessary anxiety? Could it create a lot of unnecessary scanning and biopsying? And yes, it could do all of those things. So it took us 30 plus years to figure out how to balance out the PSA confusion and start to get a sense of what's going on. And the industry is still charging along with, 10, 15 years out of date, and they're still doing surgery and radiation on people that don't need it. It's still happening, sadly. So with that caveat, and I'm sorry to wax so long on this, but
but it's an important point. It's one of the most common questions I get from just out there in the sphere. My doctor brought up this liquid biopsy test. I don't have cancer. Should I get it? And I always say, look, you're going to hear plenty of pros. But now let me tell you about the cons. That's my job, right? And you identified one of them. And another one that should be identified is in the early preliminary testing of these things, they're very good at identifying later stage disease. They're more questionable right now in terms of early stage, in terms of their track record. Second of all, they haven't been proven yet to reduce cancer-related mortality. Now, that may come, but I don't know if I want to be the guinea pig for that. And then third, what no one ever talks about is, when I used to get hired, people wanted to hire me away from Michigan to run clinics. They would hire me to say, hey, wouldn't it be great if you were the president or CEO or the person that led this full body scan clinic? And I'm like, what do you mean full body scan? Where you're perfectly healthy. Remember all these scans? And we're going to do a full body scan on you, whether it's an MRI or CT or whatnot, and we're going to find cancer early. Remember all the hubbub about that 10, 15 years ago?
Well, wait. You preempted me. That's where I wanted to go next with this discussion. 15, 20 years ago, they used CAT scans. And they were pretty much abandoned except for one purpose, and that being to check for plaque on your coronary arteries. That was the good part.
Yeah.
The rest was they were finding all kinds of distals and shadows and spots, leading to all kinds of consternation, and almost never turned out to be actionable cancer. What I was going to ask you is that
yes,
there's a new wave now of using high field strength MRI in exactly the same role as it was for total body CT scans. So we know that total body CT scan was a bust. Those companies all went bankrupt and they're not around anymore. But there's a resurgence in total body MRIs. And I've given this some thought, but I want to hear your thoughts first.
No, my thought is, okay, so now we don't give you radiation, but my thought of all these screening tests are the same. I think we share that philosophy is you better dang, notice I use the word dang. I'm not going to use any bad language. Dang. You better dang well know the pros and cons of what you're getting into before you get into it. I want to use me as an example. I'm in my 40s. I got lots of connections. I got a friend who owns a full body scan place in one state I'm not going to mention. He says, I'll give you one for free. It was an MRI, by the way. And the reason I did the scan was because we have a lot of people who have died young in my family. I have one person in particular that I look like that died of an aneurysm, a berry aneurysm. And so anyway, he said, I can take a look at your brain, see how it's functioning. Of course, it's going to come out to be stellar. It's a very pretty brain. So I go in there not thinking about the pros and cons because I want to see what's going on in my brain. So my brain, takes a look and says he's going to look at the rest of the body for free because I'm a friend. All right, no problem. I sit down with the radiologist. Long story short, he goes, Circle of Willis, everything's looking really good. I went, best day of my life. I've been waiting for this.
But that's techno speak. So no berry aneurysm.
Right. Nothing going on in the brain right now you should be concerned about. But then he goes, well, we looked at the rest of your body. You've got a lot of cysts on your liver and kidneys, a lot for your age. And all I remember is walking out of there. Here, I just wanted to hear about my brain. All I have done is instead of being joyous for the next year, I walked out going, oh my gosh, I got all these cysts. Oh my gosh, I got to have these looked at. I completely got way too much information. It made me so anxiety prone. And I use that as an example of be careful what you sign up for until they show data. Because if they're not showing data that they improve your life, you've just become one of the guinea pigs for that data. So that's my worry. That's my worry.
So this expands to this whole idea of genetic testing too. Because the chances that the genetic testing is going to move the needle powerfully, and we're talking about germline testing. I'd say the strongest argument for doing germline genetic testing is if you want to pass on some information to your children that might be actionable. That I suppose is a pretty solid motive. We've got BRCA in our family, not me personally, but let's say I did. I would definitely want my daughter and my son to know that. So that's a strong argument for that. But the exact same thing can happen. They can give you a long list of weird mutations that you have, and you have no idea what the implications are. Or sometimes you know what the implications are, but there isn't a dang thing you can do about it. I use that word dang again out of respect for you.
It's very contagious, that word. It's very contagious. But I think this is part of the mantra, the thinking into where part of prostate cancer got overdiagnosed. That's what you're saying. We have a test. Anytime it shows some volume, it shows that it's moving toward a high area, then we need to be biopsied, right? And we realize now it comes with catches. Just to rely on that to be biopsied, just to rely on that to discern whether or not you have significant or non-significant prostate cancer. So I'll tell you during the Q&A where the most controversy was with germline. And I don't know your opinion, but I know darn well what my opinion is evolving toward. I think we're germline testing. And again, for the audience, the sign that I held up all the time, that's what you were born with from day one. Somatic tests is the tumor. All right. Here's where I wish there was more discussion. Are you ready for this?
Ready.
Active surveillance. Okay. Now give me the stage for a second. We know that family history is a pretty wimpy predictor of whether or not you're going to come up with one of these mutations that's serious. We used to think it was a good predictor, and now there's a new study called the IMPACT study, where almost 70% of the positive men for BRCA didn't have the family history that would qualify them to necessarily look at BRCA. Okay. So now you have all this list of criteria that you have, Klotz has, for active surveillance. You got to follow this. You got to do this with PSA density. You got to do the MRIs. But we also know preliminarily, again, I'm going to focus on preliminarily, that if you come up BRCA positive as an active surveillance patient, the chances that you may have to move on to treatment or may progress to a more aggressive disease right now in the data is significantly higher. So I'm going to play angels and devil's advocate. Why not offer everyone who's considering active surveillance a germline test? Why? I'm not saying you have to have it. Why not at least have it come up in the discussion?
Well, I think the reason is, and this expands to other types of genetic testing in this setting as well. So the whole world of active surveillance historically has been embraced rather reluctantly. The idea of watching cancer is very counterintuitive. So they were able to demonstrate that it's safe to do active surveillance, 10, 15 plus years ago with no MRIs, no PET scans, and tremendous ignorance about how prostate cancer behaves because we've learned so much more in 15 years. And they showed with those crappy tools that you can safely do active surveillance. Now, does that mean that the industry embraced it? No. It's so counterintuitive to watch cancer that
Absolutely.
I'd say we're lucky now if half the men that are eligible for active surveillance actually get it, even today. Do I need a new test to scare people out of active surveillance just because they show that we can refine the likelihood that you're going to go off active surveillance at some time in the future? That's true. I don't deny that. You can refine that analysis. But that's not the analysis. Let's say that you are a 65-year-old guy and you're projecting everything looks hunky-dory, and we say you've got a 10% chance that you'll have to go off active surveillance in the next 10 years. And then we get a BRCA positive, and we say, oh, now your risk is 30% chance that you're going to have to go off active surveillance in the next 10 years. I don't know why people all of a sudden jump and say, well, that means I can't do active surveillance. We already know from vast experience that if you surveil people closely and act at the time that you're supposed to take action, that your cure rates are the same as if you got treated the first day you were diagnosed. So active surveillance is such a safe methodology. I don't think it matters whether you're BRCA positive or negative as you embark down that pathway, as long as you follow stringent surveillance techniques. Now, all that being said, would I deny someone that wants to know what their genetic status is? Absolutely not. And there may be some very risk-adverse people who would like to, who are extremely uncomfortable with the idea of active surveillance and need an argument to not do it.
Let me bring up something that you know, but we never talk about. I understand what you're saying. Sometimes too much information is not healthy. I understand that. We agree. It's like the body scans. It's like, where are we going? Don't you find it interesting, though? Don't you find it incredible? Because my family has had so much breast cancer that today, if a woman is BRCA positive, strongly BRCA2 or 1, that they'll do prophylactic mastectomy. Some people will have their ovaries removed. They just don't want the excess risk. When's the last time that you heard of a man becoming BRCA positive and saying, I don't want my prostate, I want it to be taken care of, I don't want this risk because so many people in my family have died of prostate cancer? And you've met these patients where they're just riddled with prostate cancer in the family, early deaths. I know you have. I've met these people. And I'm just saying, don't you find it interesting that in breast cancer, you're being proactive if this comes up positive, for getting the test and then doing something about it? Yet in prostate, crickets, man, crickets. And that's the part that just seems
the thing is, I'm not sure I agree. I'm not a breast cancer expert, but but remember, most prostate cancer patients are my age. And, and if I can live another 15 years, I'll say I lived a full and happy life. Do I want to spend the next 15 years impotent and incontinent? I don't want to roll the dice unless I know that it's going to prolong my life very significantly. My life's not going to be that prolonged anyway. I think the bottom line of our conversation is that you ought to know your own psychology a little bit before you go into all this prognostic testing. I was confronted by a patient that you and I both know about whether he should get a total body MRI. And so I went home and thought about it. So I always start off by thinking, well, would I do it? And the analogy that I did, I said, well, let's say I had an MRI in my backyard that I could use it every day if I wanted, and it cost me nothing. Because these total body MRIs, they're charging like $7,000 for these things. Let's say it was for free and I had it in my backyard. Would I crawl into that MRI once a year just to make sure I'm not missing anything? And I thought, well, I'm not a very excitable guy. I can live with ambiguity. I can live with risk. I used to play poker and I was pretty good at it, incredibly sophisticated in terms of the relevance of all these different ramifications of reading scans and their limitations and whatnot. So all that being given with the right psychology, the right background training, the answer is if it was totally free, I probably would crawl into the MRI once a year and get the scan. For $7,000 a year, even though I've got $7,000, I don't think I'm going to do it. But yeah. But I'm not necessarily a typical person. Now, the patient that you and I both know, you may or not even know who I'm talking about as we speak. I'm going to tell him to be a little bit careful in terms of possibly ruining his quality of life for a very, 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 very tiny incremental improvement in saving his life from some unknown cancer.
And that's fair. I think the argument comes down to, I just want people to have the objective information of what they're getting into, because
they need to do their background work first.
Because a lot of people will automatically always lead with testosterone. They'll go, oh, I can handle it. That's not a problem. And then you talk to them a year later, they're going, what do I do? Oh my gosh. Yeah. It's like, I give the example of what I went through. I didn't really consider what else they'd be looking at and what else they might find. And I almost became obsessed for a year of what is happening to me. I'm falling apart.
I know you well enough, Mark. You should have called me first. And I would have said, Mark, you do not have the right profile, the psychological profile for this type of stuff.
I know, but it was free. I didn't have to pay. By the way, this is napkins. My son gave me.
No, this segues very nicely into what Dr. Raman was talking about with all his imaging of the prostate. You know what is exactly the same issue is what we call the random needle biopsy of the prostate. Now with the imaging, we can see where these little shadows are and we can target them. But the policy has been, well, let's just look at the rest of the gland with all these needle sticks randomly and let's see what we find. And gosh, what do they find? They find all the little specks of something called cancer. Now, if you read the bottom line, it says, by the way, this never, ever, ever metastasized. Ooh, but it's cancer. It's cancer.
Yeah.
And these random biopsies have been the root cause. Now, they were necessary up to about 2015. The MRIs weren't good enough, and we had to live with that ambiguity of random biopsies. Now, it's been clearly demonstrated that people who do random biopsies are uninformed. They either that or they don't have access to good MRI imaging.
I asked Raman, and in full disclosure, this Dr. Scholz brought Dr. Raman in. I'd heard his name, but he's probably the one doc out there I haven't met at a meeting. Maybe he said hi. He blew me away how good he was overall. I was just really impressed. But yeah, I mean, the idea that what I brought up with him in the Q&A was really educational. I said, well, forget prostate for a second. I know you've dabbled in liver and kidney. What's going on? He said, I'll tell you what's going on. Do you remember liver biopsies? I said, yeah. He goes, we don't even do them anymore. The MRI picks it up. We don't even have to do a biopsy. I said, you're not doing them anymore or hardly at all? He goes, not at all. I said, do you remember 10, 20 years ago, you would just fear the idea of getting a liver biopsy? He said, yeah, we're not even doing them. MRIs evolved to such a point where what we see is what we see. And I said, do you think we're going to get there with prostate cancer? And he wasn't willing to hedge, but it's a great example.
Well, let me jump in right there, because he also mentioned PET scans.
Yeah.
And we are seeing patients, again, some who have more money than they know what to do with, who get a screening MRI. They're slowly their PSA's up a little bit. They're savvy enough. They go get an MRI. And then they there's a small little shadow, maybe a PIRADS 3, PIRADS 4 lesion. PIRADS 4 means that it could be something consequential. And then we we say you've got two choices. You've got financial resources. You can go ahead with your targeted biopsy, which is the traditional approach, or why not get a PSMA PET scan because it's disease specific. It only lights up with prostate cancer. If this little shadow doesn't light up, 90% likely it's not prostate cancer, and we can keep watching it, make sure it doesn't grow or something. But if the PET scan's clear, probably don't need a biopsy. So yes, I think in some ways we are getting close to what's going on in liver cancer.
Yeah, that's just really unbelievable, isn't it? So yeah. I tried to bring up, I guess we're talking about Raman now, right? So we've moved on.
Yeah.
I
didn't have it. Let me see if there was anything else. I mean,
there's one other thing I'd like to bring up on genetics that wasn't brought up in the talk, and it's pretty critical. Are you ready for this?
I'm ready.
You could quiz 1 million people in healthcare, and I bet you they wouldn't. And look, I have to educate myself. And this is the beauty of PCRI. We realize information is coming so quickly that you need other people to accumulate it and go through it and then disseminate it. That it's just one person keeping up with it is too daunting. This is not, my wife remembers 25 years ago for family dinners, after dinner, we'd go to the library, the medical library, and photocopy all the journals. I mean, that was 25 years ago. And now if you go photocopy a journal, something's wrong with you. You can get it all online. Yep. So I thought this was really important. And I hope that Alex also highlights this in the Q&A. It's called GINA. So GINA is the Genetic Information Non-Discrimination Act. It kicked in on November 21st, 2009. So it protects you from genetic discrimination from health insurers and employers. And that's the good news. So if you end up getting a germline test, the good news is that you're protected, that they can't hold this against you. The bad news is, again, because my job is to play devil's and angel's advocate, is it does not cover life, disability, or long-term care insurance. So the catch with GINA is that if you're going to discuss a BRCA or anything else in the family, they have to know that if something comes up and they're a big fan of life, disability, or long-term care, theoretically, you're not protected there. You're protected generally from your employer and your own health insurance. I didn't know any of this until recently because I thought we would cover it in the talk and we didn't have time. But to me, this was one of the most important concepts to bring up when you start doing germline testing. You are protected in some ways. Other ways you cannot be protected. So this is part of just being careful when deciding when you want family members to start running out and getting tested.
Well, this is very practical also for men that have a high PSA and are considering a random versus a targeted biopsy.
Yes.
So I can't tell you how many letters I've written on behalf of patients to insurance companies in men that had a random biopsy and they're on active surveillance and they've got 3+3, everything's perfectly fine. Statistics show that prostate cancer mortality rates are lower in men with 3+3 than the general population, and it's obvious why, because they're under close surveillance. And the insurance companies, however, see the word cancer, and these patients can't get life insurance or sometimes certain desirable types of health insurance. So we write a letter with no expectations. The insurance company can do anything they darn well please. If they want to take this cancer diagnosis at face value and say this guy's uninsurable, that's their prerogative. And so this is a very practical, real issue that we see on a day-to-day basis in my practice.
Yeah, something to think about. I would have never thought of, like, I'm just going back. People want my opinion. I'm a big fan of just discussing the idea of germline testing in some situations, but yikes, I don't want some family member getting tested who wants to buy a bunch of life insurance and then it's going to be held against them. So I want to bring up one more thing with genetics that I also brought up in the Q&A. And you and I can talk about this in the fall conference, other places, but there are these other conditions that people think are absolutely rare, but they're not really rare when you look at the population. So something that we don't often talk about in prostate is Lynch syndrome. And Lynch syndrome is often, it used to be attributed to basically a high risk of early colon cancer. In fact, the old name was hereditary non-polyposis colon cancer. And the idea was that you would get a colon cancer, possibly aggressive at an early age in these families, and a lot of them didn't necessarily start with polyps. Turned out that's wrong. I mean, some of them actually do. But now that they've looked at Lynch syndrome, they found that it's associated with a lot of other potential cancers out there, not just colon. And prostate may be one of them. And I looked at the number, it's 1 out of every 300 people carry one of these mutations. The other thing I want to say about it is, even though it's called Lynch syndrome, named after Henry Lynch used the data from a University of Michigan doctor called Dr. Aldred Worthen. And he had a seamstress called Pauline Gross. And Pauline Gross came to this Michigan doctor in Ann Arbor and said, I'm not going to live. By the way, I'm your seamstress. I'm not going to live a very long life. And the doctor said, why do you say that? And she said, all these people in my family have died young of cancer. Now, this is going back to the 1800s, early 1900s. And he said, like, how many people? So he ended up doing all this genetics and realizing that these were all connected. And then Lynch came along, looked at that data, and is attributed with the name Lynch syndrome. But reality, it should be called Worthen syndrome, or it should be named after Pauline Gross. And so that's an unsung hero in medicine. Anyway, so Lynch, have you had Lynch syndrome patients? Because they can come up positive in a germline test and have a higher risk of prostate cancer. Or is it just something that you haven't dealt with?
Now we're talking about, we spent most of our time talking about the use of germline testing in early stage, but germline testing in advanced stage, boy, we scored the lottery. It turns out that Lynch syndrome patients who have prostate cancer, I have one, in fact, respond incredibly well to immune therapy. And that is such a joy, because the modern immune treatments, and there is a test now to ensure that you're at low risk for immune toxicity as well. But immune therapy can be a far less toxic and a far more effective way to handle advanced prostate cancer. And in someone who has metastatic prostate cancer, it makes all the sense in the world to get both your somatic and your germline testing to make sure you could score the lottery. If you came up with a Lynch syndrome, that puts another arrow in the quiver, and it's a big, powerful arrow.
I think it's so interesting that all these guidelines, NCCN guidelines and all this, they say if you meet these criteria, you should get genetic testing. And then it gives you a range of the genetic tests that you should have tested. In there are actually the genetic mutations for Lynch syndrome. So yep. It's a really fascinating syndrome. Do you know how many people I looked up? This could be wrong. I saw it in one database. Do you know how many people with Lynch syndrome know they have Lynch syndrome? It's like 5%, like 5 or 10%. Can you believe this? But you just bring up a really good point. In advanced disease, that could be a lottery win. So you test for that, and you have a patient with Lynch syndrome that responded to immune therapy. Oh my gosh, you made my day. Now I'm going to make your day further. Everybody talks about Lynch syndrome, 1 out of 300 people. Oh my gosh, it's everywhere. It's everywhere. Do you know what occurs in 1 in every 250 people? Familial hypercholesterolemia. Isn't that incredible? This goes back to our mantra. Everybody talks about the cancer mutations, but the reality is the cholesterol, this is a mutation where when you're very young, your bad cholesterol just goes through the roof, and people die of heart attacks in their 20s and 30s. They have LDL cholesterols of 300, 350, but this is actually more common than any other syndrome, have a genetic predisposition to carrying a very high cholesterol. So I just had to balance that. Anyway.
And of course, it's, you don't even need a genetic test to know that you're a risk, because
that's right.
As you and I many times have said, not only do you want to check your PSA, but you want to check your LDL cholesterol.
That's right.
Know your number.
Know your number. 90% of people with this genetic condition, 90% have no idea that they have it.
No.
Man, I feel like we're conquering just huge mountains today. We've climbed Everest a few times. Now we're ready to stick with Raman and just talk.
I want to throw out a deep and heartfelt thanks to Dr. Raman for his subliminal presentation of sharks and minnows. So I searched through my vast collection of ties. I couldn't find any aquatic type ties. The best I could do was a little fish here somehow got onto this tie, but that powerful idea, which he didn't belabor his rationale for why he's doing that. What he's saying, of course, is that that if you don't specify the subtype, let's say you just say there's fish out there.
Yes.
Well, fish, we eat fish. There's nothing to be worried about. I'm going to jump in the water and swim. Oh, I'm sorry, it's a shark. I should have told you it was a shark. I just said it was a fish. And so that lack of specificity about the type of fish, and I don't even know if sharks technically are fish or not, but you get the idea that when we talk about prostate cancer, everyone sort of registers it like it's a fish. And we know what cancer does. The whole idea of sharks and minnows, he kept coming back to that.
Yeah.
Was it minnows? Yeah.
Yes,
I mean,
it was minnows.
Yeah. So the statistics that he shared, I thought were very telling. So he says that 15% of us guys are going to get prostate cancer at some time in our lives. That's 1 in 7. These are easy numbers to remember. And of the people that get it, 15% metastasize. Again, 1 in 7.
Yeah.
So that's 1 in 49 of us guys that are going to get metastatic prostate cancer someday. It's 1 in 7 of us that are going to catch prostate cancer. So the idea of sharks and minnows is a powerful way to start thinking that what was called prostate cancer, when you were told you had prostate cancer, that's not enough information. It really tells you nothing. You have to know what type it is, and that extreme of something that metastasizes and doesn't metastasize is as different than a shark is from a minnow.
Yeah, it was really good. I had a shark minnow sign, and it's driving me a little batty that I can't find it. But what I said to him during the Q&A, and he got it wrong, I think you're going to get it wrong too, is I said, all right, sharks versus minnows. I said one of the most famous movie lines of all times is that you're going to need a bigger boat. Where's that from? And
well, if I hadn't seen the very first part of your Q&A, I never would have guessed that. What was the name of the shark movie that was eating people? I can't remember now.
Jaws, 1975.
Yeah, Jaws, yeah.
Roy Scheider said it. His name, he was a Captain Brody, as that was his tagline. And he sees the shark. He goes, "You're going to need a bigger boat." But it was really good the way he brought it up, sharks versus minnows, because people, I haven't heard that analogy.
So normally I don't like statistics, but I love that 15% of us get it. Of those who get it, 15% metastasize. And that's the real cancer, the one that spreads. That's the real one we have to take seriously. And
Yes.
We'll go into how seriously, because Dr. Kwon got into that very nicely as well. The other statistic, this was kind of a cool one that Dr. Raman shared. He said 70% of men who have a screening PSA above 4, which is the supposed golden threshold of when you start looking for cancer,
Okay.
will never, ever, ever, ever be diagnosed with prostate cancer. 70% of men that have a PSA above 4 will never in their lifetime be diagnosed with prostate cancer. So you say, that's terrible. Why do we use PSA? We use it for the 30% who do have the cancer, so we can scrutinize them more closely and find out if they have a shark or a minnow.
Yeah.
Yeah.
Well, that's a good point.
Yeah.
Yeah. He
I
had a
thought
lot.
that was really nice stuff. So no more statistics beyond those.
I thought my discussion with him on when he feels comfortable using gadolinium or not was really good too. I mean, people should go back and watch that, because at the end of the day, gadolinium is such a polarizing word for some people. And he really broke it down. He said, look, we've learned when we have to use it, ideally, and when we don't, and he breaks that down in the video. I won't go back through that. So I think he did a really good job with that too. Do you want to talk about PET-CT a little bit?
We can. Let's, he has, the UCLA department does a really beautiful job getting quality prostate MRIs. And it takes, he pointed out in his talk that they may be able to transfer that wonderful information and knowledge that they've gleaned there through a lot of experience into artificial intelligence, which would be fabulous. Because one of the problems that we see, as big a fan I am for imaging as a substitute for random biopsy, MRI imaging as a substitute, is that the experience in the general community reading these MRIs is limited, and there can be real problems and many false interpretations.
Yes.
So why do I keep recommending MRI when people could get terribly misled by someone that doesn't have enough experience to be reading them? You can always get it double checked. I send a lot, you can get the images on a disc, and I send a lot of these to UCLA for a second read, and they do two things. One, they look at the image quality, they make sure that the pictures are even good enough to interpret. Usually they are, sometimes they're not. And then, assuming they are of high enough quality to be interpreted, then you have someone that's looking at hundreds of these every month who's been deeply trained, has tremendous experience, and then you get a very confident readout as to whether there's anything there that needs action. I can't tell you how many times I've had patients who've had MRIs at unknown facilities around where it sounds like they're going to die. There's a big, problem here and there, and overread, nothing. It's problem free. So it really behooves people to do two things. One, if someone says your PSA is up, get an MRI. And then if the MRI comes back favorable, I don't tend to be as suspicious, because these less experienced doctors tend to overread to cover their assets, to make sure that they didn't miss something. And so they read stuff into these MRIs that really isn't there. But if your MRI comes back and it in the reporting format looks professional and they say, we don't see anything, overreads on that almost always are going to be confirmed that there's really nothing there, and that you can forego an immediate biopsy. Now, does that mean you can forget about it for the rest of your life? No. MRIs can miss 10% of small cancers. And because prostate cancer is slow growing, and if it were to grow over the ensuing year, it's not going to spread in that first year unless it's some freaky, unusual exception to the rule. And if it's a little bigger the following year, they'll compare the clear old scan with a new scan and look for any changes. And if they detect something a year later, you can have a targeted biopsy and still diagnose the cancer when it's curable and localized.
Yeah, no, I mean, that's a good point. I tried to show them the catch with MRI. You just mentioned it, and that number varies depending on the study, but it goes as high as, I probably brought it up, maybe I felt like it was 100 times. Why don't you advertise that you do second opinions on MRI readings? He said, we probably should. I'm going, of course you should. All of you shouldn't be shy. Just advertise it, because the average person in my hometown or somewhere else out east or south, they don't know that I can go send it. I mean, you're right there, but they don't realize that's an option. They think about that now with pathology. We've won that war, right? A second pathologist, no problem. Yep. A second MRI reading. It was so funny. That's kind of how we ended. And he's kind of laughed. And I said, I'm serious. You guys need to change the website. So I'm glad you brought that up. Yep. I also tried to trip him a little bit with, okay, MRI is great, and it is, but it can miss up to 20% of clinically significant prostate cancers. And he reminded me of something which you and I have talked about, which doesn't get a lot of attention. So I'm going to be Mr. MRI here for a second. Those 20% that are missed, maybe even 10, 15% of those have in general, when they test those and they go find those later in a study, they have very favorable characteristics. Yep. So, right? So what this is sold at is MRI misses up to 20%. You go, oh my gosh, what if I'm on that 20%? This is a bad shark. No, what he's saying is that a vast majority of the ones they missed look so similar to normal prostate tissue that they act like normal prostate tissue. Ergo, they are minnows in general, not sharks. That should increase your confidence when it comes to MRI. It shouldn't decrease your confidence.
Yes. Yes, and we know that this, with random biopsies, the threshold for going off active surveillance historically has been, after you jab needles all over the place, if you find a millimeter speck of something higher grade, get that prostate out or radiate that man today. That policy we know is, now why are we doing that? It's because the doctors don't want to have a single case on their record of anything untoward happening, and they're willing to treat 1,000 people unnecessarily to save that one guy. And these small amounts of slightly higher grade cancer are in most cases going to behave very benignly. How do we know that? I've been seeing men come into my practice over the last 30 years, didn't check their PSA, and finally 5-10 years after the last time they checked, their PSA is 75. And we get a scan on them, and there's a big goomba of a cancer that you can feel with your finger.
Huh.
And you get one of these newfangled PSMA PET scans, no metastasis. So prostate cancer has, in general, low metastatic potential. In waiting a year for someone that had an invisible cancer to go to a visible cancer, those guys are 5 to 15 years ahead of the guy that comes in with a spot you can feel with your finger.
Yeah.
That's a gross degree of very advanced cancer. The idea that every little speck of higher grade cancer, even though it's invisible on an MRI, needs immediate treatment, well, we know now is wrong. More and more men are embarking upon active surveillance with 3+4. So there's a little bit of high grade disease there. And small amounts, we know, also have low metastatic potential.
Yeah. I mean, so it really is a great advertisement for that test. It really has.
Let's go on and talk, as you mentioned, about PSMA. I already mentioned one new role, and that is a substitute for biopsy. It's an expensive substitute because insurance companies won't pay for it if people don't have a pre-existing diagnosis. But there's another role where insurance companies, especially Medicare, does pay for it, and that is in these men that have proven low-grade prostate cancer, they're 3+3, but their PSAs are running high. The so-called PSA density is elevated, and this is a very common scenario in my practice. The rationale, there's 3 reasons people can have a high PSA. Let's say they say you're low risk, but your PSA is 12. Well, you're intermediate risk by historical standards if your PSA is over 10. So does that mean we're being irresponsible in allowing that person to stay on active surveillance? Well, I think you have to scrutinize these individuals closely. And the 3 reasons that they can have a high PSA without necessarily being at increased danger of metastasis is 1, low-grade inflammation or prostatitis, 2, an enlarged prostate, 3, a low-grade cancer that makes a lot of PSA. So even though it makes a lot of PSA, doesn't mean that it's necessarily going to metastasize. So we're using PSMA PET scans as a tiebreaker in these people where we say, we're just so nervous about the PSA being up, we better just treat you to be safe. We get a PSMA PET scan, generally is covered by insurance because they have this is where having that low-grade diagnosis helps you. So insurance can, oh, he has cancer, we'll pay for the PSMA PET scan and confirm 2 things. 1, that there's no spots anywhere else. Of course, that would be the most important thing. But also that there's not another undiagnosed, heretofore unknown spot in some other part of the prostate that could be higher grade. Yeah. So it takes some of the pressure off us in this relatively common situation where men have low-grade disease by biopsy, but their PSA is running higher and makes everyone a little uncomfortable.
Yeah, and there are these cases out there, right? You see them. That's the MRI is saying, hey, everything seems to be fine. PSA is still going. Hey, your PSA density is changing. It's not 0.15 anymore. It's 0.20. It's 0.25. Well, that's tough. We'll just do another MRI. And I'm thinking, wait, why aren't they advocating for a PET CT here to be the tiebreaker at least, just to give them the peace of mind? It's so interesting you brought that up because that was going to be one of my questions, that why don't they use that as the tiebreaker more often?
Yeah. Well, we use it all the time. And there's another interesting situation. We know that the men would have the high Gleason scores, the 8s, 9s, and 10s, that probably at least half of them also will never metastasize. It's never talked about because no one ever watches them. Because if there's a 50% chance something's going to metastasize in the next 10 years, are you going to sit around and watch it? Absolutely not. You're going to treat it because you can't take that level of risk. But I have had so many patients who've decided to simply watch their high-grade prostate cancer against all my advice, who have, after 10, 15 years, never metastasized. And this came home even more strongly when these PSMA PET scans show that they've been on the right track, has actually saved them unnecessary surgery or unnecessary radiation. So where am I going with this? Well, the point is that as we get older, let's say you're diagnosed with a Gleason 4+3 or a 4+4, and you're 78 years old. And we know that average survival of a 78-year-old is about 10 years. And you have a PSMA PET scan that shows you have no metastasis. Well, that individual's already had cancer for a number of years up to the time of diagnosis. The PET scan confirms, as of yet, no metastasis. Doesn't that argue that this particular Gleason 8 in that particular individual has a lower metastatic potential than just any old Gleason 8 that comes through the door? Sure it does. And what if we were to say, we'll monitor this and get a PET scan every 18 to 24 months, and if nothing spreads, we'll forego treatment. Some of these men are still sexually active in their late 70s. So that sounds a little bit cavalier, but we're also learning from these PET scans with the metastatic disease diagnosed by a PSMA PET scan is not the same as metastatic disease diagnosed by a traditional bone scan or a CAT scan. What's the difference? With the old traditional scans, you needed a chunk of cancer a ½ inch wide to pick it up. And almost always there would be other smaller spots all over the body. PSMA PET scans were detecting things at 2 to 3 millimeters. And since we radiate a lot of these and sterilize them, in some cases, these men are getting cured. Yeah. So this idea of the sharp demarcation between no metastasis and metastasis, which has always been the watershed event in all cancers, happy, simple, easy to treat, no metastasis, deadly, horrible metastatic disease. Now, in prostate cancer with PSMA PET scans and the sort of slow evolving nature of prostate cancer, that distinction is being blurred. And with regular PSMA PET scans, we're going to find some early metastatic disease that we can still cure. Yeah. So this idea of watching some of these older men with who don't have ideal Gleason scores is on the table now as a consideration.
Your point of that is a really good point, because what you're essentially saying is that now with PSMA scans, you can pick up the stuff that whispers, whereas with the other scans, we were picking up the stuff that already was shouting.
Yep.
And that changes the game, right? And so that's why you have all these patients. And I talked to all these other practitioners who have a whole bunch of oligometastatic disease patients. They got one little spot, they treat it. PSA goes undetectable for years. They don't have to take any other therapy but that type of treatment. That's a total game changer. Hey, those are 2 words I just made up. Game changer. It's not like that's not overused, but I think that's a really good point. Now I want to bring up another point.
Well, let's expand on that a little bit more, because I think that's the next. We've talked about these different scenarios. So the think about how revolutionary what you just said is. In the past, if we ever found a metastatic lesion, it was considered unorthodox to radiate it because there's so many spots. But some of us, myself being one of them, say, what do we got to lose? Let's radiate it. Let's give them hormones. Let's give them chemo. Maybe we can get rid of the smaller spots with all these other systemic therapies. That was the standard approach in my practice for 25 years. Yeah. And it helped some people. Now in 2024, with these PET scans picking up these early spots, our standard practice, I'm not saying universal practice, but our standard practice is, let's just radiate the spot and see if the PSA goes back to 0 on its own. Well, let's not mask it with hormone treatment. Let's find out if we hit the spot and if that's the only spot. If the PSA doesn't go all the way down, let's get another PET scan and see where this other offending spot, let's radiate that spot. The quality of life is so much better not having to take hormone treatment. And the durability of these responses you already alluded to, surprisingly good durability.
Yeah, I mean, shocking. When it hits, it hits. And sometimes they're just repeated and they can get a good, so
they used to call it whack-a-mole because the moles always kept coming. But we can't use that terminology anymore because in many, not all, but in many cases, they don't keep coming.
So we just went through a whole bunch of scenarios where MRI is great, but sometimes a PSMA's got to step in and tell you what's really going on, right? Now I'm going to reverse it on you, because I don't think this also gets enough attention, which also came up in the Q&A. And Raymond made me feel smart because he said that's a situation that comes up, but we always take care of it. God, it's amazing how many times you use the word PET MRI. I mean, as if it was one word, right? I mean, just PET MRI, just making sure you have access to both possible options. And so the other scenario is with all these PSMA scans, and the radio tracer is eliminated. And I had this on a sign. I can't find it because I got so many signs, I'm losing my mind. So with all these new PSMA tracers, these radio tracers, a lot of them get eliminated through the bladder. And then you see what's called a halo artifact. So the bladder lights up. So anything near the bladder can kind of be smudged out. In other words, something happening near the bladder, which the prostate's right there, there could be a lesion there or a cancer there that gets missed because of the glow of the PSMA. So every once in a while, and you should bring up a couple of these scenarios, there'll be nothing necessarily seen on the PSMA, but the PSA keeps going up. Then they do an MRI, and lo and behold, in the area where that glow occurred, this halo effect, they spot a lesion and they see where the disease actually is. So can you talk about that for a second? We first talked about how PSMA can complement MRI. Now, can you just mention how often in your practice MRI complements the PSMA?
Sure. What you're talking about, of course, where this comes up most frequently are the men who've had a previous operation, surgical removal of their prostate.
Yes.
PSA starts creeping up, and where is the cancer? And that's very common, not universal, of course, but the cancer can show up very close to where the prostate used to be and be obscured by the PSMA tracer that's being excreted through the urinary tract. I have to confess that I didn't come to our talk today as prepared as I should be, because I believe there's a new tracer out that isn't excreted through the urinary tract that addresses this issue. And we should find them and get them as a sponsor for our next meeting. But for the traditional, there's traditionally been two competing companies that do PSMA, and they both had issues with uptake near the bladder area.
Yes.
So this issue, of course, is important, and MRI can be a substitute. The difference between PSMA and MRI, which probably is apparent to most people, but so important for us to reemphasize, PSMA only lights up with prostate cancer, whereas if you talk about most scans, MRIs, CAT scans, bone scans, all these things, they light up because there's a shadow there, and the pattern of shadows can be interpreted fairly confidently to probably be cancer. But a PSMA PET scan essentially only lights up if it is prostate cancer, which is a powerful new realm for us in confidence. And that's why earlier in the talk, this conversation that we've had, we talked about substituting a PET scan for a biopsy, even, because that used to be the only way you could be 100% sure that it really was cancer.
Yeah.
So MRIs are more precise and give better resolution in the area of the prostate than a PET scan does. Although the PET scan gives you some disease-specific information, it doesn't give you the refined, fine detail that an MRI can offer. And so mixing them together, as you pointed out, PSMA MRIs in conjunction give you even more precision and confidence as to what you're looking at.
Yeah, we were talking about MRIs give a great look at seminal vesicle invasion, whether or not it's happened there, extraprostatic extension. So that clearly has its own little advantages. The PSMA companies right now are going after each other on who excretes less. So there's this is called hybrid PSMA. This Posluma says, well, we have less excretion through the bladder. The implication is, well, maybe there'll be less halo effect. So we'll have to see how that all plays out. Because again, sort of head-to-head trials with some of these companies don't happen as much. But it's something to ask about. It's something about the halo effects and the false positives and the false negatives and the catches of PSMA, which I thought we did a good job during Q&A going through with Raman. I mean, they're there, and as long as you know what they are, you have other options in case you're one of those ambiguous findings, right? We have second opinion readings that you mentioned. We got an MRI. You have an MRI as a backup. So if you're caught in one of these middle ground areas where people don't know, there's other places to turn. Great discussion. All right.
Let's give a shout out to our friends at the Mayo Clinic, Dr. Kwon. I love how he opened it up with that guy's got a way with words. Do-it-yourself combat manual. The idea of encouraging patients to take responsibility for understanding their situation. It happens commonly in the type of patients that listen to PCRI videos. They become very sophisticated, very knowledgeable, not that we're the only source, but they're out there doing their research, and they come to the doctor meeting prepared with some really profound and sensible, relevant questions, and they discover the doctor's sometimes even unaware of the technology they're talking about. And I want to take that as a good thing, because I don't think there's any other way to get state-of-the-art care these days. You have to do it yourself. To just rely on a general doctor. A urologist is treating kidney cancer, and he's treating testicular cancer, and he's treating bladder cancer, and he's going into the operating room and removing body parts. And then he's studying a little prostate cancer on the side. Your radiation therapist is treating breast, colon, lung, all these different complex diseases, and the information is exploding so quickly. People that you patients can become specialized enough to speak on an even level with these, even with the top doctors. And I think it's necessary, considering quality of life is such a prominent aspect of selecting treatment. Don't let someone tell you what your quality of life should be. You need to decide what your goals are.
Dr. Kwon always calls me in these random hours and goes, you know what, I hear about this, and that's fiction, and this is fact. And now that's how it all came together at the end. We started talking about, why don't you just answer some of this fact or fiction stuff? And so, you know, as a reminder, some of the things that we went through, and this kind of goes to what you were just saying. You know, if I ask my doctor for a second opinion, is he going to be offended in the medical team? You know, and that comes up a lot. And he said,
Yep.
yeah, you know, I deal with that a lot. So I don't know if you want to comment on that, or the idea that stage 4 cancer is a problem, when in some cases it might be something that can actually be handled. So I don't know.
Let's address the second one first.
Okay.
Because that was on my list to cover. I love how he formulated this for this idea of different types of stage 4. I think that is so important for patients to understand. Most cancers, because they have relative, you know, let's talk about pancreas cancers or lung cancers. When they're stage 4, there's things they can do now, thank God, that we didn't have 15 years ago. But it's only a minority of people that can really do well when they have stage 4. The majority of men with stage 4 prostate cancer do well. The majority. There are patients with what he called diffuse disease that are going to struggle more. But you can even have diffuse disease and do well. So this idea of stage 4 is like the end of the line is a terrible misrepresentation. And I love how he broke it down into focal, zonal, diffuse.
Yeah, that was good.
Kind of the same idea with the minnows and sharks, which was this dichotomy between, you know, the harmless and the consequential. And then Dr. Kwon's injection is even a little more detailed in the idea of 4 categories, even after you're advanced, even after you're proven to have metastatic disease.
Yeah. What did you think? Well, I don't know if you wanted to talk more about that. I think the other thing when we kind of got philosophical was on insurance company denials and not being scared to appeal. And so in talking with Alex and the team, it's going to be a priority to make patients stronger at appealing and giving some examples. And then I thought of the example, because there's a couple different types of appeal. There's appealing to the insurance company because they said no, right? That's one type of appeal. But actually, I do think you're a pretty good expert at a different type of appeal, which I want you to comment on. And we haven't, now to remind the audience, we don't discuss any of this beforehand. So I'm about to throw him, I don't think a curveball, but a softball. There's another type of appeal that people don't realize. There's a medication, and it's available if you ask for it with your doctor, but theoretically it's not available. I know this has happened with some immune therapies before we had certain types of testing. So can you talk about the second type of appeal to not insurance companies, but to pharmaceutical companies to get a drug that the patient thinks is not accessible at this point?
So you're talking about compassionate use programs, which are pretty common in these pharmaceutical companies that make these very expensive drugs that normal people would otherwise be way out of. You were talking about medicines that could cost $5,000 to $10,000 a month.
Yes.
And this comes up in in a situation where people undergo the somatic testing, and a DNA abnormality is detected that is commonly observed in another cancer type besides prostate cancer. So let's say it's a DNA abnormality or a mutation that occurs in lung cancer patients, for which there is a specific medicine approved. In prostate cancer, we have these PARP inhibitors for the BRCA mutation, and people have a high likelihood of responding well to PARP inhibitors if there is a BRCA mutation on somatic testing. So, but what if you do somatic testing and it shows some other mutation, just as common in lung cancer as BRCA is in prostate, and they're treating those lung cancer patients with a specific pill, just like we're treating BRCA and prostate cancer with a specific pill, so-called PARP inhibitors. And doesn't it make sense that that pill that's working in men with a certain mutation in lung cancer might not work in that prostate cancer patient who has that same mutation? Can that happen? Yes, it does happen, and it's picked up in people that have genetic testing.
Yeah.
So, so you say what the problem is that these pills can be very expensive, but it's an off-label application of the medication. The insurance companies say, nope, that's only for lung cancer. You can't get that covered. Approaching the manufacturer, the insurance company, the pharmaceutical company that is making the pill, commonly patients will get a free medicine from these pharmaceutical companies.
It's incredible. And people have to remember, when they get liquid biopsies from Scholz or other clinics, they should get a copy of it, because the companies have become so good. Garden 360, Foundation, they're so good now in their analysis, is that when you have a mutation, it will say within indication if you have it, and outside of indication. So if you have a prostate liquid biopsy, it will show you what drugs you might qualify in prostate cancer. And then outside of prostate cancer, off-label, it also gives that information in the report, and has for a very long time.
Yep.
I love it. Anything
Yep.
else you want to talk about? We only have 10 minutes left. Anything else you want to talk about?
There's some patient questions on Dr. Kwon. Let's see, he talked a little bit about, he called it follow-up. You know,
Yes.
I got to come up with a catchy phrase. So we'll use his follow-up. What I think he means by follow-up in patients that have metastatic disease is, let's say you're on Taxotere and your PSA is going down and everyone's rejoicing because these individuals often are resistant to all the hormone medicines, and it looks like a frightening prospect. And PSAs drop from 50 to 20 to 5 from Taxotere infusions, and everyone's rejoicing. But we all know that Taxotere can't be used indefinitely. And what is your backup plan? So when things are going well in men with metastatic disease that are taking systemic therapy as for hormone-resistant disease, an area that Dr. Kwon sees a lot of, these patients should always be formulating Plan B. You say, well, don't the doctors do that? They're busy. They tend to be reactionary, and PSA starts going up, and, well, this was working before. Let's try a little longer, maybe something good. When things start to change, they can change quickly. So this is a different mindset than our early stage patients, where we're saying, slow down, take your time. In men with hormone resistant, more advanced disease, that's the last that you never want to slow down, take your time. You want to be agile. And if it looks like, and of course, PET scans also can give you an earlier read. And this is something Dr. Kwon's been beating the drum on for a long time. Not only a uptick in PSA, but a progression on one of the scans. He does choline scans, PET scans, FDG scans, Axon PET scans. And to react to this information in a timely fashion is something that he wanted to emphasize. And I'd call it always having a backup plan in place, ready to go at the first sign that the cancer is starting to, let's say you've been on Taxotere and your PSA is coming down and it's starting to stabilize. The general feeling in the industry is, well, maybe give 1 or 2 more Taxotere treatments, hold it stable, but then move to something else. Don't just keep going internally. You can always come back to the Taxotere later, but why not try something fresh and continue to keep the enemy on the run? Or it's more like fighting a fire in these advanced patients, and just having a few burning embers is a lot better than a big flame.
Yeah.
But we all know how embers can turn around quickly and reestablish the flame quickly if we don't keep the pressure on.
Yeah, no, he has some really great points. Outside, I was kind of enjoyed the fact that he didn't have that many slides this time. It's just, let's go off script a little bit. Let's really figure out what's going on in that in the gray matter there. And it's interesting how he presents things. I'll tell you a thing that still rings true in my head from a few years ago. I mean, comment on it or not. We talk about these new PSMA scans. Or the ones, gallium got approved, Polarify, Posluma, you can pronounce it any way you want. But his argument is, look, first of all, just being able to have access to them is what I get excited about, not which one's necessarily better. I just want someone that's competent, that can read a scan, and whether it's choline or fluciclovine, Axumin, just having access to them is the point. It's not so much why are we arguing which one's better or worse. And it's those kind of little moments where he kind of shakes me out of my emotions, right? And I just love those moments. Anyway, I had to throw that in.
So Dr. Kwon has really built a name for himself in handling these men with hormone-resistant advanced disease, some of whom have been told there's no hope, nothing you can do. And then lo and behold, he has some ideas that really make a difference. And what are we talking about? We're talking about men that have had Taxotere chemotherapy, probably Jevtana, which is a cousin. They've had Pluvicto, and they may have benefited from these things for extended periods of time, but now their disease is progressing again. And some doctors are talking about switching Xtandi to Zytiga to Nubeqa with relatively low yield. Others are talking about giving high doses of testosterone, again, with kind of low yield and sometimes some danger associated with these things. The natural thing that comes up next is to knock on the door of academia and ask them, what is coming? Can you get me on a clinical trial of a new drug that is going to be the next big, the next big Pluvicto? And Dr. Moyad, you're in academia. You've been through this with many patients.
Yeah.
What do you think is the best way to navigate this difficult area where we know the academics have all kinds of trials and they need patients? They're not necessarily looking to match you to the best treatment. They're looking to match someone to their trial. And people can get sidetracked into medicines that may not be very likely to help. Have you got any advice for us in terms of how to take advantage of the new stuff without getting hurt?
I always kind of, if you want to get really philosophical here, I got to have a little sip of my green tea. It always makes me philosophical. Notice the advertisement. I always thought that life was about probability. What does that mean? I hang out with you guys because I like you. I'd rather hang out with a lot of you folks than other people. So the probability is if I hang out with you in the PCRI, I learned something, I can pass it on. When I got married, it was about probability. I was convinced that the person I would find, this would be a lifelong bond, and it has been. Probability also happens when it goes to the emergency room. The high probability gets the attention, right? We do what's called triage. We get more education if we want to, because probability says that's going to take us somewhere we couldn't have gone otherwise, for example, right? That's probability. We put on our seatbelts. Probability doesn't guarantee that I'll survive a car wreck, but you know what? It increases the chances I'll survive a car wreck. Why did we ever think that medicine would be different than probability? So when I think of clinical trials, or I think of medicine, what are the high probable clinical trials that looks like there might be success? So if you go down the line with all the drugs that you've been working with in your career, there was that gut instinct. There was, first of all, a phase 3 trial. This had reached the point where it was at the last trial. And now if this trial is positive, it's going to get FDA approved. So you want to look for trials that ideally not only fit you, but are in the last phases of testing. If they just pass this one other probable marker, then they will be FDA approved. Think about it going back to early 2000. That was the deal with Taxotere and chemotherapy. You were excited about it. Then there was a phase 3 trial, and lo and behold, it got FDA approved. Jevtana became that way. We were just talking off camera about abiraterone, Zytiga. There was always this thought, they're in a phase 3 trial. I'm feeling really good about the phase 1 and 2 data. I'm feeling very good about a patient signing up for a clinical trial that's phase 3 that has a high probability of winning. Before Pluvicto was approved, you were sending people to Germany and through around the world because you had such a good feeling that it was going to get approved. So there was high probability in your brain that there was going to be success with the agent. And that's the type of thinking that I wish more people would get involved with when they're picking a clinical trial. So now comes along actinium, and overseas you're seeing success even when Pluvicto is not working. It doesn't mean actinium is going to make it. It just means it's getting to the point where if it does one more trial here in a phase 3 success, it will be approved. So I think before people pick their clinical trial they're going to go into, they just got to think about the word probability. What is the highest likelihood in a phase 3 trial of being successful? And I'm always looking around for these kind of moments, right? So that's why actinium comes up really high. I just picked off a meeting from an article about cabozantinib. Remember that drug? We used to talk about it, plus Tecentriq, in immune therapy that's being used in a phase 3 for patients. Well, they're showing some activity there. So I don't want to belabor the point, but think about it like life. You want to pick, ideally, if you can, a phase 3 trial where a diverse group of people with knowledge are feeling really good that it's going to clear that hurdle for success. And that is a little nugget that has served me quite well when people say, what's a good clinical trial? I think too many people say, is there a clinical trial? That's not enough. The question should be, what's a high probability good clinical trial that I can join that has a great chance of getting FDA approval? And then you ask the particular questions of, it's always important to know about crossover. What's the other group going to get? And if this drug is showing success and I don't get it up front, can I cross over and get that drug? Which today, now, most of the time is yes. So a short, semi-long answer to a very important question. We could do an entire lecture series on it, but that's how I get excited. When I'm seeing the words phase 3, I know there's been success in phase 1 or 2. I'm hearing about people going to different clinics around the world because prostate cancer is now a global disease in terms of treatment and clinical trials. Many of our clinical trials are international. You're hearing about success, and then it's like going to Vegas and you're betting on a hand that has a high probability of winning versus just a hand just playing the game. So if I put a number on the roulette wheel, if I just pick 14, my chances of success are very low, right? If I end up putting chips on about 20 other different numbers, my chance of winning goes up because I'm increasing the probability of winning. And this applies to clinical trials. So please have that kind of discussion with your medical team and second opinions. And even looking at, I still tell patients to look at the ASCO annual meeting, for example, the big meeting in June. See what clinical trials are in phase 3, see what's showing success. And these are the kind of thoughts. I think people should take as much time before they enter a clinical trial into any other aspect of their life. They should do heavy, heavy analysis because there are millions of trials. But in my opinion, there's only a handful of them going on currently that may show enough success in the next 12 months that will give that drug FDA approval.
It's almost the same thing as the sharks and minnows.
Yes.
Remember, it was 15% of men catch prostate cancer and 15% of those have it spread. You're saying what we are dreading, the bad type of prostate cancer, thankfully, is far less common. And what you're saying is that the really good clinical trials, the one that you would put your dad on or your brother on, are much less common. So we have to be quite discerning because it's a big industry. And the doctors that are talking about these are quite charming and they really believe in the science and whatnot. But anytime you hear the word phase 1, or you're looking at something where it's a lot of speculation. Phase 2 is hopeful, but more speculation. And I'm not trying to say these trials are never to be used, but it's a much bigger gamble to be doing a phase 1 or phase 2 because the information just hasn't been researched with a great enough depth.
That's right. If you look at the 100-yard dash and you see someone right before they break the tape on a frozen photo, you feel pretty comfortable they're going to cross the finish line. If you see someone as a frozen photo halfway down the 100-yard dash at let's say the 50-yard line. I'm feeling pretty good they're going to make it to the 100, but I don't have proof. They're not that close. If I have someone that's just at the starting line, I don't know if they're going to get a false start. They're going to break their ankle. Something's going to go wrong. You can tell me nothing from that picture at the starting line of who's going to finish the race.
Yep.
So all I'm saying is what a phase 3 does is it shows you right before the finish line tape who the players are that may or may cross the finish line. It's showing you later in time. They've already gone the distance. Now they just got to go that little bit further to get approval. Those are the ones I get excited about. Those are the ones that I like to talk about. Those are the ones that I think are going to get FDA approval. And according to the system, that's the only way you get the FDA approval if you are toward the end of that finish line. So that's kind of what we're talking about today, right? And we can go through every FDA-approved drug in our careers, and I can't name that many surprises. Many of them were phase 3. The phase 1 and 2 look good. We were feeling really good about it. People forget, and you should probably mention this because we take it for granted. People forget that you were recommending PET CTs 4 years before they were FDA approved. And what were we all thinking? What's the matter with this guy? Has he lost it? He's recommending an imaging test 4 or 5 years before it's approved. He's telling people to go into a clinical trial and get the imaging done at UCLA because you had a darn good feeling from experience that this thing was toward the finish line and was going to break the tape. And so there were people in your practice and other practices getting these imaging tests 4 and 5 years before they were actually approved. That's the empowerment of a clinical trial. That's the empowerment.
Yeah. And I think that this is an essential type of analysis that patients who are maybe they've started on some Taxotere, maybe they just started on some Pluvicto, and we're very grateful that the majority of these men are going to benefit with declining PSAs, improving scans, but we know it's not going to hold the fort forever. And that means that it's time to get knowledgeable and conversant in this clinical trials world because there is stuff coming along. You mentioned actinium. We're pretty excited about that as a agent that can take someone who has had Pluvicto and maybe even progressed on Pluvicto and see meaningful responses that are durable. So I think that's a good example of this. And being sophisticated and wise on how to navigate this complex world, I think that's an excellent summary. Thank you so much.
No, I appreciate you bringing it up because let me just tell you, I'm in the preventive medicine world. This is so much easier outside of cancer. And the reason it's so much easier is a drug is tested in phase 3 against really difficult patients in the cardiovascular world. So you know what you're going to get excited about to take yourself. I remember when the cholesterol lowering, the statin drugs were just trying to make their way and just get approved. But they were working in people that had the worst type of cholesterol and lowering the risk of heart attacks in people with familial hypercholesterolemia. So I'm going, wait a second. If it's helping those people, I'm going to jump in that clinical trial. Look what's happening now with the newer drugs, these what's called PCSK9 inhibitors. They're injectable drugs that lower your cholesterol by 50%, and you can give yourself the injection. These are game changers. But what they were doing in phase 3 is they were taking the people with the worst cholesterols and reducing them dramatically and reducing the risk of heart attacks and other cardiovascular events and reducing the risk of needing a cardiovascular procedure like a bypass, right? Or an angioplasty. I'm going to bet on that drug. It's so easy in cardiovascular medicine. I wish we would apply that same kind of logic in cancer. Like I'm going to show you, I'm going to look at the track record. This is a high probability of success. So I just love it how it's done in cardiovascular medicine. I'm going to give you a classic example, what I bring up when I do a lecture. There's a drug called bempedoic acid, Nexletol. It doesn't work like a statin works, but it works on the cholesterol pathway at an earlier point. Well, it just got approved this week for primary prevention. So meaning that all these people who can't tolerate statin drugs, which is a fair number, it's not a huge number, it's a small minority, but that minority shouts, this becomes an option now, and the price should drop. Now, it comes with its own catches, but the drug itself is taken as a prodrug, and then it turns into the active drug through liver metabolism, but it doesn't go into the muscle tissue and cause those same kind of issues. So for some people, this turns out to be a huge winner. Well, this was first tested in much higher risk patients. So you get more comfortable with it that eventually it's going to find itself out there. I'm not going to mention the fact that this has nothing to do with Michigan, but it's an Ann Arbor company. I have no involvement with the company. It's just a great story of people wanted to find an alternative pill to a cholesterol statin drug that people could take if they couldn't tolerate the statin. That's a beautiful example of how to look at it. Remember, you and I have had all these people watch us about Wegovy, and remember all these GLP-1 drugs, Zepbound, and weight loss, and helping people lose 10, 15, 20% of their body weight. And now it's all the talk, and everybody knows what these drugs are. And we did a video maybe a year and a half ago that everybody in the world has seen. And we said, wow, these are exciting drugs. I think they're going to last. Do you have any comment on that before I comment? Because they're still helping a lot of people, and they still look really good. And what changed this week is Medicare now says, you know what? For some people who are high risk for a cardiovascular event, we may cover it. So they've gone from, these insurance companies have gone from, I don't think so. Now it's showing a benefit for people that have had a cardiovascular event to reduce a second event from a trial called SELECT by 20%. And now the companies are going, well, wait a second here. And all this has been happening this week, which is kind of cool. Any comment about these drugs? You still excited?
Oh, well, it certainly changed my life. There were two things in a busy clinician's life. I'm seeing, a large number of patients every day. And your physician, if you're smoking, you should be, your physician should talk to you about that. If you're overweight, your physician should talk to you about that. But historically, these things have been psychologically so difficult to impact that we just jump past them and talk about things we think we might be able to change. Well, ever since the Ozempic and Wegovy and these new medicines came out, it's almost routine to talk to people who are overweight about the possibility of addressing this successfully with medications. Yeah. And it's a very exciting thing. And it's so revolutionary. I would say at this point now in early 2024, it's becoming routine for us to talk about this, which is it was mind-boggling before that we would broach the topic of weight loss with a patient, because historically all you did was make people feel guilty. There were motivational people who devoted their whole lives to diet that could make an impact on these people and help them hold their hand through weight loss programs. Very, very difficult. I'm not an expert in that. I didn't have the resources and the time to do that. But now, with the possibility of just initiating an effective pharmaceutical and changing people's lives, I feel obligated to talk to all of my patients who are significantly overweight.
Good for you. One of my favorite comments, and it is good. I'm so glad we talked about it. My favorite comments in the PCRI later that I hear about in the conference is they say, boy, as a moderator, we can't tell what side you're on. You really seem to come at it from both sides. And I say, well, that's my job. So my job now is to tell you after a few years what the downside of these drugs have been so far that we've learned. And it's very interesting because I didn't know I would have this kind of list to work with. So let me tell you the Moyad 5 catches, which goes also into my area, lifestyle. And I think these are catches you can work with now when doing Wegovy and Zepbound. And let me remind people that it's going to be in the next year or two, they're going to have an oral agent that's probably going to work almost as well as the injectable. So for some people want to take the oral agent. But here come the catches. Compliance has turned out to be a catch. In some of these new studies, they did a huge one of insurance records recently. They found out that up to 2/3 of patients in some areas of the country after a year said, nope, I'm done. Now, why were they done? It could have been cost, because we know cost is a clear catch. That's an understatement. I always said to you in our talks, it's an embarrassment how much these cost. So compliance has to be discussed up front. Non-responders, now we're learning that there's a small fraction of people who take the medication at various doses and they just don't get the hit that the majority get. And so it may mean switching to another one. Who knows what it means, but it's something that's going to have to be tackled. The biggest surprise, I think, for me thus far is number 4, anesthesia. Now the anesthesiologists are saying at least a week before an elective procedure or some type of procedure, you need to stop it, because if food is still in your gastric area, and you could regurgitate that during a surgery or during some type of procedure, an endoscopy, for example. That food could go down the windpipe, and then you could have a real problem. You're going to develop a type of pneumonia, an infection. So you have to always check with the anesthesiologist before any procedure, especially any type of surgical procedure, any elective procedure. Hey, when do you want me to stop this drug before I receive anesthesia? Number 5 has surprised me because it's in my category. And I'll tell you why it surprised me. People think somehow this is magic and lifestyle doesn't matter anymore. The biggest success on these drugs have been people who maintain somewhat of a healthy diet, lower calorie diet, and are still physically active. They're the ones who in general in the clinical trials have seen the biggest effects. So I just published a paper last year in a medical journal that got some attention. And I said, look, lifestyle matters more than ever before with these drugs because it complements the drug itself. And another way it complements is that any diet you're on, or when you lose a lot of weight, you also lose a lot of muscle mass. So in the clinical trials of most diets where people lose 10 to 20% of their weight, anywhere from 20 to 40% of that will actually be muscle tissue. So now the push is that not only to get an adequate amount of protein in your diet, but you have to do this with resistance activity so that actually what you're losing is more fat than muscle. So there are lifestyle tips around these medications. It's the same thing with androgen deprivation therapy. Look, I love androgen deprivation therapy because it's been around for 35 years for a reason. It's changed lives, but we also have to admit it can change your quality of life unless you head it off at the pass. And in order for a person to stay on these drugs and be compliant, you don't want them to be dealing with a ton of side effects. You want to prevent side effects. So one complaint that happens with androgen deprivation therapy is, look at me, essentially I've gained some fat and I seem to have lost my muscle mass. And we have to remind people, just like with Wegovy and these weight loss drugs, the way to maintain your muscle mass when you're on any of these medications is resistance exercise twice a week. In some clinical trials is enough. Other clinical trials, it's 3 times a week. The point is you're doing upper and lower body weightlifting type exercises 2 or 3 times a week for a very small period of time, which can help combat that muscle loss. Because think about it, Mark Scholz, if I'm going to lose 20 pounds, I want 15 to 18 of those pounds to be fat. I don't want it to be muscle, right? And that is a point that has to be getting out there more to patients on these weight loss drugs. And that has to get out more and people on androgen deprivation therapy because this is a massive problem, muscle loss. So I'll get off my high horse. I just wanted to mention that. I don't know if you have any other comments. I want to also bring up another piece of news from last time to make myself feel good. Are you ready for this?
I'm ready.
Okay, I just had to review this for the doctors. This was one of the largest meta-analyses of randomized controlled trials just published in the British Medical Journal 2024. They looked at 218 unique studies, over 14,000 participants. Now remember, this is randomized trials of exercise, all right? And here's what they have found. Effects appeared proportional to the intensity of exercise prescribed, which means the more you bet on yourself and the more you exercise and the greater the intensity, the bigger the payoff mentally. And we're stronger for group exercise. So socialized exercise was stronger than isolated exercise. Anyway, here it is. These forms of exercise can now be considered alongside psychotherapy and antidepressants as core treatments for depression. In other words, when they graphed the effect of exercise in randomized clinical trials, it was as good as getting therapy and some medications. Now, of course, I'm not saying you should skip your medications and skip your therapy. I'm just saying anyone that's taking an antidepressant or is in therapy that's not exercising, that's a problem. That's a problem because if you look at this new data, it complements conventional therapy so much that it could be the difference between a response to an antidepressive agent or not. That's how profound it is now from an analysis of clinical trials. Unbelievable. Anyway, sorry. I don't know if you wanted me to say anything.
It's funny that the invisible underlying mood that we face the world with is it's construed as not being a health problem. It's a mental problem. And what you're saying is that there are actual activities that can change that, just as there are other activities and treatment that we can treat prostate cancer with. And
That's right.
That is, of course, a challenging one, but there are ways to make it a little less challenging. You mentioned getting involved with a group, having some sort of accountability, getting some sort of supervision. These sorts of things that allow us to measure whether we're actually following through, because it's so easy for us to fool ourselves and to compromise, and there is a momentum factor to this whole thing as well. The starting up part is always 10 times harder than the sustaining part.
Yeah.
And so if people are able to get on a roll, they have to really value the fact that they're on that roll and that it's precious. If you go on a 2-week vacation somewhere and take a holiday from exercising, I've had so many patients that will take a 2-year holiday from exercising because they can't get back to it when they return from their trip. So the defending the success that people already have is just as important as it is for those that aren't doing it to get started.
So if this doesn't motivate you to exercise, nothing else will. This just shows you that every animal loves exercise. Every type of person loves exercise after they conduct the exercise. You always feel the best after a workout. You never regret a workout after it's done because you feel so darn good with the endorphin release. So I thought I would give you a surprise one here toward the end of the conference. He's going to show you everybody benefits from exercise. And this is on the beaches of Lake Michigan with my dog. And I'm going to show you what I mean here in a second. Okay, here's Olympic training with my dog on the beaches of Lake Michigan. Here he comes. You got to look carefully. You see the little dot? Here he goes. Here he goes. Here he goes, baby boy. He's a front runner, baby boy. Baby boy's the front runner, and baby boy's gonna win. Good boy, good boy, good boy, good boy, good boy. If I have a comment on it, you can't see a happier dog running a 200-yard sprint like that. I mean, it makes my dog happy. Everybody's happy. And I'm going to leave you with one more thing in exercise because you know this is my mantra. This is where I like to hang out. Last year when we did Q&A, I brought up the idea of this erase trial. It was done in Edmonton. And it was a randomized trial of active surveillance patients. And everybody got so excited about its first publication because it showed that men became more fit over 12 weeks doing an exercise protocol versus not. All right. It even showed some PSA changes that were favorable for active surveillance. And people got excited. And I just kept saying, wait till the real good stuff comes out. And it did in 2022 in the Journal of Urology, the erase randomized trial. Here's the conclusion of what they found in these patients who got together a couple times a week for 12 weeks versus a control group. A 12-week supervised high-intensity interval training program appeared to improve prostate cancer-specific anxiety, fear of cancer progression, hormone-type symptoms, stress, fatigue, these are all significant, by the way, and self-esteem in men with prostate cancer on active surveillance, published in the Journal of Urology. If that was a pill, everybody would lose their minds. They would be so excited about taking that pill. This was just exercise in prostate cancer patients and all the profound mental health benefits. I rest my case when it comes to that.
Thank you, Mark.
Can I tell you one more thing? Can I tell you one more thing? This comes near and dear to my heart. I hear these words probably more than you do from friends. I hear it from family. I hear it from people I've just dealt with through the years. And I just want to respond to this. And you had no idea I was going to bring this up. And when it comes to lifestyle, and this is the part that gets a little bit of a hit, and I want to respond to it. I often hear, whether it's in breast cancer, colon, it doesn't matter the situation. I often hear this quotation. I did all of these things you tell me to do, all of these healthy things, and I still got cancer, and I still got a bad cancer. I always hear that. And I always give the same answer. And this is the quote that I give because I believe it. I've been doing this since 1999 in medical journals saying this is what I'm seeing in the data. Yes, I say, but I think it was delayed or actually less aggressive because of your lifestyle. See, a lot of people take care of themselves. They do everything I want them to do, and still something bad happens. And they immediately defer to, well, this didn't matter. And I'm going, that's not what we're seeing in the data. What we're seeing is you delayed a very bad diagnosis, you reduced the aggressiveness or if it hasn't progressed as far, had you otherwise just sat on a log and done nothing. So what we're seeing in the lifestyle data, and maybe it's just reducing the risk of cardiovascular events while you're going through prostate cancer therapy. What we're seeing still is a major payoff in the area of taking care of yourself. And rather than going to the cup is half empty, I truly believe that what we're seeing in the data is the cup is actually 95% full, that had you not taken care of yourself in this manner, the situation could be actually much worse than what you have it, even though I know you have a bad situation. I think that just has to be stressed more because we're seeing this in data. This week, I'm reviewing a paper of bad genetics. We call it lethal prostate cancer. So in these studies, they have all these people that died of lethal prostate cancer. They're going back now and they're looking at diet, they're looking at lifestyle, and they're finding that some of the heart healthiest people for 5, 10, 15 years up before their diagnosis, when they've continued to follow them, tended to have a higher probability of surviving prostate cancer. So the payoff, they're not being told what the potential payoff was for putting that investment in. Instead, they're being told, well, you did all this exercise, you took care of yourself, and stuff still happens. And I'm going, no, but you got to pat yourself on the back because maybe this happened to you at 62 and it was going to happen to you at 38 instead. And that's what we're seeing in the genetics. And that's what I think should be sold more with lifestyle, that it's paying off in some category that we have to just look at it a different way based on the statistics that we're looking at it at. So I had to throw that in because I just hear this quote a lot. I understand the quote, but I also understand the data that you can benefit in a multitude of ways, but that has to be mentioned to you where you're benefiting. Look, I just throw this out to you. Look at all the people going through chemo, androgen deprivation therapy, abiraterone, all these things that could potentially, they have to be on them, and these are life-saving drugs, but they have to be on them. But if they're not taking care of themselves, the quality of life is so much worse. I have to have you comment on that one more time, that so many people call me and go, well, I heard you have this side effect, that side effect, this one. And I go, well, are we talking about the person who takes care of themselves? Or are we talking about the person who does not? Because there's a huge difference. So Dr. Scholz, will you please comment on the person who goes through all these advanced therapies and takes care of themselves better versus ones that don't think it's as important?
Yeah, I think when people are getting more informed now, they go online and they hear some of the horror stories about taking Lupron and having low testosterone, and they find it quite daunting. And it is a powerful treatment, and removing testosterone or even taking chemotherapy has to be respected for its potential side effects, there's no doubt. But I can't tell you how many times I've had patients who listen to my admonition. In our practice, we take out a little contract that they have to exercise 3 times a day with weights. And although very few patients have been willing to do that, they do get an idea that I'm serious when I put the fear of God in them, that if they're not exercising, they're going to be miserable while they're on the treatment. And if they will comply with this protocol and be diligent and consistent, that they're going to feel relatively normal. And the patients come back after being in the midst of this, who actually have been taking this, and often will tell me that this has been nowhere near as concerning as I thought it was, because many of these patients have done a lot of research in advance to find, and are quite intimidated by the prospect of having loss of testosterone or taking a chemotherapy medicine. And it is like night and day. Before we discovered this, maybe 15 years ago, we would counsel patients because we believe in full upfront disclosure. We told our patients, and we didn't know that exercise could help back then, and we would tell them, we're really sorry, we have to give you this life-saving treatment, and it's going to make you feel like a limp dish rag. You're going to just really struggle, and it's going to be very unpleasant, but it will prolong your life. Therefore, we are advising that you proceed with therapy. And that was just being honest, full disclosure as to what they're getting into. And of course, the patients that embark upon treatment in 2024 and don't follow through with their exercise do indeed feel that way. It is like night and day. So glad you've emphasized that. It is one of the, I won't say one, it is the most important thing that we counsel people about when we're confronting someone that comes in with more advanced disease and is going to be embarking upon testosterone deprivation.
I went to a prostate meeting. It was a small gathering of experts, whatever that means. It's a big ego term, but I think we all just call ourselves experts for the heck of it. And someone gave a talk on androgen deprivation side effects, all the possible side effects that you could experience from androgen deprivation therapy. So they listed them all there. And then they talked about all the solutions, right? All the solutions. And then clap, clap, clap. And I said, Moyad, don't get too wacky here. Don't get emotional. You generally just stay your ground. Don't show your position. I said, just be careful here. And I couldn't hold my mouth. I got up to the microphone and I said, bring that slide back up. I said, you've just mentioned 8 to 10 potential side effects. I said, what's the only intervention on there that you have listed of all the interventions that cover basically 99% of those side effects? Maybe not hot flashes, we're not so sure, but almost every single other one. I said, it's exercise. Exercise covers the majority of the side effects that you're talking about with pharmaceutical medications, and those are helpful. But don't you find it interesting that what covers almost every single one of those side effects that can help mitigate those somewhat, from cognitive, right, to possibly even bone loss, muscle loss, all of those, exercise is one of the solutions. So why am I not seeing a pharmaceutical commercial that says exercise for ADT? You don't see that.
It's not the pharmaceutical, it's the physicians. Earlier today,
yes,
we talked about how my behavior changed when talking to patients about weight loss or stopping smoking. And to this day, I don't berate people about stopping smoking, although we have things like Wellbutrin that can help. But my whole approach changed when things like Ozempic and Wegovy came out, where we could have an intervention that's going to make a real difference without having to undergo a giant psychological shift, which is a very time-consuming and difficult prospect. And this is the way most physicians see talking to their patients about exercise. You and I have crossed over to the other side because we realize it's a non-negotiable. Right. If these patients don't exercise, they're going to be in serious danger. And therefore, we are ethically obligated. I don't think most of the medical world or the physicians out there understand how dramatically powerful fitness is in patients who are going through androgen deprivation or radiation or chemotherapy. It makes a giant difference and has been well established in clinical trials. But I don't think it's just come home to the day-to-day practitioners on the front lines who are so busy and they have to know how to give different complex medicines. And the idea of figuring out a style, a communication style that's going to take some time out of their day with these patients to motivate them to change their lifestyle. It's if I hadn't lived with the misery of hormone-deprived patients for probably a decade before we figured out and it sort of surfaced in the field that this is an amazing breakthrough. Fitness compensates for the deleterious effects of testosterone deprivation.
Yeah, and I want to remind people that we are cars. I'll say it again, we're cars, and with rechargeable batteries. When we sleep, it gets recharged, right? And so we're driving around, and when you hit 50, 60, 70, if you have a car in your garage that's 50, 60, 70, it's no longer called a car, it's called an antique. That's fine. We're getting older, we're rusting, right? And the idea is you have to realize that as we get older and things rust and more things can go wrong, we have to start taking care of that car more and more. So even not just on androgen deprivation, people don't realize that once you hit 40 and 50, there's a actual metabolic physiologic change where the human body just gets older. It's not capable of doing what it used to do. So what happens is adipose tissue begins to infiltrate. It begins to infiltrate bone marrow. It begins to go into pericardial tissue like the heart. It begins to go into the muscle. And unless you subscribe to the use it or lose it phenomenon, it will continue to do that. So they say by the time you hit 70, if you don't do much, you lose 40 to 50% of muscle mass. That's true, because once you go into entropy where you're not doing something, then the machinery, the car, starts to fall apart. So even for anybody who's not undergoing all these drugs, it could be someone who's just doing perfectly fine. The body begins to age and it starts to accelerate unless you do something that's anti-aging. And unfortunately, the anti-aging phenomenon has been sold as a lot of these different elixirs, when in reality, it's about using it or lose it. It's about aerobic activity being combined with resistance activity. And then that should become mandatory. And so what we're reviewing now are papers of people in their 80s and 60s who are now doing resistance activity with aerobic activity 3 times a week. And what's stunning is how quickly they're able to gain more strength, balance, coordination, and muscle mass, and how they become so much more mentally and heart healthy. It's stunning. What's also stunning in these clinical trials is how at the ages of 60, 70, 80, 90, when you take a couple weeks off, boom, the body loves to go back toward being filled with adipose tissue, and physiologically you run into trouble. So taking too much time off becomes far more risky with aging than it did when you were 21, of course, right? And these kind of things have to be taught. I'm going to leave you on this topic with a big ego boost, so you're not going to get your head out the back door. I can't tell you, and I shouldn't even admit this, I can't tell you how many times I've gotten somebody in person or on the phone, and they say, well, I'm doing all this, and I just love my exercise routine, and I'm doing much better with chemo, and I'm doing much better, for example, with hormone therapy. I mean, everything is just a lot better, and oh my gosh. And I'm sitting back going, yeah, it's okay. You don't have to buy me a car. I know what I preach. And they go, you know what did it? And I'll go, no, what did it? And I'm going, here it comes. The love for Mark Moyad. They're going, I was watching a video, for example, and Alex and Dr. Scholz were on it, and they were talking about exercise. And I thought to myself, well, there's an oncologist who sees only prostate cancer. So if he prescribes exercise, I'm definitely in. That was a life changer. And I'm going, wait a second, it wasn't me. Well, take your ego out of it, Moyad. And I'm going, that's your point. Your point is when someone is day to day in the trenches and says, this makes a difference, it screams to the patients. It screams. I can't tell you how many times in the past several years someone told me that when Scholz emphasized it on a video, I was convinced he must be seeing something because he just sees prostate cancer. And I go,
well, this has been shown in studies too. I don't know if it's motivating for our fellow physicians, but the studies, and you probably know the literature, show that if, I was talking about being intimidated by the time and my lack of skill, say, in talking with someone about ceasing tobacco use, and that we'll just live with this. And but studies, the limited number that I've reviewed, show that physicians can have a big impact in motivating people to change their behavior, even with tobacco abuse, which is so addicting.
yeah.
So thank you for that kind comment. And I want to take just a second too, Mark, to thank you for making another one of these conferences just a delightful success. Thank you for the speakers that you bring to the table and drawing the best out of them, and for helping this information get into a digestible form for our patients, who's really our audience. I know that there are physicians and other caregivers that pursue prostate cancer and men's health understanding through the PCRI, but it's primarily the patients, the ones that Dr. Kwon says that are the do-it-yourself patients that are looking for their own combat manual. So I just so appreciate that you've carried us through this again. I know it's been a lot of hours and a lot of preparation, but thank you.
I appreciate it. Of course, you know how much I appreciate you and the whole team out there. And people always say to me, do you watch the videos? I told Alex this morning. I said, I don't watch the videos after they're done, because it's like telling someone who prepares all their life for a Super Bowl. And, I just want to be ready for the Super Bowl. And then after the Super Bowl is done, I've had it with the Super Bowl, because there's so much prep that goes on in here. But the one comment, the one place I appreciate is that people always ask me too, well, why don't we talk even more about diet and lifestyle? So finally I decided, when we sat down with Alex and the team, we said, we're going to create a series of diet videos and release them every couple weeks. And it's going to start in April and May, that my wife and I did, because my wife's such a great cook and she has great nutrition knowledge too. And we're just going to cover topics in the area of lifestyle, not to try to sell you a specific lifestyle or a specific diet. What makes me half wacky is when people say, this is the only diet you can do. This is the only thing that has data. And we know that that's not true. Lots of different methods have data. So what we've already done is put 5 in the hopper, and we're going to do another 5. So over the next 6 months, every few weeks, you're going to see a release on a certain topic. So we're going to talk about omega-3s and salmon and fish in the first topic, and not only how to prepare it, but how to look at it nutritionally, and also how to look at it from a medical standpoint. And they're not there to say, this is what you have to do. It's just to do and give you a foundation of what's going on in the lifestyle world. So for those of you who leave this conference going, Moya didn't talk enough about lifestyle, he didn't talk enough about multivitamins and all these other things, we are going to cover that over the next few weeks, and we're going to make sure that gets its due, because we've had so many requests. And I promise you, by the end of this year, you're going to go, I'm sick of him talking about it. So I want to thank...
It's an unmet need. And I think the idea of providing professional state-of-the-art information without an underlying agenda, who gets motivated to do these sorts of things is someone's got a new pill or a new angle, and so they hire a charismatic guy like you to be their spokesperson, and there's this agenda that's undergirding these things, and you've been in this realm and have no affiliations with any of these companies, and can just bring your experience and your delightful persona and communication style to motivate us, because it's not only knowing what to do, it's being able to follow through and actually make the lifestyle changes that lead to these benefits. And the last thing I want to say is that you've got that common sense that you're not going to waste our time with stuff that has some technical, theoretical benefit in rats from 13 years ago. Practical, down-to-earth stuff that is something that you would do in your own life, that is what you feel is justifiable and beneficial, because there's cost or there's inconvenience that is associated with these lifestyle changes.
That's so true. And I appreciate that, because people still ask me, I get hounded by a lot of nutrition companies, supplement companies, come on, we'll pay you X. And I'm thinking, that's okay. Maybe earlier in my career, when I had to do it, people always step over the boundary in some way, but I'm just going to tell you what I believe now, which is, lifestyle changes change lives. That's become my mantra. Doesn't mean that you shouldn't embrace conventional medicine. I'll just give you a classic example. Alex showed me a bunch of questions for this meeting, and it's the same. We got a number of questions, for example, can I have an egg? It's a painful question for me to read. It's a painful question, because life is meant to be enjoyed. We can go into the environmental and all that stuff, but the question in and of itself, can I eat an egg? Is that okay? Well, we take people through the education. It may have a little more cholesterol, but it also has vitamin D. It also has these 2 carotenoids called lutein and zeaxanthin, which are good for your eyes, for example. And it tends to be low calorie overall, and the egg white is a decent source of protein. So can you have it? Well, yes, you can have it, but it also means that subjectively, if that's something you enjoy and that makes you happy, great. But you also want to combine any dietary change or what you think might be a sin with something that's objective. I find it interesting that in all of medicine, we use PSA, PSMAs. We talked about MRI. We talk about all these ways to gauge success, but we don't do this enough with diet. So the truth of the matter is, if you know all your basic numbers, you know your cholesterol, you know your blood sugar, you know your blood pressure, you know all the numbers that matter, your weight. If you're having a bunch of eggs during the week and then you go up for your follow-up exam and your cholesterol is suddenly through the roof, there's an indication, an objective parameter that maybe you need to dial it back. But there are plenty of people that have several a week and their cholesterol won't even budge. Part of this is based on genetics. And that's why I love the genetics talk, because we all have these polygenomic situations where some people, for example, are fast metabolizers of caffeine. Some are slow metabolizers. We're going to learn more about cholesterol. Some people can eat 5 eggs during the week and their cholesterol doesn't budge. Some people eat 2 or 3 and their cholesterol takes off. By working with your doctor and knowing your numbers, the answer to whether or not you can have several eggs during the week will come up and be answered for you individually. That's the point. But to look at the question as an all or nothing event is what the fallacy is. And I don't blame the patients. I blame the experts for telling people, oh my gosh, if you touch that one food once or twice a week, you're going to HE double toothpicks. It's not that simple. I wish it was that simple. It was that black and white. It's not. So for those of you people who love eggs, I'm not going to go into the environmental part. I'm just talking about straight. If you want to eat an egg and you're worried about it in terms of your heart and your prostate cancer, this is why you work with your physician to know your numbers. Plenty of you, including on cholesterol-lowering medications, will never see a change in your cholesterol. Some of you, and unfortunately, will see a change and will then know you have to dial it back. It's the same thing with sodium. Do you know how mad it makes me that my two brothers can eat as much sodium as possible and their blood pressure doesn't change? If I go over the recommended daily allowance of sodium, if I even go to 3,000 milligrams a day, my blood pressure shoots up. I get in trouble. I am clearly working with my doctor, one of those salt-sensitive individuals. So my sodium requirements are much less than the average person, but it's just what I was born with. That's the way it is. So what we're going to do in this diet series is we're going to give you the data and how to look at it in a way where you can individualize it. Does this work for me? Does this kind of food work for me? Because one thing that's mentioned is this compound of cell membranes. It's called choline. So, you know, in Mayo Clinic, they have that choline, right? PET CT. And some people are scared to get choline. But we forget choline's not just found in dairy and fish and meat. It's also found in cruciferous vegetables. I want you to eat your cruciferous vegetables. Of course I do. So again, our series is not about telling you have to do something. It's giving you the tools whereby you can decide whether or not individually that works for you or not. And that's the essence of my teaching. And that
I think this is going to appeal to our the same folks that Dr. Kwon is appealing to and trying to encourage them to take responsibility and understand if the metabolism of these complex bodies that God has given us was that easy to understand, this would have all been worked out a long time ago.
That's right.
We'll certainly look forward to that. And thank you so much again for making this happen, Mark. We really, really appreciate it. And I want to mention as we close the our going back to actually meeting in person in September, the second weekend of September. This is a event that has been a storied centerpiece of the PCRI for almost 2 decades.
Yes.
And so we're looking forward to that happening at the Marriott Hotel in in the second weekend of September. And Dr. Moyad will be moderating, and we'll have a lineup of wonderful speakers. So thanks again, Mark, and hope you have a wonderful, wonderful Easter.
I can't wait to see you in the fall. We're going to be in person. Now realize Michigan is national champions for 1 year. So do you think I'm going to make everybody nauseous around me by wearing all this gear at the conference? Of course I am. And just remember, had you gotten those 2 quiz questions right at the very beginning, you would have had dinner for free for life from me. But at least now you know the answer to the question. Who was the national champions this year? Michigan. Who did they beat? The University of Washington. I am now converting one of my best friends of all time, Dr. Mark Scholz, into a Michigan fan. Thank you, my friend. I can't wait to see you soon.
All right. Thanks again, Mark.
Thank you.
I want to thank each of you for watching this conference. We really appreciate that you came out and you supported us. We hope this information was helpful for you, and it is an honor to do it. So first of all, I'd like to thank our moderator, Dr. Mark Moyad, and our speakers, Dr. Scholz, Dr. Helfand, Dr. Kwon, and Dr. Raman. The information that they presented is crucial, and it helps us stay up to date, so I'd like to thank them all for volunteering their time. Also, I'd like to thank our sponsors, Bayer, Pfizer, Janssen, and Dendreon. I would really encourage you to go ahead and check out PCRI.org and check out the exhibit hall, because they provide information not just on what they do as a company, but also supportive resources, whether that be financial or educational. It's really great information, and there's a lot there, so go ahead and check it out. And if it wasn't for them, we really wouldn't be able to do this completely free. So again, it's a great way to appreciate them. I would also like to thank my PCRI team, because if it wasn't for them, none of this would be possible. Whether you're in admin or AV or in editing or graphic design or your helpline, I really appreciate you. It is because of them that we are able to present this conference to you, and they do such an incredible job. So I truly, truly appreciate them, because none of this would happen without them. Now, please remember, on September 7th and 8th, 2024, this year, we are coming back and doing a big in-person conference at the Los Angeles Airport Marriott. I am so excited. We haven't done a conference like this since 2019, but it is an amazing event because you get to have multiple opinions in one 2-day span. You meet support group leaders, advocacy leaders, other prostate cancer patients who are in your particular stage of cancer. And it is so helpful because you can hear other people's experiences, get your questions answered, and talk to world-renowned physicians. It's an awesome event. I hope to see you there. You can sign up at pcri.org/2024-conference. Now, please subscribe to our YouTube channel to stay updated on more content just like this. If you have questions, you can call our helpline and we will be happy to answer and give you information. I hope to see you at our conference in September, and please remember, most of all, you're not alone.
Grazie. PCRI Spring Conference was amazing, wasn't it? It was amazing. Don't turn your head like you don't know. It was amazing. You know it, I know it. See you next time. Thanks for watching.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.